Ma'am, we are good to go.
Just display the CV slide. Good morning, all. It's my pleasure to welcome Dr. Madhulika Mahashabdeva for chairing this session, which is on obesity medicine and type 2 diabetes remission, a primary care perspective. Dr. Madhulika Mahashabdeva is a MD Medicine, professor and head of the unit at Dr. D.Y. Patil Medical College Hospital and Research Center. Worked as consulting physician at Sahyadri Super Speciality Hospital, Covey Road, Pune. Undergone certificate course of diabetes from MP Hospital, Chennai, in collaboration with WHO. Advanced certificate course in thyroid disorder. Has many national publications and posters on her name. Has keen interest in diabetes and thyroid disorders. I'd like to, Ma'am, would you like to introduce Dr. Manjul Patwardhan for this session?
Good morning.
Over to you, ma'am.
Thank you. Good morning, all. So we are starting this session with a very important topic of obesity medicine, type 2 diabetes remission, a primary care perspective. And to speak on this topic, we have an eminent speaker, Dr. Manjul Patwardhan. Dr. Manjul is a board certified obesity specialist from American Board of Pediatric Medicine. She is MD Family Medicine from University of Illinois, Chicago. She has an experience of 25 years of practice in Bay Area, California. She is MD Obstetrics and Gynecology from India and has a meritorious career throughout in medical college. She's a winner of 12 gold medals in her undergrad and postgraduate days, and she is a awardee of prestigious C.S. Dunn Award during her residency. I know Dr. Manjul since last 55 years, and it's my privilege and honor to invite Dr. Manjul to speak on this important topic. Over to Dr. Manjul.
Thank you and welcome everyone. I'm so excited to be here today. Obesity management is my passion, and that's what I love to do day in and day out in my practice. Thanks, Dr. Unikrishnan, for asking me to speak today. And thanks to my sister, Dr. Madhulika Mahashabde, for introducing me to this wonderful group. This slide shows prevalence of obesity and diagnosed diabetes in US adults from 1994 to 2015. And clearly you can see how obesity and diabetes have increased hand in hand. This is true not only in the US, but also in other parts of the world. So today we will talk about obesity medicine and the type 2 diabetes remission. The last 2 days, you have heard a lot about obesity as well as diabetes management from various speakers. So I invite you to look at your patients who are coming for diabetes treatment through the lens of obesity. So let's talk about diabetes management through lens of obesity. So today I'm going to start with a storyline. After doing my 2 MDs, one from India and one from USA, I started private practice in Cupertino, Bay Area in Silicon Valley, California. It's surrounded by many high-tech companies. Closest to my office is Apple, walking distance from my office. So who were my patients? My patients were well-educated, goal-oriented software engineer, constituted about 80% of the patient population. So what did I see myself treating? Over and over, every day, patients coming with hypertension, high blood sugar, high triglycerides, low HDL, fatty liver, basically metabolic tree branches of this slide. So I realized, in fact, I am seeing the whole spectrum of insulin resistance, starting from young women with polycystic ovarian disease, having hard time getting pregnant, to conditions meeting criteria of the metabolic syndrome, to overt type 2 diabetes. So what did I advise these people? I asked them that how important weight loss is, and asked them to work on nutrition, exercise, lose weight, and I would ask them to come back. But the frustration came in when the patients would come back and there's no weight loss. They would be frustrated, and me too. So in 2006, I decided to get myself a tool to manage this problem. I got board certified in obesity medicine. So now I am weight loss MD. And what I really been successful in my private practice is to help patients lose 8 to 10% of the body weight, because I know, and I assure them too, that achieving even that small 10% goal of the weight gives them tremendous medical benefit. And we know now that not only 10%, even 4 to 5% of the weight loss is enough to start to see improvement in diabetes, as you all have seen in the last 2 days of lectures. So it's crucial that this message gets conveyed to all our patients. So today, hopefully, I can share some pointers which I use in assessment of my patients with obesity, and I can share with you so that you can apply them in your practice too. So most important thing is recognizing obesity as a chronic disease and a multifactorial disease is very important. Lack of obesity training in medical education, we all know when we were in medical college, in residency, we did not have any formal education for obesity. But now in the medical colleges, we do see some education being given. So 72% physicians feel poorly prepared to treat patients affected by obesity. And some feel the treatment is futile and not rewarding. Physicians believe the major cause of obesity were eating too much and lack of motivation. And heavier patients were perceived that they were less likely to comply medical advice. So now, as we recognize obesity as a chronic disease, and we know it's multifactorial, we can treat considering all these factors, the genetics, environmental, endocrine, neurobehavioral, immune, and medical factors affecting obesity, and treat the patients accordingly. That's why in 2013, obesity was recognized as a disease by American medical associations. And since then, medical world started to view obesity less as a lifestyle choice and more as a multifactorial dysregulation of hunger and satiety hormones. So the Obesity Medical Association has a more elaborate definition. Just going to read it for you. Obesity is defined as chronic, relapsing, multifactorial neurobehavioral disease, whereas increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, psychosocial health consequences. So to summarize that Obesity Medical Association definition and to understand, if we think obesity as sick fat disease leading to deranged endocrine and immune responses, leading to elevated blood glucose, elevated blood pressure, dyslipidemia, and metabolic diseases. Also, along with that, a fat mass disease, abnormal and pathological physical forces causing stress on weight-bearing joints, immobility, sleep apnea, and skin conditions, and many other obesity-related medical issues. CDC, Center of Disease Control, says obesity is a common, serious, and costly disease. In United States, obesity prevalence was 42% in 2017 and 2018. So during the assessment stage, when the patients come in, the key concept to keep in mind is a positive office space to make sure that the patients feel comfortable when they arrive in the office. Sturdy armless chairs or firm sofa in the waiting room, large patient gowns, appropriate medical devices like large adult blood pressure cuffs or even thigh cuffs, and the weight scales with the capacity of measuring the patients weighing more than 400 pounds. Also, sturdy, wide exam tables. As you can see here, these wide exam tables are automatic. They go up and down. So patients really can prevent the stepping stool and tipping in the exam room because of their weight. So giving the chance of appropriate equipments in the medical office is important. The other very important thing is the atmosphere in the office, how the staff addresses the patients who have obesity. So a supportive language, people first language to avoid labeling individuals is another very important thing we all have to remember. Patient has obesity is preferred over obese patient. Similarly, patient with diabetes is preferred over diabetic patient. The other day, I was hiking with a physician colleague of mine, and she mentioned that how her sister got affected by COVID, serious. She was in a serious condition, and she mentioned that her sister is diabetic. And I interrupted her, and I said, please, let's start not labeling the patients with their diseases. It's the people first. So we should say your sister has diabetes, not she's diabetic patient. So the encouraged terms, as you all have learned over the last 2 days also, it's good to talk. Is their weight, unhealthy weight, overweight, body mass index, patients affected by obesity. And we want to try and discourage terms of somebody who is obese, morbidly obese, or fat. So making patient comfortable in the office environment is another very important part of the assessment for patients for obesity and diabetes. I really like this quote by Maya Angelou when she says, I have learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. Another important tool of the patient's assessment you may have heard of, which I use it every day in my practice, is motivational interviewing. Stage of changes. There are 5 stages of change. Pre-contemplation, contemplation, preparation, active phase, and then the maintenance phase. It's a very powerful tool because it helps us realize when the patient is coming in the office, what is the mindset? What is the mental readiness the patient is in? And with the help of motivational interviewing, we as physicians should meet the patient at whatever stage of readiness the patient is in. And that's the only way we would be able to work together as a team. So, motivational interviewing. Pre-contemplation stage, number 1 stage, where patient is pre-contemplating, meaning not really ready to change, not even thinking that patient has a problem. So let's take and understand these stages of motivational interviewing through a case of Mr. K. Mr. K, I saw him on January 8th, 2019, 31-year-old Indian man, came in for annual exam. So annual physical exams are done in United States very regularly when the patients come in for their test, and they are completely covered by the insurance. So patients are very motivated to come in for that reason too. So software engineer, married, accompanied by his wife, who says when the patient is not working on his computer for his work-related things, he is playing video games until 1 a.m. She says the patient doesn't exercise and the weight gain over the last few years didn't bother him. Patient does have history of father with diabetes. So our patient here clearly was not aware of the problem. So pre-contemplation stage. Contemplation stage is when the patient became aware that there is a problem which exists, and maybe in the next nearest future might think of doing something about it. So when he came in during the physical exam, I did certain blood test, point of care test in my office. So his weight was 212 pounds, his BMI was 34, obesity stage 1, blood pressure was normal, his cholesterol is quite high, and this is the first time that he was diagnosed, and he realized that his sugar fasting was 227 with hemoglobin A1C of 10.5. So that's the time when he became aware of his problem. And then I used 5 A's of motivational interviewing. After assessment, I asked his permission that if I could address his weight today, and then went on for advising and agreeing to a plan and assisting to help him for his weight and diabetes management both. So this particular patient, Mr. K, from pre-contemplation phase now came into contemplation phase, and he got really anxious with the newly diagnosed diabetes, and he really started to ask me how he can prepare and how I can help if he wants to work on managing his diabetes and the weight control. And this time, when it's a preparation phase, when I gave him, okay, why don't you write a 7 days of food diary? Whatever goes in the mouth goes on the paper, bring that food diary to me in 1 week. And in this week, we will work on doing whatever exercise that you can do. It may be 15 minutes, 30 minutes, whatever you can promise me that you will do, but write that down and bring it to me. And that was our action plan for him that I gave in baby steps, very small steps, identifying what exercises and what food diary he needs to bring when he sees me in 1 week. And when he came in, the action plan we finalized is he will see me once a week for 12 weeks. So this is a 12-week weight loss plan with a structured approach for his weight management to 8 to 10% weight loss as the first goal is what we decided. So these are the 4 pillars of obesity treatment, I told him: nutrition, physical activity, medications, and behavior. And these 4 pillars, the first goal with these 4 pillars that we have is 5 to 10% weight loss from your baseline body weight. Why is it so important? The benefits of 5 to 10% weight loss: reduction in diabetes, improved blood pressure, improved lipid profile, and reduction in the cardiovascular factors. And also I told him, don't forget, there is improvement in sleep apnea up to 50% with the 10% weight loss. So that will be our first goal. Nutrition is tailored to one's needs and what they can do, whether they are vegetarian, non-vegetarian, they are vegans. Also, one important thing I always keep in mind, then whatever nutrition plan that we decide, not starving and enjoying food is very important. So giving that baby steps of nutrition. And exercise also, I do give them a definite exercise prescription depending on what they can do. I'm not going to go into details of nutrition and exercise because I know we have wonderful speakers in this session. They follow after my talk, so we'll hear from them. Then the next step is glucose lowering medication in type 2 diabetes. We have seen really last few years with DPP-4 inhibitors, GLP-1 receptor agonist, and SGLT2 inhibitors, which are weight neutral or weight loss, that we have seen with these glucose lowering medications were very, very helpful by managing patients who have obesity and diabetes. Metformin is our old faithful medications. Along with the diabetes weight neutral or weight loss medication, weight gain medications also we have to look when we are taking the patient's history. Other weight promoting medications patients may be on, like beta blockers, antidepressants, antipsychotics, and then is there any alternative medication that you can recommend instead of that weight promoting medication would also matter in the weight loss efforts. And then the FDA approved anti-obesity medications are indicated for patients who have obesity, BMI 30 or more, or patients who are overweight, BMI 27 or more with the presence of adiposity complications like diabetes, hypertension, and dyslipidemia. Anti-obesity medications, the 1999 and before medications, especially very commonly used till now, is phentermine, and I use that a lot. Sibutramine or Meridia is off market since 2010 for the cardiac side effects. But there are anti-obesity medications approved 2012 and beyond. And out of them, the one which I really like to use is a combination of phentermine and Topamax. Lorcaserin is being discontinued because of the possibility of cancer as the side effects. And other two, I don't use much. Naltrexone combination with bupropion and liraglutide as the weight loss medication. So coming back to our case of Mr. K, when he came back in 2 years later in 2021, he had lost about 11 pounds, kind of off and on, in and out of the diet. But then in February, he decided that he wants to come back again, his 3 months structured diet plan, and his A1C after 11 pounds weight loss and metformin 1000 milligram daily dropped to 6.7. We talked about it, that how much better he's doing and how he was very determined to lose more weight. And we talked about getting to the next BMI of below 30. So from obesity to overweight range as our next BMI goal. And patient came back just in January this year, and the total weight loss was 32 pounds, 180. He was 180 pounds. So A1C this time was 5.3, and I discontinued his metformin at this point, but we continued with weight maintenance, which is the 5th stage of the motivational interviewing. And this is where the behavioral change needs to continue by seeing these patients again in a structured manner every 3 to 6 months, monitoring their A1C, their lipids, their blood pressure, and their maintenance phase. So in the end, I like to say, I practice what I preach, because obesity is a chronic condition that requires a strong physician-patient relationship. My patients inspired me to, over the years, for regular biking and hiking as my lifestyle. Remember, our patients are our teachers too. So there is a lot to learn from them. I look forward to successful, happy losers in our practices. Thank you very much.
Thank you, Dr. Manjul, for this very practical approach towards the management of obesity. So I invite any questions from the audience. Any questions? I would like to ask one question to Dr. Manjul. Is usually the patients who are losing the weight, that they don't stick to the weight management protocol. So after losing weight after a few months, they started eating, not following the protocol, and then they regain the weight again. So how do you manage this problem of maintaining the weight loss in your patient? Because I think this is a very difficult job to do, to maintain the weight loss in your patient. So how will you do?
Yeah, that's a very good question, Dr. Madhulika. And it is something which is the most difficult part of the weight loss equation. So weight maintenance is the most difficult. So what I have in my office is the posters in exam rooms talking about taking this weight loss approach as a lifestyle change, not as a crash diet. So not something one would do for 12 weeks, 3 months and lose a lot of weight and then go back on what they were doing before and gain all that weight back. We know that it doesn't work like that. So a physician's message to the patients that, look, this is a chronic medical disease and we need to work on it as a lifestyle change. And the way I work with them, as you asked, is that I give them a 12-week plan to start the program, and 12 weeks is to make sure enough to form a habit. And then that habit is what they take it when I see them every 3 months. And it takes 2 years to form into a lifestyle. The habit changes into lifestyle. So if I see them every 3 months with support and with help in their nutrition and their exercises, that's the lifestyle change that I'm looking for. So I give them the example. Let's see, if diabetes, if one has, they are on medications, they are on lifestyle changes, what happens? You stop that. If you stop medications, the diabetes is going to be uncontrolled. Same way, obesity, if you stop medication, if you stop the lifestyle changes, it's going to go back again as a chronic medical disease. So it has to be treated as a lifestyle change. I'll give you an example of one of my patients when she came first time. This was about 10 years ago. I still remember clearly. She was referred by a gynecologist because for the PCOD, polycystic ovarian disease, she wasn't able to conceive. So she comes in and I tell her that, look, you're going to be with me for a long time. You lose weight, you'll get pregnant, you deliver, you will again gain weight and you'll come back. And we got through that whole process of a year and she came back and she's still my patient, 10 years. We meet each 3 to 6 months or so. That's the weight maintenance. So it's a long-term management and long-time lifestyle change is the answer for that.
Dr. Unni, do you want to ask?
I think the fascinating story here is also the presence of the Indian diaspora there in the Silicon Valley, and how you think in clinical practice how they're completely different from the Indian population living in India. So those insights were wonderful. And would you like to add to that?
So some, I would say the people who are living there for a long time, they do change, but there are a lot of them are just landed from India like yesterday. So it is a good combination of software engineers because of globalization, we see that change all the time. But what I do see is talking to them and their kind of diet, which is from South India or North India, and making that small change and giving them the baby steps. I say, do 1, 2, 3. And when I see you, you just do those 3 things and come back. Because I know out of this office, you'll be on your computer and you will not remember me. But 3 small steps is what I identify. I write it down and I give it to them. And I say, stick that on your computer and just do that. May it be 10 minutes of that exercise, which is yin yoga. I promote a lot. And whatever is doable in their setting is what I figure out and give them their baby steps. And they come back and said, I feel good, doctor. That is what I want to hear, and then take them to the next step. And this is very rewarding if taken at small stepwise manner to see the small differences that we can make as physicians.
Thank you, and it's been wonderful listening to you. And thank you, Dr. Manjul Patwardhan and Dr. Mahashabde. We had a wonderful session, and I really, this is one of the most important sessions because it began with a primary care perspective, and that too from an international perspective with also an Indian perspective added to it. So thank you for that. Thank you, Dr. Mahashabde and Dr. Patwardhan. And over to Dr. Session.
Thank you very much, Dr. Unikrishnan. To have same podium sharing with my sister is amazing. Thank you so much.
Thank you. Thank you.
Thank you so much, ma'am. Thank you so much, Mahashabde ma'am, for chairing the session. Moving on to next session, I would like to welcome Dr. Nitin Banga for the next session to chair the session, which is on exercise advice is not about walking 5 days away. Dr. Nitin is MD General Medicine, consultant physician and a diabetologist at Jalara Diabetes Institute. He's an ex-assistant professor at Prakash Institute of Medical Science and Research Center, Istanbul.
I think we can go ahead and introduce the next speaker straight away. And may I take the privilege of introducing Dr. Nikita Morwal, who's our
Sure, sir. Sure, sir.
Dr. Nikita Morwal, who's our own consultant physiotherapist, has an interest in yoga. He's a wonderful physiotherapist and has got a very calming and spiritual influence on our patients, which motivates them to do better, in addition to being very evidence-based in all her approaches. So over to you, Dr. Nikita Morwal, for your presentation. Dr. Nitin is here. Would you like to say a few words?
Thank you for letting me chair the session, sir. Thank you.
Thank you, and do participate in the discussion. Thank you.
Yes, sir.
Good morning, everybody. Firstly, I would like to thank Dr. Unikrishnan sir for giving me this opportunity to talk at the conference. My topic for today is exercise advice is not about walking 5 days a week. We'll be covering 3 topics here. First topic is facts about walking. Second topic, various types of exercises. Third, active living, and followed by 2 case studies. Now, facts about walking. About 2000 steps is equal to 1 mile. Walking just 21 minutes a day can cut your risk of heart disease by 30%. Adding 150 minutes of brisk walking to your routine each week can add a little over 3 years to your lifespan. We might have heard such statements regularly in our day-to-day life. But when we see jobs like waiters who are walking 23,000 steps a day, or nurses who are walking about 16,000 steps a day, or any retail worker who is walking 15,000 steps a day, do you think they are really fit? The answer is no. Reason being, walking is not an exercise, or it is not a complete workout by itself. Fitness routine must include 3 components, that is your endurance training, resistance training, and flexibility exercises. Walking falls short of these 3 main components of exercise. Simply walking every day makes one lose muscle mass, which shows during the aging skin, and also the energy levels over the years. Walking, when it is complemented with other specific training like resistance training or flexibility exercise, then it will help to build muscle mass, improve the blood sugar levels, keep energy dips in check, and also delay the aging process. So, walking can be considered only a part of physical fitness, but not only the only solution for any kind of exercise. Now we see what are the various types of exercises. In that, first we see the aerobic exercise. Any activity that uses large muscle groups in continuous rhythmic pattern and maintained for a considerable amount of time, that is minimum 30 minutes, is called aerobic exercise. Each type of exercise that overloads the heart and lungs and causes them to work more than that at rest is called aerobic training. Now, examples of aerobic exercises are walking, cycling, jogging, and swimming. According to American Diabetes Association, 2019 guidelines on aerobic training include the frequency should be spread at least 5 days per week, intensity ranging from moderate to vigorous intensity, But for beginners and older people, the exercises should be started at lower intensity. The time duration should be 30 to 45 minutes of exercise, but they can also be done in short sessions of at least 10 to 15 minutes daily. The type of exercises include brisk walk, cycling, jogging, marching at one place, and swimming. What are the benefits of aerobic exercise in diabetes? It strengthens the heart muscles and improves the lung capacity. It assists in maintaining an optimal weight. It increases the good cholesterol and decreases the bad cholesterol, lowering the blood pressure. And also it relieves stress, decreases depression, and improves the quality of sleep. Now, second type of exercise is strength training or resistance training. Strength or weight training exercises are those done using different weights, dumbbells or resistance band, and also self-resisted exercises where one is using own body weight as a resistance in the form of planks, push-ups or pull-ups. Now, a recent study done by Angelic G. Brelinth in USA in 2020 suggests that combination of aerobic and resistance training worked best for maintaining weight in obesity and also diabetes patients as compared to only giving them aerobic or weight training alone. Now, what are the benefits of strength training exercises? Resistance training helps to improve the glycemic control. It wards off age-related muscle loss. It improves the joint mobility. It delays the degenerative changes. It builds up and maintains the muscle strength and balance. It also assists in fat loss and maintains a healthy body weight. Now, according to Canadian Diabetes Association 2019, the resistance exercise guidelines include frequency, they should be done 2 to 3 times per week. Intensity is 2 to 3 sets of 8 to 12 repetitions. 10 repetitions can also be done. Type of exercise include the TheraBand exercise, weight lifting exercise, dumbbells or sandbag exercises. Also self-resisted exercises like planks, push-ups or pull-ups where we are using own body weight can be done. Stretching exercises are for flexibility of joints. Stretching exercises help to lengthen the shortened muscles after a vigorous workout, which in turn helps to prevent DOMS. DOMS is nothing but delayed onset of muscle soreness, that is accumulation of lactic acid in the group of muscles, where it is caused in the initial 12 hours of a sudden workout. It improves the flexibility of joint and muscles. Stretching exercises are another form of exercises for improving the flexibility of joint. These exercises help to lengthen the shortened muscles after vigorous exercise, which in turn helps to prevent DOMS, that is a delayed onset of muscle soreness. It improves the flexibility of joints and muscles. Ideal time to do stretching is immediately after exercise. Each stretch has to be done for about 2 to 3 times with holding time of 20 to 30 seconds. Stretching session should last for about 5 to 10 minutes. Yoga is another form of exercise that is used for building up flexibility. Yoga is a way to stay flexible, strong, and always helps to keep your mental health in check. It helps in the development of body, mind, and spirit, reducing the stress and enhancing good quality sleep. It can be done for about 2 to 3 days in a week. Now, what is active living? Active living is defined as a way of life that integrates physical and recreational activity into your everyday routine, encouraging a healthier lifestyle. Physical inactivity causes 3.2 to 5 million global deaths annually and is the 4th leading risk factor for global mortality. What is physical activity and sedentary lifestyle? Now, physical activity is defined as any movement carried out by skeletal muscle requiring energy ranging from low, moderate to vigorous physical activity with varying amounts of energy expenditure. For example, playing a recreational sport or game, activities of daily living, or any planned exercise sessions. Sedentary lifestyle, on the other hand, is an individual who engages himself in prolonged sitting or lying positions without much movement. That includes your desk job, prolonged computer use, TV viewing, video game playing, These are collectively termed as screen time. These days we see that screen time is increasing more compared to your physical activity. Epidemiology of sedentary behavior and health risk. Increased sedentary behavior has been shown to greatly affect the health outcomes such as increased risk of obesity rates, lowered cardiorespiratory fitness, and lowered insulin sensitivity in young people. It is predicted that the 4.1 million children and young people who are obese and overweight globally are likely to remain obese and overweight into their adulthood, and there is a greater risk of developing diseases like diabetes and cardiovascular conditions at a younger age. We are all aware with the food pyramid, but have you ever seen an exercise or physical activity pyramid? Let's have a look at it. This pyramid is self-explanatory, where it shows that the sitting time should be less. So it is kept at a lower hierarchy level as compared to the other activities. Your everyday activities like walking, stroll, or climbing stairs, gardening, your other hobbies throughout the day are included at the highest level. Earlier, the concept was that only walking for a few minutes a day can help keep you healthy. But no, today's motto is to sit less, move more, and be strong. What is the role of physiotherapy to tackle sedentary lifestyle? The Chartered Society of Physiotherapists had released a corporate strategy which states that by the year 2020, physiotherapists should empower individuals and communities to maximize independence and live long and live well. Physiotherapists have specific competence and expertise and are ideally suited to promote, guide, prescribe, and manage active living. Physiotherapists need to immerse themselves more widely in the community to tackle sedentary lifestyles proactively and prevent their associated comorbidities. Now we look at the case studies. Our first case study is a 55-year-old female having type 2 diabetes since last 13 years has come for exercise consultation. Her present HbA1c is 6.5%. She was regularly doing exercise, but since last 15 days started with severe left knee pain, and X-ray findings are suggestive of osteoarthritis. What would be the exercise plan for her considering her knee pain? We start with knee isometric and strengthening exercises for the quadriceps, hams, and VMO strengthening. We advise her to avoid cross leg sitting, full squatting, stair climbing, and prolonged standing. Use of supportive kneecap during activity that can be taken off while resting. If there is a swimming pool nearby her residential, then she can do water walking or water aerobics for knee pain. And later she can start with walking and static cycling. Our second case study is a 33-year-old male who has been recently diagnosed as type 2 diabetes, working with IT company, has back pain since last 6 months, and at present he is not doing any exercises. What would be the exercise plan for him? We start with back exercises, back isometric, stretching and strengthening exercises. He should avoid forward bending activities, heavy weight lifting, prolonged sitting or standing in one place. He should maintain a proper posture, swimming and desk exercises so that encouragement of movement is done. Then after that he should start with cardio fitness for about 30 to 40 minutes per day, and then once the back pain is subsided, then we give him resistance or weight training exercises. This way I conclude my session, and I would again like to thank Dr. Unnikrishnan sir for giving me this opportunity to speak at this conference. Thank you.
Any questions from your side, please?
Dr. Nikita, do you want to talk about nerve pain or any physio for the nerve pain specifically? Yeah.
we have any kind of radiculopathy, it's a cervical or lumbar, then we start with the modalities treatment, like we have IFT for that, or TENS, that is a transcutaneous electrical nerve stimulation. We will manage conservatively. Post that, we give him the stretching exercises for reducing the nerve pain, and thereby accordingly we will manage the other things.
Thank you. Thank you, Dr. Nikita. So you want to ask anything?
Nikita, can you hear me?
Yes, sir. Yes, sir.
No, I think we can't hear you.
Yes, sir.
Yeah, so I was just asking you your views on exercise in people who have got both knee pain and periarthritis shoulder. What sort of exercises would you recommend? And after that question, I think we can go on to the next session.
Sir, we start with the shoulder exercises and the knee exercises both. Shoulder exercises, we start with the range of motion exercises, the pendular exercises for relaxation, and knee exercises, again starting with the knee isometric exercises for your hamstrings, quadriceps and BMO strengthening. And post that, we can give him exercises for the diabetes. Because periarthritis shoulder, for our first main goal is to improve the range of motion so that the patient is able to do all his daily activities. Usually in periarthritis shoulder, it is seen that the external rotation and extension is affected more than the other range of motions. So we have to tackle that and then proceed with the diabetes management.
Thank you, Dr. Nikita. Thank you, Dr. Nidhi, for chairing this session. Thank you, Dr. Nikita, for enlightening us with the details. Thank you.
Welcome, Dr. Meenakshi Bajaj.
Very good morning, sir.
Honor to have you with us. And Dr. Shweta and team, do introduce Dr. Meenakshi, and let's start with the next session.
Yes. Moving on to next session, which is nutritional approach to remission. I would like to welcome Dr. Shilpa Surya and Meenakshi Bajaj to chair this session. Dr. Shilpa Surya, presently working as an assistant professor at Bharati Vidyapeeth Deemed to be University, Pune, worked as consultant physician and diabetologist at Chellaram Diabetes Institute. She has done DNB General Medicine from Ruby Hall Clinic, Pune. Meenakshi, can we have the slide of Meenakshi Bajaj, CV slide? Meenakshi Bajaj is a registered dietitian with 29 years of experience in clinical and therapeutic nutrition, certified bariatric and critical care nutritionist, certified diabetic educator, and nutrigenomic consultant, a state rank holder and best outgoing student. Over to you, Shilpa, Dr. Shilpa Surya and Meenakshi Bajaj. Would you like to introduce Rucha Mehta?
A very good morning to one and all present here. At the outset of the 6th International Diabetes Summit, I thank Dr. Unni Krishnan sir and his entire team at the Chellaram Diabetes Institute for the opportunity to be associated with the CME certificate course on type 2 diabetes remission. We are aware that several elegant studies discuss the fact that ethnicity, environmental factors, genetic predisposition, type and duration of diabetes play a very, very important role in the remission of diabetes. And the present session is lined up with the most sought of speakers, Dr. Rucha Mehta, Cheryl, and Dr. Geeta Darbati, to share their pearls of wisdom on the topic nutritional approach to remission, which is unfortunately very often confused with reversal. And today we have 3 sessions. The first session, which is going to be spoken of by Dr. Rucha Mehta, is on keto diets, intermittent fasting, and type 2 diabetes. Can we have Dr. Rucha Mehta's CV, please? Yeah, Dr. Rucha Mehta is a very experienced endocrinologist at Ahmedabad, practicing at the Apollo hospitals, and has an experience of over 16 years in this field. She's also a member of the American Society of Internal Medicine, American Association Clinical Endocrinology, European Association for the Study of Diabetes, American Diabetes Association, and the Indian Medical Association of Southern California. Here, the session is open for discussion with Dr. Rucha Mehta, ma'am. She's going to be talking to us about keto diets, intermittent fasting, and type 2 diabetes. Over to you, ma'am.
So welcome, Dr. Shilpa Sule. And also we'll have the 3 lectures, and after the...
And welcome to this conference. Thanks to my really dear friend, Dr. Unnikrishnan, for always putting together such a fantastic conference. So today the topic given to me is how can we use ketogenic diet and also the concept of intermittent fasting for the management of our patients with obesity, diabetes, and the metabolic syndrome. So in the next 15 to 20 minutes, what I'll do is I've broken my talk into 2 parts. We shall first talk about ketogenic diets. Then I'll move on to intermittent fasting, show you some of the data and how to apply this in real-time practice. And then we move on to see the guidelines and some practical key points as to how can we go about using this very effectively. Now, as we all know that the principal components of diet are 3, the macronutrients as we like to call them. 50 to 60% of the total calories generally in our diet come from carbohydrates. About 50 to 20%, 50 to 60%, and then 15 to 20% from proteins, and about 20% from visible and invisible fats. This is generally what has been observed, and this is from the Indian consensus guidelines. Now, what do Indians like to have in their diet? So I am from the city of Ahmedabad, and you can see that this is what a Gujarati thali typically looks like on a Sunday morning, and we are all here on a Sunday morning. So you can see that it's carbs, carbs, carbs rich galore. It doesn't matter, however, if you go to some other part of the country too, as you can see, there is rice, paneer butter masala, there is dal tadka, lots of carbs on our plate always, no matter what part of the country. If you go to the south of the country, if you go north, east, west, I think all of us love to have carbohydrates. And truly, this has been shown by the START study that a high carbohydrate diet is a common Indian reality. And instead of the guideline of 40 to 50%, we consume about 60 to 70% of energy intake through carbohydrates in a diet. Now, why is this of concern? Because we know that refined grain consumption, as is shown over here, can lead to the metabolic syndrome. And this is what we are trying to prevent. A higher intake of refined grains was associated with insulin resistance and the metabolic syndrome. We also know not just that, as the glycemic index of food increases, what you see here, a p-value, that the total dietary carbohydrate glycemic load leads to an increased diabetes risk. Fiber or dietary fiber, which is a negative carbohydrate, was inversely associated with the risk of diabetes. So it would make sense that we should try to practice a low carbohydrate diet. And that low carbohydrate diet helps to improve glycemic control. As you can see in this particular study, there's a low carbohydrate diet versus a low fat diet, and it had a better impact, not simply on weight loss, but also on the reduction in HbA1c. So this is important. This is just to set the stone as to when your patients ask you, what should I eat? How can you guide them? What is the ideal proportion of carbohydrates, protein, fat, and now the new kid on the block, I like to call it fiber. There's a plethora of information out there. When your patient starts searching the internet, he goes crazy because there is the cabbage soup diet, the Atkins diet, the zone diet, keto diet, and he doesn't know what he should be following. So my role today is simply to speak about the ketogenic diet. So in the interest of time, I'll stick to what was designated to me. So what is truly a ketogenic diet? So what we are doing in this particular diet is we are playing with the macronutrient composition, or we are doing this in order to reduce the amount of carbs in the diet. As you can see, typical diet, the blue shows you the carbs, red shows you fat, and green shows you protein. This is what is typically the guideline. However, in a ketogenic diet, majority of your calories will come from fat. About 20 to 30% protein remains about the same, but the carbs are what go down. So in a ketogenic diet, the total daily carbs need to go down to less than 30 grams per day, ideally. Now, what are ketones? I'm going to take you back to school. I apologize for that. And what is ketosis? The minute you are not taking or consuming enough carbohydrates, what happens is your body, you flip a metabolic switch. Instead of using carbs as a source of energy, your body now switches to using fat as a source of energy. The process of ketogenesis begins in the liver, and at the level of the mitochondria, you will now start to use these bodies to make ATP or energy. Now, this is what is important to understand, that you will not throw your diabetic patient into ketoacidosis. Just to give you an example, you can look at the blood levels of ketones during a normal diet, ketogenic, and DKA. So if you go down at the very bottom, you are only trying to get them a ketone body concentration when they're mild to trace ketosis. Whereas in DKA, those ketone body levels are very, very high. The blood sugar levels are very high, and the insulin is completely turned off. Hence, you do not have to worry that you're going to push your patients into DKA. Moving right along. The screen is not moving. Okay, so how does this work? This is simply put, if you wanted to hand out something to your patients, that in the traditional diet with the higher carbs, the glucose levels rise, you secrete insulin, and you use glucose as a source of energy. However, in the keto diet, what you do is as the glucose levels fall, you actually will start burning stored fat and stored triglycerides. These travel to the liver, and the liver produces ketones, which are now used as a source of energy. So truly speaking, the ketogenic diet is a fat burner. It can be very effective if used in the right sense and for the right indication. Because after a while, your body undergoes what is known as keto adaptation. If you choose to practice this for a longer time, your body will now learn how to use fat as a source of energy. However, it does not mean that you are going to do this chronically. Why is this becoming so much in vogue, and why are we talking so much about it? Because the ketogenic diet has not only appeared to be helpful, as you can see to the left of your screen, having strong evidence for diabetes control and even remission, weight reduction, improving CV risk parameters. But as we know that it was first designed for children who had epilepsy, it works at the level of the brain. It may even prevent diseases such as Alzheimer's disease, certainly for PCOS and also cancer. So there are a lot of roles that have been now touted for the ketogenic diet. These are some simple handouts you can prepare in your clinic as to do's and don'ts. Because as I just told you, we want to have the carbs very less and the fat is going to be high. So in the Indian context, generally speaking, say you have an individual where you need to give a 70-gram fat diet, we would usually give them a keto. I'll just show you in the next slide. We want to give them good sources of fat. We are not giving them saturated fat, trans fat. We are not asking them to use processed foods. We are trying to use good sources such as good oils, nuts, seeds, the flour that is made from almonds. So it's a good source of fat also. Typically, the breakfast would look like this. This is used with almond milk or coconut milk based tea, or they can have black tea, black coffee. They can have just one serving of sprouted moong with olive oil in it. For snacks in between, they can have almonds. This is what a lunch might look like. So the keto atta roti along with palak paneer, because paneer is a good source. And for dinner, we try to ask them to use paneer again. So we have several different ways of doing this and several different items we have prepared in our clinic also that we are using for these patients. Now, does this work? Let's now see what happens with a metabolic syndrome. So Dr. Wallach, who has done huge amounts of data with ketogenic diets, he designed this study. Very interesting, even though it's a small study, I thought it was very cool. It was a 3-way crossover control feeding study. 16 obese participants with the metabolic syndrome. They had a run-in period, then they did a low carbohydrate diet, followed by a washout, then a moderate carb and a high carb diet. Let's see what happened to them. As you can see that the prevalence of at baseline of metabolic syndrome and what happens to these people on the low carbohydrate diet, you can see that a higher number of patients were able to get out of the metabolic syndrome. Whereas we do not find this happening on the moderate carb and the high carbohydrate diet. So low carbohydrate diet worked very well to reverse metabolic syndrome. However, this was just a small study. Now let's look at a large meta-analysis comparing low carbohydrate and low fat diet. In these people who are overweight and obese, this is Dr. Sanjay Kaul's study. Here are about 900 patients. You can see they're about 44 years of age. They are most of the part, they're obese. These are the cholesterol values. And what you can find, okay, that we also have the dietary intervention. About to the left of the screen in the low carbohydrate group, they received averagely 60 grams of carbs. And in the low fat group, they had 205 grams of carbs. And fat was vice versa, 90 grams in the first group and 37 grams in the low fat group. Now, what do we find across the board? You can see the weight loss favors the low carbohydrate diet versus the low fat diet in this particular hazard plot. Now, again, they also looked at, this is a very interesting study, so hold on, at the cholesterol values. So overall, there's a total cholesterol was lower in the low fat group, but if you can observe, the HDL cholesterol improved in the low carbohydrate. LDL cholesterol did not increase in the ketogenic diet or the low carbohydrate group, and the triglycerides went down further in the ketogenic group. So this is something we worry about when we give our patients high fat, but this was not observed. And again, the systolic blood pressure also fell to a higher range in the low carbohydrate group. Now, what they had also done is they had calculated ASCVD, which is atherosclerotic cardiovascular disease risk score in these groups. And if you look at the bottom of the screen, which shows what was the estimated 10-year ASCVD risk, who did better, it shows that the low carbohydrate group was superior to any of the other. And they looked at whites as well as African Americans. So this is very, very reassuring, because we always hear about things such as, is the ketogenic diet very high risk? If done appropriately and in the right setting, it can work. Now, what about our type 2 diabetic patients? So here's a network meta-analysis comparing the diet effects on glycemia. And here they looked at several different studies. Just to be fair, I also thought I want to mention versus the other studies. So here's your low carbohydrate or the ketogenic group, and n equal to 8 is the number of studies included, versus vegetarian, Mediterranean, high protein, moderate carb, as well as a control group. And what do we find? Low carbohydrate diets worked the best for improvement in HbA1c versus the high carb. We have data now up to 6 months. We don't have long duration studies. Very low carb diets also had a superior advantage versus even low carb. So ketogenic did even better. And other benefits of low carb, it raised HDL cholesterol, it lowers triglycerides, and it reduces diabetes medications. Also, there was no difference in how hard people think it is. So to look at the quality of life, people were able to stick with low carb and low fat diet to the same extent. So again, something to bear in mind. What about reversal or remission of diabetes? Because we are talking about this. So again, from the VERTA diet studies, this is taken from Dr. Saslow's paper, who has also done a lot of work for ketogenic diet. They show that there is about a 37 to 50% chance of partial remission of diabetes. So I think at the end of 1 year, significant reduction is seen also in the medications when you use a very low carbohydrate diet. So again, from week 0, as early as week 16, from Dr. Yancey's group, we can see a reduction in the number of medications. Now, just to be fair, the cons for a very low carbohydrate diet, we do not have any long-term studies. We do not have studies in people who already have end organ damage. We do not have studies looking at the quality of fat, low versus high saturated fat. As I said, it's very important to make sure you're using good quality of fat. Medication adjustments will always be needed. You cannot leave your patients unchecked, because a low carbohydrate diet otherwise will cause significant hypoglycemia. So something very important that it's done under supervision, as I've repeatedly mentioned. So now let me switch gears and speak for a while about intermittent fasting, pros, cons, indications, and how will you implement it. As a diagram shows you, it talks about you will eat in a narrow window and you're not going to eat, or you're going to be fasting for the remaining time. So it's basically periods of voluntary abstinence from food, or both food and drink, as some people are doing a stricter intermittent fasting. These are the various patterns that you may have heard about, but there are even many more. So the first line talks about an alternate day fasting. The second line talks about a 2-day fast and a 5-day eating period. So in the 2-day fast, you eat very low calorie, up to 500 kilocalories. And the other 5 days, you can have ad libitum eating. What is most popular is what we call TRF, or time restricted feeding. In this, generally people will follow a fast anywhere for the bare minimum for 12 hours, up to 18 hours and even 20 hours, and they will eat in the narrow window of 4 to 6 or 8 hours. And in that time period also, it doesn't mean they need to go crazy and eat 5,000 calories. In order to have benefits, we need to be careful about what they are eating. And then you also have modified alternate day fast, wherein there's alteration of 24 hours with a very low calorie consumption. So instead of complete fasting, you can eat a little bit with a 24-hour ad libitum eating period. So this could be something which is very popular, the 16-8 method, as we like to call it. For Indians, I think, since we all tend to eat dinner very late, the 12 p.m., if you can fast in the morning, that's probably the easiest way to strike the balance, and try to eat your last meal by 8 p.m. And that might be a good way to go about it. During the fasting period, what we do allow is, as I've written over here, a sample meal plan. The patients can wake up and have green tea, warm water. First meal at noon could be either breakfast, or they could start with a protein-based smoothie or a shake, depending on their activity level. Tea, coffee, poha, upma, eggs. Lunch at 2 p.m. is generally a regular meal. A light snack if necessary at 4 to 5 p.m. And then dinner before 8 o'clock, usually a khichdi or something light, depending on, again, their protein requirements and other things. We have set several examples of meal patterns that we hand out to our patients over here. Now, why does it work? Why does ketogenic diet work? Why does intermittent fasting work? Is it the macronutrient composition? Are we supposed to just restrict them to carbs, protein, fat? Or is it calorie restriction? What we've always learned so far, that it's always the number of calories in versus calories out. Certainly we know that if you want to lose weight, you need to consume less calories than what you're eating. But what seems to work very well in both of these dietary patterns is a metabolic switching. In the ketogenic diet, as I mentioned to you, you flip a switch wherein your body switches from using carb as a source of energy to fat as a source of energy. Let's see what happens in intermittent fasting, and why have these two been clumped together? What is the metabolic switch? So what I've shown you in this diagram, the minute you stop eating for 10 to 14 hours, there is a depletion of your liver glycogen store. So again, the same concept. You do not have carbs coming in. This leads to a switchover and hydrolysis of triglycerides to free fatty acids in the adipocytes. These, as we just spoke about, they produce ketone bodies and acetoacetate and beta hydroxybutyrate. So ketosis is triggered. There is a release of FGF21. Your ketones are now transported into cells where they form acetyl-CoA, generate ATP, activate other beneficial transcription factors, In the long term, reduced activity of the mTOR pathway and upregulation of autophagy is seen. Additionally, if you could also calorie restrict during this time, you will stimulate mitochondrial biogenesis and mitochondrial uncoupling. So you can see that if you can't strictly do a ketogenic diet, your option is to do intermittent fasting and stimulate the ketone pathway through the starvation ketosis mechanism as well, or through an energy restriction pathway. How does this impact human metabolic health? It's a very interesting paper. I just thought Dr. Patterson's paper should be mentioned, wherein intermittent fasting, she also suggests that because we are working with the circadian rhythm and we're disrupting the circadian rhythm to a certain extent, there seems to be an activation of the beneficial intestinal gut microbiota. This leads to a metabolic regulation or a change in metabolic regulation, reduced inflammation, and therefore an improvement of glucose and lipotoxicity, and impacts on obesity, type 2 diabetes, cancer, CVD, and several other diseases. Okay, as I promised you some practical considerations, I made sure I was showing the dietary patterns in the beginning so I don't run short of time and we don't have that. So what are the effects on weight, metabolic syndrome, and diabetes? How many hours should you fast? Should you calorie restrict? Can you do ketogenic diet plus intermittent fasting? And does it matter what you're eating? That's the macronutrient part. So here's a study which was looking at a 4-hour and a 6-hour time-restricted feeding on weight and cardiometabolic health. As you can see over here, some of the subjects were fasting for eating for 4 hours. Others were eating for 6 hours, whereas the control subjects maintained their usual diet. What we find is that there was no weight loss in the control group, and there was a significant weight loss, which was similar in both the 4-hour and the 6-hour eating group. Now, okay. So what I also want to show you in this panel over here, this is the change in fat mass, which goes down in the 4-hour and the 6-hour window, much more in the 4-hour. Lean mass was maintained. Visceral fat also reduced only in the time-restricted feeding patients. Fasting sugars, fasting insulin all went down. Insulin resistance improved in the feeding group. Markers of CV risk such as 8-isoprostane, TNF-alpha, interleukin-6 all improved in the fasting group. Blood pressure and also the cholesterol values improved in the fasting group. So this is interesting to keep in mind, that maybe the stricter the window, the better you will see results. Now here's alternate day fasting combined with a low carbohydrate diet. As I was talking to you about, do the macros matter? So the initial phase, they looked at weight loss for the first 3 months, and then they put them on a weight maintenance. So the calories were increased. Initially on the feast day, they were given 1,000 calories, and on the fast day, 600. In the weight maintenance period, I mean, this is a very strict protocol, giving them only 600 calories per day, and then they were maintained during that period. In the low carbohydrate group, as you can see, there is a 50 gram and a 30 gram. So this is really a ketogenic diet done for almost a 6-month period. Let's see what they found. You can see this really nice weight loss. So body weight decreased over the study period, as you can see over here. And then in the weight maintenance period also, it's interesting to see that patients were able to maintain their weight. Similar impacts were seen that the cholesterol values, blood pressure values dropped down. And if you're able to maintain your time-restricted feeding, there was not much more of a drop, but they were able to maintain whatever loss was seen. HbA1c values remained about the same, which was surprising. Now we have several other studies showing the effect of intermittent fasting on A1c and weight loss in adults with type 2 diabetes. And you can see there is a robust drop in the HbA1c. The weight loss may not be as significant, as you can see the p-value. However, no hypoglycemia was observed, and the glycemic control certainly improved in most of these studies. Another just word quickly on the PESCO Mediterranean diet with intermittent fasting. As we know, the Mediterranean diet has received a lot of importance and significance for CV risk along with diabetes. This is data from the Predimed study, wherein we know the Mediterranean diet simply with extra virgin olive oil and with nuts seem to reduce the CV risk dramatically. Since there is a lot of talk about vegans lacto-ovo-vegetarians, pesco meaning fish. I just wanted to show you this scatter plot over here that looking at all-cause mortality as well as ischemic heart disease mortality, what was surprising to a lot of us, and we kind of knew about it, that the vegan and the vegetarian diet did really much better compared to non-vegetarian diet. So there is a lot of talk about animal protein triggering all of these factors. Also, we can see the pesco vegetarian diet was the best along with intermittent fasting in all these studies. However, this is very small data. It is hypothetical, and we need much more prospective and randomized studies to document its efficacy. So to summarize, the ADA consensus and the guidelines says there is not an ideal percentage of calories from carb, protein, and fat for all people. Macronutrient distribution should be based on individualized patient assessments. Secondly, however, they also go on to say, if your patients are not meeting glycemic targets, then what is important is that reducing overall carbohydrate intake or a very low carbohydrate intake for a short duration is a viable approach. We know there are several eating patterns such as the Mediterranean, vegetarian, vegan, low fat, low carb, paleo diet. We need to look at which one works. So I've shown over the top the reduced risk of diabetes, A1C, less CVD, and you will see that the Mediterranean diet works very well for diabetes and CV disease risk. The low carbohydrate diet seems to work for several of these. So that's why the ADA also further goes on to say, let's emphasize non-starchy vegetables, minimize added sugars and refined grains, and choose good foods, whole foods over processed food, and reducing overall carbohydrate intake is important. So let's put it all together. For type 1 diabetes, carbohydrate counting, not many trials found for this approach. For type 2 diabetes, certainly I've shown you low carbohydrate and very low carbohydrate patterns are the most studied. After low fat and A1C improves. And we need to keep in mind that intermittent fasting, A1C improves, but not to such an extent as we compare with the controlled diet. So we can combine the two and get a good bang for our buck, however, under supervision. Adherence is always what is more important than the meal plan type for weight loss success. And what is new from 2013, again, as I mentioned to you, that you need to get your patients to lose weight for treatment of diabetes, overweight, obesity, and the metabolic syndrome. Very low carbohydrate diet is no longer considered unsafe. It may be viable and an important option in your patients with diabetes. You want the patients to lose weight about 5 to 10% for improvement of their medications. So, are you ready to make this change? Are you ready to keto? Is something you need to ask your patients. You need to really walk the talk and be hand in hand with them. And with this, I will go ahead and stop and be ready to take any questions. Thank you very much for your kind attention. And thanks to Unni again for allowing me to present today.
Thank you so much, ma'am, for the elegant presentation and upscaling the skills of our audience today. Ma'am, I had a query to ask you.
Sure, please go ahead. Yes. Can you hear me?
Sorry, ma'am. Yes, ma'am, you're audible.
Okay.
Ma'am, you've taken us through all the studies and the practice points. Just a little query that if you're going to follow a ketogenic diet, basically it's going to be totally non-vegetarian and the sources are more so saturated fat. So do you expect gut dysbiosis and its effect on metabolic health?
I'm not sure. That's a great question, just to clarify. And I think yesterday, Dr. Dharmati, who's going to follow me, said that in India, even people who say that they are non-vegetarian are truly vegetarians because they don't eat so much non-vegetarian. So in fact, the ketogenic diet, when we used to look in the past, and if you're looking only at Western data, you will start emphasizing non-vegetarian. So I'll again remind people I'm from the city of Ahmedabad, where I've done Jain keto. So they don't even eat onions, garlic, and we have managed and got more levels of ketosis in the vegetarian diet versus the non-vegetarian diet. So that's something very important to keep in mind. Now, as far as gut dysbiosis goes, where I showed the slide with, the data is just, I wouldn't say it's upcoming anymore, and several international guidelines last year. I was part of one such guideline looking at different diets and how does it impact insulin resistance and thereby the metabolic syndrome and CV risk. So one of the pathways wherein I showed vegetarian and vegan is doing better than non-vegetarian diets to reduce CV risk, is the gut microbiota. It all boils down to what is inside our gut is we like to think, but then next year, as you very well know, Dr. Bajaj, we may talk about something else. So everything with a grain of salt. So no, certainly the meat protein, animal protein has been shown to impact all of these factors of insulin resistance. So I would say they cause gut dysbiosis. But as I mentioned to you, we have found in our data and our work that there is a better results with vegetarian ketogenic diet because we focus on good sources of fat. So we don't want them to use trans fats and saturated fats. In fact, we want them to use this atta, which is made of super seeds or almonds. We want them to use more of olive oil, nuts, and those kind of things. And really the emphasis on green leafy vegetables so that the carbs are also kept low from the vegetable point of view. And we are using that as much more of a dietary approach. So yes, that's a great point that eating meat is not mandatory to do ketogenic diet. Yes.
Thank you so much, ma'am. Just another question because of paucity of time. This is from Pratyasha Agrawal. How long can keto diet be continued for diabetes and obese patients? And how many weeks are needed to see observable change in weight and diabetes control?
So that's a great question again, and as I mentioned, since we don't have long-term data, what we practice in our clinic is we do a cyclical ketogenic diet. So for generally speaking, we'll ask the patients to do, when we start ketosis, it takes them about, depending on the body size and the stores of carbohydrate, it will take an individual about 3 to 4 days maybe to exhaust their carbohydrate stores and go into ketosis. And therefore, after that, they should at least stay on the keto diet for 10 to 14 days to improve fat burning. So what we generally do is we'll put them into ketosis and keep them there for 2 to 3 weeks. Then we bring them out of it for say 1 to 2 weeks. And then again, we repeat the cycle. So it's a cyclical ketogenic diet. Now we have data up to in all these studies up to even 12 weeks and 36 weeks and 6-month data as well, where safely ketosis was practiced. But as I mentioned, medicines need to be reduced because their sugar levels are really low. So all of that has to be kept in mind. And I apologize, I'm not wearing the same dress as my recording because I just came from a Women's Day run. So I had to be leading it. That's the reason why. So
thank you so much, ma'am. It was wonderful.
Can I ask a question?
If the moderator allows, yes, of course, I'm willing to answer.
Yes, ma'am.
I just wanted to know whether there are any ill effects of keto diet, any cardiovascular.
I kind of just showed them in a con is that we don't have long-term data. We can classify them as into the short-term effects and certain long-term effects. So in the short term, the patients, when they are doing it for the first time, they might feel a slight headache because the sugar levels are low. Sometimes we have sensors on most of our diabetic patients and the sugars can be as low as 45. So there is some panic factor and we have to tell them your body is using fat as a source of energy. So ketogenic flu, ketogenic headaches are common in the initial part. We need to make sure that they are drinking plenty of water because the ketones are being excreted in the urine. So they don't want to get dehydrated. Number 3 in the long run is definitely if you don't reduce medicine, significant hypoglycemia should be avoided. And number 4 is there are some concerns for if you don't replace vitamin D, calcium for bone loss. If the patient has underlying kidney insufficiency, of course, you want to stay away from that if the GFR is already low. So otherwise, there can be damage at the level of the kidney also. So those are some of the broad, but as I said, there are no long-term data. To me, the longest term data is on babies who had epilepsy. And if it was safe for them, if it is practiced in the right way, just in mild ketosis, we should be pretty safe.
Thank you so much, ma'am.
Thank you. I'll stick around to listen to Cheryl and I.
Thank you, ma'am. So I'd like to welcome the next speaker, Dr. Cheryl Sales. Madam is the founder of Nurture Health Solutions Mumbai. She has a rich experience with 16 years career in field of nutrition and metabolic disorders. She has authored the Family Guide for Mumbai and 7 other books, which includes a book on carb counting. She works closely with type 1 diabetes patients and has special interest in carb counting. She features as an expert nutritionist on the TV show Health Magazine. So over to you, ma'am.
Hi, thank you so much. I'll just correct. I think the CV that was shown was the older CV. I have 22 years experience in this field. So just to correct that, yeah. So I am going to share my screen and At the outset, I'd like to thank Dr. Unni, Dr. Savita, and the entire team of CDI for this kind invitation. It's always a pleasure and honor being here, and it's truly an academic feast. So my topic is meal replacement therapy in diabetes, and I'm also going to touch upon diabetes remission, but to talk about the broader topic of diabetes. And though we're doing so much of awareness programs and there are so many conferences, we still face the burden of a rising tsunami in the number of people with diabetes in the world, and more so in India. And we are also aware from the ICMR India study that the number of people with uncontrolled diabetes is also very high, with the average A1C being around 8 to 9%. And again, the biggest problem in India is we're a carb-loving country. We eat around 65 to 70% of our calories coming from carbs, and we are mostly in the postprandial hyperglycemic state. And definitely we know that higher dietary carbohydrate consumption is associated with higher postprandial PG values. And Dr. Rucha very nicely elucidated on this fact that yes, we need to cut carbs, and we definitely need to monitor the person, and under strict medical supervision, when a low carbohydrate diet is done, it really works well for people with diabetes as well as obesity. Now, what are the challenges? Now, when we take dietary recalls of individuals and we try and understand that why are they not able to actually achieve their desired HbA1c level, or how can we prevent them from getting diabetes if they're in the pre-diabetes stage? And what really comes out very clearly is time restraints. Today, I think even in the pandemic period, we have people working long hours. In fact, yesterday I was consulting a young 25-year-old boy who's got obesity, 150 kilos, and he was telling me he works in investment banking, starts work at 10 in the morning and finishes work at 2 in the morning. So there's inadequate sleep, late sitting hours, and obviously access to a lot of unhealthy food because he's been ordering on the through the delivery chains. No access to healthy food. Evening is the time, I think, which is the most difficult time, because that's when most of the unhealthy snacking happens. No portion control, calorie-laden food. And again, there's a perception, and I'm sure my dietitian colleagues will agree with me, that people think that if it's diet, I can eat unlimited amounts. And that is when we see that people, they choose a packet of biscuits just because it's ragi biscuits or oats biscuit or a multigrain chuda and eat the entire packet, not realizing that, yes, it is still carb-rich, it is still having calories, and that is definitely going to impact not only my weight, but also my blood glucose levels. Again, there's a perception that diet food is boring, it's not palatable, and that is why we have people who go, before they consult us, they'll have a vada pav or a samosa, or they'll go for a buffet and then come to us because they think that now they have to be on this very, very restricted diet where it's going to be very, very dull and very, very boring. Now let's look at meal replacement. MRs offer meal replacements offer a structured pre-measured amount. So what actually helps, because when we're looking at putting people on a calorie restricted diet, we definitely want to ensure that they're having the right amount of calories, because calorie deficit will result in weight loss. And definitely we are also looking at the macronutrient distribution in terms of lowering the carbs. And that's where meal replacers really play a huge role, because there's a pre-measured amount of food with specific calorie and nutrient needs. In fact, if we looked, I think Meenakshi shared that with us this morning, that we're really concerned about the malnutrition in the country and the rising cases of anemia in the country, in spite of so much of awareness, because people are going on to extreme diets. And like Dr. Rucha showed, that yes, if done under good medical supervision, giving the right amount of good quality fats, ketogenic diets work well. But what we're really concerned as the nutrition and the doctor fraternity is when people do it just off the net, and they go on to these kind of fad diets, so to say, and they really restrict themselves of good quality nutrients. And that is where we see nutrition deficiency rising in. Again, there's an elimination to need to measure, weigh, or estimate portion sizes. It aims at controlling portions because it's very simple. If we tell them, okay, this is the amount that you need to consume, mix it with water or milk, and you consume this, we are rest assured that they're taking the right amount of calories, carbohydrates, protein, as well as the essential micronutrients. It also helps in lower caloric intake, providing nutrient density and aiding in weight loss. It limits unhealthy food selection. I think this is most crucial, because sometimes when people are traveling, they find it very difficult to have access to good food, or if we are in long meetings, and especially when we, consulting people in corporates, they say that meetings, they'll order a samosa or they'll order biscuits, and therefore there is no access to healthy food. And actually there's no acceptance. Everybody wants to talk healthy, but when healthy is served, they don't really find it appealing. And that's where this really works well, because if you have no access, meal replacers become a very, very good, handy option. For quick weight loss before and after surgery, especially bariatric surgery or a knee replacement, where we want them to lose some amount of weight before surgery, it really comes of use. It's convenient, quick, easy to make and carry, especially for people who are living in PG accommodations or in hostels where the access to food is again very limited. No pre-preparation and no cleanup required. So I think this really helps, especially when you do not have those kind of resources. It's easy to prepare, easy to carry, balanced, portion control, low calories, nutrient dense, adequate fiber. I think that is the biggest concern that we have, that most of the meals, especially snacks. And today when we take dietary recalls, we also see that dinners are now becoming more and more snacky. Our breakfast is very, very rich in carbs, especially high GI carbs with very little protein and fiber. And that is where this really fits in very well. And it's also easy on the pocket because one serving is around 100 rupees, which I think is okay for a meal. Now, what are the meal replacers? The pre-packaged portion control food products that replace meals or snacks. You have variety of forms. So they're liquid, shakes, powders, you have soups, you have snack bars, and you have chef's table. But most of it is people are looking, I think this is something that the meal replacement companies can take as a feedback, is people still want to eat meals. So we could have some kind of a meal as a meal replacer that would really work well. I know a company who actually introduced that, but they really didn't find too much of success. Various combinations of all the three macronutrients, whether it's carbohydrate, protein, and fat, and very, very important, all the essential micronutrients which are important. And most are vitamin and mineral fortified and designed to provide balanced, low calorie, low fat diet when combined with more meals or snack. Now, what does the Codex or the FOA guidelines actually ask when it's a meal replacer? So there are very set guidelines in place that the meal replacer should give you at least 200 calories, but not more than 400 kilocalories per meal. It should have at least 10 to 15 grams of protein per serving. And this is extremely important because we are trying to give protein at every meal. And protein is definitely a nutrient of concern, especially in our country. Less than 30% of total fat energy coming from fat, a minimum of 3% of linoleic acid, and very, very important is no hydrogenated vegetable oil. Because if you look at most of the packaged foods, whether it's biscuits or it's your chuda, which is available commercially, they will all have saturated fats or hydrogenated vegetable oil, including the khandvi and the dhokla that is sold, and we so love it. I have a client who actually supplies khandvi and dhokla to all of Mumbai, and she tells me that they use hydrogenated fat just because of the cost and because it has no set kind of a flavor or taste. Less than 10 grams of sugar per serving, free of high fructose corn syrup. And this is extremely important because again, most of our packaged foods, whether it's cereals or whether it's your juices, even if they call it fresh juices, they are having high fructose corn syrup. And we know the role of high fructose corn syrup in increasing triglycerides as well as uric acid. What is also important is that it should provide you adequate fiber, inulin, FOS, fenugreek fiber, and pectin, etc. Vitamins and mineral fortified. It should have no preservatives, artificial colors or flavors, and it could also include bioactive compounds such as Garcinia cambogia, green tea, etc. Now let's see what the guidelines say. So when it comes to RSSDI, the 2020 guidelines say that meal plans with strategic meal replacements, whether it's partial or full meal replacements, which I'm going to speak about in the slides to follow, may be an option under supervision when feasible. Now, what does the American Diabetes Association guidelines say? That if you're looking at achieving a weight loss of more than 5% for short-term interventions with low-calorie diets or very low-calorie diets of less than 800 kilocalorie a day, meal replacements can be prescribed. Again, very important is for carefully selected patients. And therefore, whenever we do this, it has to be under strict medical supervision, working in a multidisciplinary team where the physician, the dietitian, a psychologist all work together with this person who's trying to achieve his health goals. The Canadian Diabetes Association also says that weight loss programs for people with diabetes may use partial meal replacement plans. Now let's look at evidence, because evidence is very, very important. Now we all know about the twin cycle hypothesis, where positive calorie balance will increase your liver fat, increase your triglycerides, increase fat, as well as predispose you to insulin resistance causing diabetes. Now when there is a negative calorie balance, so just by reversing the cycle and creating a calorie deficit, we're able to see reduction in liver fat as well as pancreatic fat, thereby reducing insulin resistance, increasing insulin secretion, and in early stages, we are also able to bring diabetes into remission. Now let's look at what is the low calorie diet. So when do we say it's a low calorie diet? When the diet provides you around 1000 to 1500 kilocalories a day, it's a low calorie diet. And a very low calorie diet is what provides you less than 800 kilocalories a day. Now, when we take dietary recalls, we see that the calorie consumption is sometimes even 2000 to 2500 calories, because there's a lot of unhealthy eating, especially a lot of high, foods which are high in simple sugars, refined carbs, as well as saturated fat. Again, a VLCD protocol is where a meal replacement plan will really work well, especially when it is done for a short period of around 12 to 16 weeks, followed by structured solid food reintroduction for weight loss maintenance. Because as we discussed yesterday in my talk, weight loss is easy, maintenance of weight loss is a challenge. And this is something that will help us keep diabetes in control or in remission. Again, we know that VLCD, a weight loss of 15 kgs or greater, can be achieved, and maintenance of weight loss is the main driver and predictor of remission. And therefore, it is definitely weight loss that we are looking at. Now, these are some of the studies, and there is a study. This was an interesting study again, which showed that when you actually have people going through either a lifestyle education intervention or you put them on a meal replacement fared better in terms of lowering your glycated hemoglobin levels, fasting insulin, your insulin resistance went down compared to when it was only lifestyle intervention below. And also that the glycemic benefits at 12 weeks was much higher. Now, this is something, I think this is a study which all of us are aware, which is the Look Ahead trial, which again had people randomly divided into two groups, which is the intensive lifestyle intervention group, which is using meal replacers, and the other group, which was the diabetes support and education group. And again, in the ILI group, depending on the weight, which is below 114 kgs, they were put on a 1200 to 1500 kilocalorie diet, and more than 114 kgs, they were put on a 1500 to 1800 kilocalorie diet. Less than 30% of calories coming from fat, and less than 10% of calories coming from saturated fat. Again, in the first phase, that is month 1 to month 6, they replaced 2 meals and 1 snack daily with replacement. And in the phase 2, that is from 7 months onwards, 1 meal per day was to be replaced by a meal replacement shake. And then you saw that you tried to put the person on a 500 kilocalorie reduction diet. So therefore, if you see that the people in the ILI group had actually significantly better HbA1c levels compared to the DSC group. The Y-weight study also had similar findings, where they showed that yes, 82% of participants on the MR group actually achieved better HbA1c and less than 7% on lesser diabetes medication. So definitely MR or meal replacement group fares better. Again, this is a study which was done in Chelaram itself by Dr. Anjali Bhatt and team, where they put 12 people with type 2 diabetes, and they received a low-calorie diet of 1000 calories, again on meal replacements for 12 weeks. And they saw that 50% of this population actually were able to bring diabetes into remission. The OptiFast study again showed that with meal replacement, we saw better improvements in fasting blood glucose weight loss, and also that the rate of patients achieving weight loss or able to maintain weight loss was higher in the group receiving meal replacements. Now let's look at diabetes remission. Now this is again the counterpoint study, where they actually saw that in 11, they had 11 people with type 2 diabetes, and controls matched for weight, age, and sex. On a very low energy liquid diet, they were able to actually achieve 15% of weight loss of the initial body weight, and HbA1c also decreased from 7.4 to 6%. There was decreased hepatic and pancreatic triacylglycerol content, has also increased first phase of insulin secretion. Now, this is a direct trial, and I think all of us know about it, that when they actually put people on a meal replacement diet, they achieved 15 kilos of weight loss. Also, the mean HbA1c fell by 0.9% in the intervention group. And also what was really, really encouraging to see was that this was maintained even at 24 months, where weight loss of more than 15 kgs was still there in 11%, that is N is equal to 17 in the intervention group, and 36% of remission in the intervention arm, and 3% in the control arm. Now, this is the Diadem study, where 147 adults with type 2 diabetes, less than 3 years of duration, 70 in the intervention arm and 77 in the control arm, where they were put on a 12-week total diet replacement, where 800 to 820 kilocalories per day was provided in the form of meal replacement. And again, at 12 months, they saw 11.98 kg weight loss in the intervention group, and again, 61% remission in the VLCD group, which actually goes to show that yes, VLCD done under strict medical supervision using meal replacements fares much higher in terms of diabetes control, diabetes remission, and also maintaining weight loss. Now, this was an interesting study that I came across, that which meal replacement is better? Is it whey? Is it soya? Or do we give an isoenergetic amount of carbohydrate? And what the study clearly showed was that lean base circumference was smaller in the participants consuming whey protein compared to the other groups which consumed soya protein. So whey protein definitely fares better. Now let's look at, in clinical practice, how do we really use it? So you have two types of meal replacement. One is total meal replacement, and the second is partial meal replacement, where we replace 1 or 2 meals with a meal replacement. So this is what typically we see a diet recall, and we're looking at this case scenario where breakfast, lunch, evening, and dinner are all meals providing you around 2,500 kilocalories. And we want to achieve some kind of calorie reduction. We can do either a complete meal replacement, where we're actually reducing by 1,700 calories and putting them on a VLCD diet of 800 kilocalories for a short term under strict medical supervision, or we have 2 meal replacements where we can replace the breakfast and the dinner with a meal replacer, give a mid-morning snack of fruit, an evening snack of fruit and nuts, and a good lunch. Again, here we're able to bring down the calories by 1,200 and keep the calories to 1,300, still achieving weight loss and improved blood glucose control. Now, this is, as we mentioned, and I'm sure all my dietitian colleagues will agree with me, that when we take dietary recalls, the biggest culprit is evening snack. And again, there is no access to healthy eating and evening, and that is where we see that replacing that evening snack with a meal replacer really works well. We in fact tell people to carry it maybe on their way back from work. They can just mix the meal replacer with either water or milk and then consume it. So this is where partial meal replacement comes into play, and we see the acceptance for this is also really very good. So therefore, you can replace the evening snack. And again, the evening snack is very high in simple carbs as well as sodium and also your fats. If we can replace that meal with a meal replacer, we're able to reduce the calories, but we're also able to improve the quality of nutrients that we are providing to the person. So instead of giving them, meals which are very high in carbs, especially refined carbs, and no protein, we're able to add protein to that evening snack. And, that is itself a very good thing. Now, this is something that we did in our clinic with our people with diabetes, and we actually saw that there was an improvement in the post-meal blood glucose reading by just replacing the snack with the meal replacer. And therefore, again, if you see with makhana, yes, the post-meal glucose response was good, but on the other snacks, it really went high. But then if you could replace that either with meal replacer with water or using the meal replacer with milk, we definitely saw much better postprandial blood glucose levels. Now, who cannot or who should we not prescribe a meal replacer to? Pregnant or breastfeeding women, teenagers and children. I think above the age of 10, it's fine under strict medical supervision, but definitely not below the age of 10. People with liver or kidney problems, people with allergies. Some people may have lactose or gluten intolerance. We ask them to read the food label to see whether it is gluten-free or lactose-free. For people with diabetes, again, like Dr. Ruchak clearly said that yes, it has to be done under strict medical supervision, and we definitely will need to reduce the amount of insulin or the drugs, especially if they have type 1 diabetes and they choose to go on a meal replacer, then definitely they need to reduce the amount of insulin. Or for people on drugs, on sulfonylureas or any other kind of drugs which reduce the blood glucose levels, we definitely need revision. Changes in body fat and other variables will again depend. So it's not only adding a meal replacer, but we have to also look at the quantity as well as the quality of calories that we're giving at the other part of the day if we're doing partial meal replacement. And it always has to be done under supervision of a qualified dietitian or a doctor. Because today you have a lot of people, you go to these jogging parks in the morning, they do your body composition, and then they put you on to some kind of a meal replacer, and then people go on to that. And once they stop it, we see that the weight all coming back because there is no medical supervision, there is no follow-up with the person, and therefore it really does not work in the long run. In fact, we see a lot of ill effects of such kind of meal replacement strategies. So comprehensive supervised treatment approach involving a meal replacement diet, behavior modification, nutrition education, definitely emphasizing on physical activity, because this is most important, especially if you want to keep the weight loss maintained. And I think diabetes remission is very important. For that, you will definitely need to bring about good lifestyle behaviors along with a healthy diet, physical activity, and most importantly is also looking at sleep and compliance to treatment. And therefore, it is an effective non-surgical intervention in weight management, achieving glycemic control and diabetes remission using VLCD. Thank you so much for your patient hearing. I'll be happy to answer any questions if you have.
Thank you, ma'am. I think we can have one or two questions. Ma'am, this is your corrected CV. Sorry for the last one.
Thank you.
Thank you so much, Cheryl. It was an amazing session.
Can we have one question? There's a question.
Yes, there's a question. There's a question from Dr. Manjul Patwardhan. The narrow window of 8 hours in intermittent fasting should remain constant every day. How much emphasis do you give for keeping the window constant at the same time? I'm sorry, I think this is a question to the previous speaker.
Yeah, maybe I can just answer that. In fact,
Yes,
we did
sure,
a
sure.
study, in our clinic actually, with 32 participants, and we saw very good improvement in waist circumference, weight loss, and also that a lot of people said that initially it was difficult. So therefore, we do not really start with 16 hours of fasting. We step it up very gradually, and then we see how comfortable is the person. So we started out with maybe 10 hours of fasting, stepping it up to 12, 14, and 16, and then we keep it to that. And like Dr. Rucha said, there are many ways of intermittent fasting. You also have a 5-2 diet, where 5 days you eat what you eat normally, and 2 days is where you try and restrict the feeding window. In fact, that is where you actually restrict it to only once a day. So in our study, we really saw good improvements in terms of because we were able to restrict calories. Again, very, very important, like what Dr. Rucha said, is we definitely need to do, because otherwise we see intermittent fasting done by people, just because they've listened to some talk or they're on social media seeing somebody else do it, and they actually accumulate all the food of the day and eat it at one time. Sometimes we have our clients actually wake up at 1 in the morning because they're doing fasting till 12. So, they're sleeping through the night and the day just because they want to wake up and only be there during the feeding period. So that is not the right way to actually do it. So therefore, doing it under careful medical supervision is very important. Still looking at the quality of calories and calorie restriction, because we have to be able to try and get in calorie restriction. So that is key. So then you can decide what you want to do. It is not really necessary to do like 16 hours, whatever the person is comfortable with.
So is the meal replacement also done stepwise, like you said, for intermittent fasting, or is it replaced all through?
I think that's a very good question. In fact, yesterday I was having a long discussion with Dr. Mehta on this, and we were discussing about meal replacement. And I'm sure Meenakshi again will agree with me that putting them onto complete meal replacement is not always easy, because people still want to eat food. And especially when they come to a dietitian, I think they expect us to give them food and not really like, a shake. So what we see really works well is partial meal replacement to begin with. But yes, if somebody is really motivated and wants to really, improve, because, suddenly they get a shock that, oh, now I have diabetes. My HbA1c is really high. And doctor has told them, okay, you have this window now where you can actually bring diabetes into remission. And that is where we see that this person is so motivated that he's ready to give it his all. And especially if he does not have resources, like if he doesn't have, a resource to make food for him at home or try and get healthy food or, try and control the calories, that's where meal replacement really works well. We also have to look at the cost. We have to look at other factors. And therefore, careful selection of the candidate becomes extremely important. But yes, intermittent fasting with the meal replacement, like I showed, I use it a lot at either breakfast or at snack time, evening snack. And that's where I see it really working well, because it's got fiber, it's got proteins, it gives you satiety, and you actually end up eating lesser at dinner, because otherwise people are so ravenous by dinner time because they've skipped that evening snack. And that is where most of the calories are consumed, and they sleep immediately post dinner, leading to weight gain. And obviously that is going to impact their insulin resistance and diabetes.
There's one more question. It says any common meal replacement. I think it means a common meal replacement for all of the types
I
of
have to take
patients
a
that we
brand
have.
name, and I don't think I will take a brand name.
No, I think it means whether we have a common meal replacement for all types of patients that we have, be it the young ones or the older diabetics. I think the question actually is.
So we definitely look at the meal replacers that we are prescribing. Like I said, suppose somebody's got lactose intolerance, then there would be some which would be suitable. Suppose somebody has gluten intolerance, and we have to look at it. And therefore, as I said, it has to be done in consultation with a qualified dietitian, because then we are able to select the right ones for them. Like I said, when you go to a jogger's park, I'm not going to take the brand name, but that people just automatically go on to a meal replacement. They go on some kind of a detox tea, and they do it, and they're very motivated initially, but the moment they stop doing it, we say that they've actually regained most of the weight, because weight loss is not a challenge. It's always maintenance of lost weight, and that is where a qualified dietitian's role comes, because we will definitely we'll also give them a maintenance plan. So after having put them on a VLCD diet for a short period of time, we will definitely try and put them on a maintenance plan, and then follow up with them on a timely basis, because we really do not want them to lose, regain the weight. And I always feel very sorry when I see my clients who've gained all the weight that they've lost. It's my failure. Honestly, it is my failure, because I have not really, maybe educated them well. So that is the biggest grief that we have.
Thank you, ma'am. We have a few more questions waiting, but I think we can take them at the end of the session. First, just to speakers to be with us for the discussion as well.
Sure.
So, I would like to welcome our next speaker, Dr. Geeta Dharmati. Madam is the Chief Nutrigenomic Counselor of Gene Support. She holds a master's degree in clinical nutrition and dietetics from Nagpur University, where she won the gold medal for topping her MSc examination. She holds a doctoral degree in this field. She is registered dietitian and topped the special RD examination by IDA board in 2012. She also serves as director of Geeta NutriHeal, a nutrition service consultancy, and is an executive member of the Indian Diabetic Association. Her areas of expertise include critical care, bariatric, nutrigenomics, wellness, and lifestyle management. Welcome, ma'am. She'll be speaking about vegetarian and vegan protein-rich diets in diabetes reversal.
Welcome all. Hello and namaskar. Thank you very much at the outset to CDI. This international summit organizes Dr. Unni Krishnan sir to have given me an opportunity to be amongst you to talk about the support application of nutrition in diabetes management. I have been given topic of practical application to talk about nutrition, to talk about the application of diets in our daily practice. And I think this is a wonderful way to connect, because it helps us to see, understand how I can improve my patient's nutrition or a diet and the challenges behind the scene. So the topic today is obesity management in vegetarians. I feel Indians are definitely vegetarians, even if you say I eat non-vegetarian. Why? Because we eat non-veg as an occasion. We eat when we go out, we eat 1 to 2 times a week or once in fortnights, except for a few cultural practices where non-veg is regularly eaten as their daily meals, like fish in their diet is a must. Then I think we can call them non-veg, because they contribute to 20 to 30 grams of protein daily. But if it comes once a week as an outside food, I think we all come into the category of vegetarians. And with this ketos and importance of proteins going all the way around, what a challenge to handle cases like obesity, diabetes. And let's understand how we can really work on it. I have taken 2 cases here, and I hope to make you understand or invite questions from you to deliberate on what else can be done on these cases. Let's take the first case. It's a typical case of metabolic syndrome, where we have a 40 years old male with a BMI of 32, With dyslipidemia.
Can I interrupt?
Yeah, hypertensive.
Can we stop screen sharing, ma'am?
The challenge. This is yesterday's session. Can we have today's session, recorded today's session, put it up? I think the RX events, the technical team can do the needful.
Yes, ma'am. We are just doing the needful. We'll have your today's talk on board.
Nishad, can we have today's session?
Yes, ma'am.
Ma'am, give me a moment, please. I'm checking.
In the meantime, we can pick up a few questions by the time they are ready. There are a couple of
I think
questions.
Rucha ma'am and Cheryl are also online, so they can also contribute. They can put on the video and talk till the session starts.
Cheryl, I had a query. Two things. One is, one of the queries was that when you consume pea protein, there's a lot of bloating and flatulence. And the second thing is, have you encountered constipation in those patients who are on full meal replacers?
I think that's a very, very good and pertinent question, Meenakshi, because yes, I think what is really important is that you can give them, some vegetables along with it. So we do give them vegetables in between, or maybe a fruit with, so that they get some amount of fiber. And also that we know that when we increase protein, we also have to step it up slowly. And also we have to make sure that the person is hydrated well, especially when it comes to fiber. I think this is something that people forget. They will only increase the protein and fiber, but not really work on the hydration. So these are important things. And again, I always tell people that when you're stepping up protein, because they see there's a gap and then they suddenly start, try and meeting that gap by increasing a lot of protein. So that also has to be stepped up gradually, which we definitely do in our clinical practice. And we encourage them to have vegetables so that they get enough fiber. And again, it's very low on calories, but it'll also give them additional nutrients, especially the micronutrients.
Your comment on remission and meal replacers?
I think there is so much of evidence to talk about VLCD using meal replacements, like I showed in my presentation. But also very important is also that, when we're talking about remission, and I'm sure Dr. Rucha will agree with me, that today it's become like a business. Everybody's talking reversal, and you have so many companies which are promising reversal. And honestly, we have so many people come to us saying that they've paid a really big amount of money and they signed in for it, but they actually did not get the service, and they were not able to bring their diabetes into control. So you do have positive feedback. Yes, we do see those testimonials, but I think what is really important is, to select the candidate properly, that we know that not everybody can reverse diabetes, not somebody with 20 years of diabetes, uncontrolled on insulin with their beta cells completely exhausted. You can't look at remission there. So we have to be very realistic. So careful selection is important. And also I think reversal is a very tall claim. We are talking about remission. I know people use reversal because somebody told me it is very popular, that is something which attracts people. So that is why they use reversal. But I think re-reversal can happen. And this is something that we need to tell them, that if you go back to your old eating habits, you're going to go back to your old lifestyle, it's definitely going to come back and there's going to be a relapse. So therefore, we're talking about remission. And I think the messaging that we need to give as qualified professionals is very important. And though we know that there is so much of information on social media, people are talking about it, I think we also can use social media in a very positive way by giving the right kind of information, which I think all of us have been doing.
Thank you, Cheryl. Ma'am, a query to Rucha, ma'am. Ma'am? Ma'am, we can't hear you. Yeah. Okay. Ma'am, your comment on athletic triad, when somebody is put on very low carb diet, like as low as 30 to 50 grams, have you seen any patient like that? Because in South, we have seen one or two of them who have, had a hormonal imbalance and ultimately menopause. So have you seen something like that in your practice?
What was your question? Very low carb, and I couldn't hear you.
Ma'am, athletic triad. Athletic triad, when you go in for a very low carb, so there is menopause.
I'm not familiar with what the epileptic, not understanding what the epileptic triad is.
Athletic triad, ma'am.
Athletic. Okay, sorry. I'm just hearing epileptic triad and I'm like, oh my God, I've never heard of this. Okay. Yeah, so certainly. So I think the athletic triad started from understanding our younger girls who were our athletes, and mainly it came from the gymnasts who were working out very high. And certainly that is considered as a stress on the body in terms of the FSH, LH, wherein they have a hypothalamic amenorrhea. So that is your athletic triad, and which was just like the Virchow's triad, reverse the minute you give them food. It did take some time for the periods to come back. So in any diet, it doesn't matter if it's ketogenic or if it's any very low calorie meal replacer trial, whatever you're using, if you're going to induce this for a long time, it's going to be just like exercising. The athletic triad was more with exercise. You don't want to induce that with diet either. Because as similarly for the intermittent fasting, as someone asked, if it's stressful, you're going to increase cortisol, and therefore you're going to negate all the effects that you want to get by fasting. There are certain theories, and we have looked at as to when does fasting induce ketosis. So it takes at least 10 to 12 hours for all the food to get digested, and by the time you go into ketosis. So you certainly need to do that, because that's the mechanism by which it works also. So we have a lot of patients that we put on ketogenic diets. As I said, we practice cyclical ketogenic diet, so we don't do long-term unsupervised keto. So we have not gotten into that problem. I think you will see that much more with the very low calorie diet, 600, 800 calorie diet. So we do have patients who do that on their own, and because they want to lose the weight very rapidly, and it's not advisable in the long term for sure.
I just want to make a comment on ketogenic. I think again, like what Dr. Rucha does, and that's why I'm very convinced. Like when I talk about ketogenic now, I talk with conviction because I know Dr. Rucha does it and so scientifically and gets good results. So therefore it has to be really monitored. But what we've seen is when people do it on their own, I have a lot of friends who are doing the ketogenic diet, and what I see with them is they go on a binge. So they'll do the ketogenic diet, and then, they are completely off carbs. And then they go on the other extreme, where they've actually, deprived themselves of the carbs and the sugar, that they go on the other extreme and start consuming a lot of sugar and high carb foods. And then they gain all the weight that they've lost. So we see a weight cycling happening. And I think that is why we, like Dr. Rucha said, I totally agree with her. We have to carefully select our candidates and know that, okay, this is not going to cause them stress, because then it's not worth it. They have to enjoy life and doing anything. I think that is most important.
Thank you so much, Cheryl. I think the video is ready.
Yeah, thank you.
Yeah.
Hello, everyone. At the outset, I would like to thank CDI, Chelaram Diabetic Institute, to have given me this opportunity to connect with you all to talk about today's topic, which is vegetarian and vegan protein-rich diets in diabetes reversal. I understand when we talk about diabetes, obesity, non-communicable diseases, nutrition, diet is a very integral part of the same. And with this pandemic and communicable diseases in picture, I think we are not very seriously for these 2-3 years thinking about these NCDs. But of course, with this kind of Congress, our attention is again coming back to these areas where we need to update, upgrade, and understand how we can improvise our own lifestyle, our own nutrition, our own nutrient composition of our food, so that we have a better management of all these non-communicable diseases. And the topic given to me is so important to understand in a country like India, and where the culture of vegetarian diet, vegan diet is really growing fast. So does it have a real contribution? Will it impact the diabetic health, or does it have a part in improving your nutrition? Or let's understand what it is all about, because diabetes is definitely gaining a status of potential epidemic in India, and all of us know about it. And this Congress, I think all the speakers, all the experts here are here to understand and deliberate on techniques, ways, evidence-based science to help us understand the management better. In nutrition area, when we come to diabetes reversal management, A recent paper in 2019 in Nutrients spoke about the evidence which exists in type 2 diabetes reversal, or we can say remission. It spoke about the bariatric surgery, it spoke about the low-calorie diets and the carbohydrate restriction to help us to work on diabetes remission. So if we have an option to understand the remission of diabetes to nutrition, I think education on nutrition, calorie counting, protein, macronutrient management are the techniques which may help us to have a better diabetes remission. Because if you look at the overall scenario of our nutrition or of our health status, the major challenge is the calorie intake. Excess calorie intake, positive energy balance always gives a tendency of ourselves to adipogenesis. And this adipogenesis, we all know, contributes to adipocyte inflammation and leading to insulin resistance. Definitely, with this kind of adipogenesis, increased fats in our body, we have increased free fatty acids, we have reduced adiponectin, increased leptin, higher demand of insulin. And definitely all the markers of inflammatory response like cytokines, IL-6, chemokines, all those are on a higher side. On the other side, if you have a pancreatic beta cells, which are having inflammation contributed through the adipogenesis, we know there's a lot of oxidative stress. We know there's a lot of islet inflammation and dysfunction. And that gives us another side of this type 2 diabetes, which is insulin insufficiency. So overall, we all know that the calorie management behind the scene can be responsible for the cellular chaos of the body. So here we are to talk about the role of vegan and vegetarian diets in remission of diabetes. So there's a paper which took almost around 60,000 subjects enrollment and divided into different type of diet. And it was found that, as the slide shows, the vegans, the subjects were around 2,731, had just 2.9% of diabetes type 2 prevalence. Then came lacto-ovo-vegetarians. Subject size was quite high, 20,000, 3.2%. So you can see the decreasing trend of the type 2 diabetes incidence when it comes to more of plant-based diet. So we have to understand how a vegetarian diet in a pro and con helps us to have a better diabetes remission. So when we talk about vegetarian diet or a plant-based diet, the best source of proteins are legumes, pulses, etc. So we will little deliberate more on how they really help us so that we understand in a nutshell a plant-based approach at a cellular stage. So with increased consumption of the pulses or legumes, you have three areas of action by them. One is on insulin sensitivity, larger tissues, and target tissues. So if you eat a processed pulse, when I say processed, it is either sprouted, malted, powdered, which is more easy to digest and have more bioavailable amino acids and other nutrients. So when you have a good processed pulse, soak, sprout, etc., definitely it creates an impact on insulin sensitivity by acting on skeletal muscles, the uptake of amino acids, especially the leucine and the lysine, which is high in pulses, will help us to improve the GLUT4. And on the adipose tissue, which decreases the PPAR gamma and increases the GLUT4. Overall, it means good amino acids uptake by skeletal muscles, and decreased adipogenesis. At the second level, which I'm speaking, is the larger tissues. Again, with this increase of muscle glycogen action, we definitely have a good benefit on decreased adipogenesis and hence a good insulin resistance. At the gut level, we'll have good gut flora support and good increased SCFA, which are a very good prebiotic for our gut flora. At the third level, the target tissues, we definitely start looking at decreased adipogenesis and increased gut flora. So the 5 golden rules in diabetic remission is definitely the first one is work on ideal body weight, work on macronutrients, and lastly, the distribution of macronutrients, which needs to be balanced. And hence, we need a dietitian to help us. We need a medical nutrition therapist to help us to work on these principles of nutrition management. And as we are talking today about vegetarian diet or vegan diet, protein is a very integral part of this management. And in the macro contribution of protein, we look at least 15 to 20% of protein management. But the theories of giving protein to 1.5 to 2 gram per kg body weight, which was suggested for weight management and type 2 diabetes, can be thought over in a country like India because protein also contributes to inflammation. Our current ICMR or RDA guidelines say 0.8 to 1 gram per kg body weight, 15 to 20% of proteins of the macros can be an adequate amount of protein contribution. And if you want your diet to be vegetarian, vegan, you can look at balancing with significant amount of macros, the servings which are contributing. So you have to start looking out complementing amino acids for the best profile of essential amino acids. And hence, going ahead, we will talk about the same. What's important, friends, is to understand the contribution of the amino acids, especially the essential amino acids. And if you can see from this table, the essential amino acid, where the contribution of leucine is 39 milligram per kg per day. Contribution of lysine is 30 milligram per kg per day. So in a complete amino acid profile, you have a leucine-lysine, which is contributing to a maximum amino acid profile. Then you have your phenylalanine and tyrosine. Then you have your branch chain amino acids, where you have isoleucine, leucine was already a part, isoleucine and valine. So if you look at the profile of amino acid, and we know that leucine, lysine contributes to the maximum amino acid profile. And what's important now is to understand that how do I build up a good amino acid profile in my diet if I am vegetarian? And what is lacking here to understand is the contribution of key amino acids. And leucine is one of the most studied amino acid, which says that the contribution of leucine is very high in muscle building. And if you look at this picture of the various food which contains leucine in grams, in that particular amount of serving, we will find dairy, which is contributing to the maximum. If you look at the plant foods, you also have a good amount of leucine present in it. 0.6 to 0.7 grams in almost 1.5 cup of the legumes which are cooked. Egg also has 0.5. Friends, to understand, if you have a good quality protein, you will have a balance of all essential amino acids. But if you do not have a good quality protein and you're struggling to understand that I want to eat vegetarian or vegan and I want to maintain the good quality protein, then the contribution of those particular foods which contribute to the maximum content of amino acid should not be ignored. Plant-based food has its own advantages in contribution to fibers, antioxidants, bioflavonoids, and definitely minimizing your calorie intake. Because the key in working towards diabetes remission is lifestyle and calorie control. And if I am able to work on all this with the help of vegan or a vegetarian diet, I think we can have a better understanding of amino acid profile by complementing the food so I get the best of it. So we know in an Indian culture, we always eat rice dal, we eat khichdi, we eat idli sambar. The combination of our diets are based according to the nutrition factor also is what I assume. In a current scenario of eating roti sabji as one dish meals is a wrong way. A thali, if you see, is a contribution of the fiber, the proteins, the lentils, and the curd, the dairy, till the dairy. And I think that gives us the best utilization of good bioavailable source of the nutrients, and especially the amino acids and the micronutrients, which I'm looking for. Now it's a thought that, am I struggling with a quantitative approach towards my nutrients? Am I looking at my RDAs, ADAs, AMDR, or am I looking at the best bioavailable source of nutrients where I have a limited source in my hand, especially food like protein? So now in 2020 guidelines or in recommendations by ICMR, a newer protein quality index, if all of us know, has been proposed. And that is called as DIAAS. In short, indispensable amino acid score. Digestible, indispensable amino acid score. Now this earlier it was PEDICAS, first it was HBV, then PEDICAS, and now we are entering into the world of DIAAS because it is based on true ileal digestibility. Because the whole goal is to understand the contribution of good amino acid profile. And hence, the cereal, legume, and milk consumption in an Indian scenario, which was earlier 11:1:3. I repeat, cereal, legume, milk. It is like eating a dal chawal and a dahi chawal in your meal, where your chawal contributed to 11, your legume contributed to 1, and your dairy contributed to 3. Today is changed to 3:1:2.5. So if you can see the contribution ratio of dairy has improved and the grains have reduced. This is a very significant change because we are here working on EAR, which is 0.66 gram per kg body weight, RDA with 0.8. But I look at it as acceptable range, which is 10:35% of total range. But the total contribution of protein is 15, 20, 8, 12, whatever you can make it up. But the challenge is, can I make it ratio of cereal, legume, milk consumption, which is recommended by ICMR? And hence, again, going back to those units, let us look at a good amino acid profile of leucine, lysine, branch chain amino acids being contributing to the maximum. So leucine we have seen. Now the lysine, if I have to introduce you, I again would say that the lysine content is highest in legumes and animal proteins compared to the cereals. So am I looking at a vegetarian diet which just says roti, bhaji and dal or sprouts? I am looking at complementing my foods with the complete and incomplete proteins, where I would utilize the maximum amount of amino acids, especially, which I have just noticed, leucine, lysine, and BCAAs, with the sulfur-containing amino acids to a balanced format. And if I have to complement, it is the legumes, lentils, which has tryptophan and methionine, which is limiting. I complement it with grain, nuts, and seeds. So moong dal, khichdi, dal, chawal, idli, sambar can be a good source of a complete amino acid profile. And mind you, they are very good in bioavailability because they come to us in a process from they soaked, fermented, they are dried. So these way of cooking, especially the legumes and pulses, makes your proteins, amino acids very well bioavailable, because we know that all protein calculated which I eat is not 100% digested and assimilated by my body. And there are a lot of studies which support plant proteins, if you take it from a supplement source, or if you try to balance it in a complementing ratio, has a good base of nutrition. The digestibility is a challenge. The availability is a challenge. Why not process them and complement them? Why not start looking at one pulse and one rice? Nutritionists, dietitians should start encouraging the base of ethnic and cultural food practices, but make the ratio to the best bioavailable source. Because challenge with Indian diets are we still eat roti ke liye bhaji and chawal pe dal. So the pedicars or the DIASS, which you've just noticed, becomes very, very poor. The amino acids which are needed in more quantity, like lysine and leucine, are not really up to the mark. So train our patients and clients to take a bowl of pulse or dal, add the rice in it. Make the ratio of dal, the rice, as 1:1. 1 dal, half rice. Because dals are liquids. Sprout 1:1. Add a bowl of yogurt or a curd to your diet, to your lunch or meal. So every meal should have a protein. Because there are different sources of protein in India, and the challenge is because of vegetarian diet, because of fiber, because of phytates, the bioavailability becomes a challenge. And let's start utilizing the Indian food to make it the best bioavailable, because if you go back and learn the cooking practices in Indian food, they do make an impact in understanding now the scientific base that yes, those cooking practices of soaking, fermenting, or malting helps us to have a better digestibility. Do vegans and vegetarian diets along with give me another side, which is micronutrient B12, omega-3 iron. Yes, they do. I improve the source, I add lime, I make a lime in my diet. I educate my patient to eat a 4-square meal in every meal. A fiber, a good source of fat, a protein, and a carb is essential to make the best of nutrition. If I teach them 20 grams of protein in each meal, a South Indian meal, for example, a South Indian meal, because I want to add idli sambar in my breakfast. I tell them that eat idli only with sambar, not with chutney. If it is a chila, I process the chilas. It gives me 10 grams of protein. I add a cup of curd, bowl of curd or a cup of milk, it complements. Because 150 ml of milk or dairy gives me 5 grams protein. 2 servings of protein in every meal definitely can contribute to good amount of protein. So friends, to conclude, if I eat variety, if I eat food which comes to my standards of nutrition in my cultural and ethics practice, but getting educated in it, will help me to have a better management of all the kind of lifestyle diseases. The vegan diets can supplement, complement as per the requirement, but should try to understand to make the protein which is present in the diet as best bioavailable source. And count the protein so that they at least form into 12 to 15% of their requirement. If you want to become a vegetarian or a lacto-vegan diet, we need to look at 150 to 300 ml of the dairy, which is contributing to good amino acid profile, because in the DIAASS score, dairy is said to be the best source of amino acid profile. So whatever diet your client, your patient wants to follow, it has its own way. Vegetarian diet, vegan diet, the only challenge is the protein. And if I have been successful in educating you today about the style, the way, the contribution of the amino acids in your protein, the micronutrients bioavailability also is very easy. And the lot of positive sides of vegan and vegetarian where calories, fiber, and antioxidants, phytonutrients, which are lacking in today's scenario, can add on to your diet. Thank you very much for giving this opportunity. I'm eager to understand your questions and answer them. Thank you.
Thank you. Excellent talking.
I think, as always, Dr. Geeta has left no stone unturned, whether it was practice points, going straight to the kitchen and talking to us about how we can achieve the 20 grams of protein per plate was simply amazing. And how you have, really upscaled the knowledge of the gathering today from HBV to moving on to DIASS. So I think it was amazing. I actually don't have questions to ask because I don't think you left anything.
Thank you, Meenakshi. That's wonderful of you to say those words. Thank you. I think previous speakers have also said so much about contribution of nutrition in remission of diabetes. And that says it all, that whatever diet we follow, I think we need to be more educated and balance our own way of looking at the nutrients. That's the goal, I think.
Basically, you've even covered the points as how you can make even the vegetarian sources more bioavailable with the basic traditional diets which we are already consuming. So we don't really need to look at probably even meal replacers when it comes to protein if we want to talk of traditional diets.
I think
unless and until we are lacking out on
pulses and legumes are more blamed for not taking because somebody have acidity, somebody cannot digest, somebody feels that I'm not eating rice, so why should I eat dals? I think that needs to be more emphasis. I think 2018 or 16 we had year of legumes. This year we have year of millets. I think the promotion of these millets and legumes, the problem with them is phytate. The problem with them is anti-nutrients. But these food, which are very easily available, dense source of nutrients, needs to be handled with a good processing, so digestibility and the assimilation and getting the best out of them in today's era where the soil nutrition is also a challenge for us, needs to be highlighted by all our fraternities so that we give the right message to our patients. That's what I
basically, instead of doing a shortcut, we genuinely do the sprouting, fermenting, roasting, and toasting to make all the nutrients bioavailable. As simple as that. No shortcut.
Traditional recipes that we have, I think we have to that is the most important thing, they were so well thought about, even though they didn't study the science of nutrition. But there's so much of science behind each of those traditional recipes. And I think that is something that we need to speak about and talk about, because that is really good bioavailable nutrition.
Yeah, being the year of millets, I think at least down the villages, we see that they actually roast, sprout or ferment them. But in the urban areas, they don't do it. And that's when they are goitrogenic. So that a little issue is there. So I think the best thing is, to go back to our roots and follow the traditions in our preparations.
I think one point I want to just raise, since we're talking about vegan diets, also, as I'm sure as qualified dietitians, we always talk about B12 and iodine deficiency. So again, when people want to do a vegan diet, it's very important that it's done under the supervision of a qualified dietitian, because otherwise we see that they come out with deficiencies of vitamin B12 and iodine. And I think that was very well highlighted by one of the celebrities. I am sure you all must have seen that Instagram post where actually she went on to do a vegan diet and then, went off iodized salt. And then she realized that she's got iodine deficiency. And she actually put out a post saying that please do it responsibly. And, I think that was very good of her, that she also talked about the deficiencies that arise because of this.
I think Dr. Geeta very beautifully highlighted the deficiencies associated with vegan and how we can sort them out.
Absolutely.
I think there are no questions, so we can call it a session.
I'm sorry.
We have questions.
We have questions. I've been listening to this entire session with keen interest. And I would first of all like to congratulate both the previous speakers, Dr. Richa and Mrs. Cheryl Sales. Excellent talks by both of you. What is your opinion? I would ask the entire panel, what is your opinion about almond flour and jackfruit flour, etc.? Each one of you. Dr. Rucha?
Yes, certainly when in the ketogenic diet or even our vegan patients or anybody who wants to can use the almond flour. So certainly one thing to keep in mind, anything that is high fat is always high calorie. So we have to be careful about the caloric intake because eventually remission of diabetes, as we've seen from the direct trial, which used meal replacers, as Cheryl knows very well, and most of us. One of the meals was a meal replacer, and it was a very low caloric diet, 800 calories, when they tried to get these patients to reverse or remit their diabetes. So almond flour, if you're using, it's a low carb option for our patients. You can also mix it half and half. Better than almond flour if it's just a regular diabetic diet we are prescribing. Then I prefer they use flaxseed powder or something simpler, which is a negative carb. Now, lots of flours, not just jackfruit flour, but we have cassava and many such things coming up nowadays, which can be added into your regular, since roti is a staple and it doesn't matter which part of the country you go. We can add these into our, whatever you're using, wheat, jawar, to make it a negative carb. So you can, yeah, it's quite they do work. And in fact, we in Ahmedabad, we do get a flour which has jackfruit flour also in it. So it seems to work well.
And Mrs. Cheryl Sales?
I think one is definitely we have to look at the affordability, the cost, and then prescribe. That is first. And almond flour, yes, but some of these keto rotis, like we have a lot of type 1 kids who want to go off carbs completely because they don't want to take insulin, and we see that the mothers are just adding so much of fiber to that roti. They're adding oat bran and wheat bran and seeds, and what happens is your nutrients going to be available, because we know that fiber will also block the absorption of nutrients. So I think it's very, very important, because they're just looking at it at a very microscopic angle, that they're only looking at not giving insulin and trying to keep the carbs very low. I think that is again extremely important, because they're also seeing anemia resulting out of these kind of diets. So very important is that even when we're talking about fiber and the importance of fiber, you can't overdo anything just because it is good. So that is something that is very, very important. Jackfruit flour, I think Dr. Vinod is here, and we have used it in our practice. In fact, we published a review article on jackfruit flour, and we've seen very good results with jackfruit flour in terms of giving satiety. It's a good prebiotic and also a good source of fiber. And we've definitely seen improvements in the postprandial blood glucose levels. There's improved satiety. That is what most of our people tell us. And it's very easy to incorporate in the diet, because if somebody doesn't want to use it in the roti, just mixing it with curd and consuming it for the meal, it actually helps in achieving better satiety, and people eat lesser. So that is our experience with jackfruit flour.
Dr. Geeta, your comments on it?
I have two areas to work on. Jackfruit is a fruit and almond is a nut. So going back to the composition of these two food grains, looking at the food cellular biology in it, nuts have a little higher amount of phytate. So whenever we look at, they are very good sources of omega-3, but we need to make it bioavailable. So if this nut flour can be malted and powdered, like we call it in Maharashtra as satwa, and we make a lot of ambils and we make a lot of dosas out of it. I think every part of country will have that. That will have a more impact on definitely carbohydrate and other areas which our previous speakers have a plus point here. But just using an almond flour from nutrition point of view scores in calories and carbs. But if you want to make that almond to best of, if you are really spending so much of money and you want to use almond flour, use malted almond flour. If you have a sauce to it, it have a better impact. Jackfruit and almond have more of anti-nutrients, so when you soak and malt it, it is a better. Jackfruit has a very good source of inulin, and that is why as a fruit, the fiber or the prebiotic in jackfruit will have a better score to contribute in our daily intake. So I think both of them needs to be looked at what I'm using. Definitely both scores in calories and carbs and all the other areas. But again, as I've been speaking, how best nutrition I can extract from that food if I really want to eat is the area where I think the fraternity has to jump in and highlight and tell the people about it.
There's one question for Dr. Geeta. What are some examples of soy food products available in India?
Okay. Soya food, earlier there was a practice of adding soya bean into wheat flour. And then we started saying that using a bean doesn't work because soya bean has a very high amount of anti-nutrients. Then we say process the soya bean. Then the world become very high, very big for soya bean. And we have so many products now. I mean, India, Western, with globalization, I think we are in no dearth of soya products. So what we try to say is you start looking, if you want to really look at the best quality proteins, start using processed soya. You have chunks, you have these chunks in various formats. You have tofu, you have soya milk, you have kefir. All these are processed soya products which are available everywhere. And I think you get the best of nutrition out of it. Rather than adding bean into your diet, use processed soya flour as, not the processed soya products, which will have a better protein digestibility as well as availability. I think the other two, or Meenakshi, you also can contribute to this thought.
I think that was a perfect answer. But one more thing to add on is why she's so particular about processing the soya is when you use unprocessed soya, there is a risk of hemagglutination and male infertility, apart from it being goitrogenic. That's the whole reason why we need to talk of processed soya. Otherwise, we would always talk of, foods, their original form, but only when it comes to soya, we talk of it as processed soya. But beware of the sodium being put or the potassium being put in it. So for those patients who have an issue with, hypertension or potassium sparing diuretics, then maybe you need to worry
Ma'am, can you throw more light on the millets like kodo, foxtail? So we have many questions regarding that.
I think
The different millets that can be used.
I think kodo and foxtail are good millets, and we have a variety of millets. And definitely, as nutritionists, we do promote millets. And there is a variety of millets out there. And foxtail and kodo definitely score, especially when it comes to diabetes. And they can make different recipes out of it, either a dosa or a pulao or a upma, and it turns out really nice. And it's also low on the glycemic index compared to ragi, because ragi has a higher glycemic index. But only thing is, we have to remember that they have to use unpolished millets, because nowadays whatever is available is very polished and processed. So that is something that we have to keep in mind. But yes, I think we all encourage, and that is why we're celebrating the year of millets, because there has to be more variety. And I think, we all endorse the fact that our Indian diets are the best. Everybody's looking at Indian diets. And I think we have to definitely, try and promote our Indian traditional recipes. And they use a lot of millets.
One input there about millet is try to use whole millets rather than millet flour. The two advantages: when you cook the whole millet, it bloats up, it absorbs water, it makes the soluble fiber available in it, and then it has a better glycemic load. And quantitatively, you end up eating less carbohydrates with this, and soluble, and the fiber becomes very bioavailable. So the resistance starch improves, and then the improvement. So generally, people say millet bhakris or millet rotis. So more than that, I think the emphasis is eat whole millets, and rest of the point what Cheryl says makes a lot of sense.
And also that they're gluten-free. I think that really works well, especially if people really have celiac issues and want to go on a gluten-free diet. It really works well. And there are so many recipes that you can make. In fact, you get even jawar ka dalia now. So where we used to get broken wheat dalia, nowadays you get jawar ka dalia, you get moong ka dalia, and these are easily available on your e-commerce websites.
Whatever said and done, portion control is the key, even whether it's millets or other whole.
Absolutely.
And millets do not contribute protein, because a lot of people think millets give a lot of protein, and that's why then they eat a lot of millets in the diet, and they think that is where they're going to get their protein from. So there are a lot of misconceptions also.
I think it was a wonderful discussion. And Dr. Meenakshi Bajaj, final comments before we close. Wonderful discussion by everybody. Thank you, Dr. Rucha, Cheryl, Dr. Geeta.
Thank you, Dr. Nish.
Thank you, Dr. Unikrishnan. I would say that whether it's intermittent fasting or keto diet, it has to be done under supervision. And we've had enough of evidence to tell us that, vegetarian is the better go, even if it is when it is keto, because we are looking at metabolic health on the whole. And secondly, when it came to Cheryl, I think she gave us a beautiful description telling us that it's better to go partial than to go complete meal replacement. And in case, even if you're going on complete meal replacement, think of including, negative calories from very, low carb snacking pattern. And the best options, what she has seen is when she replaces the snacks with these partial meal replacers, they do wonders in terms of glycemic control as well as weight loss. And to, have the icing on the cake is to go traditional. And remember that protein can be, outsourced not only from animal sources, but also from vegetarian and vegan sources, and complementing is the day in and day out. And remember to go sprouting, toasting, roasting, fermenting. Nothing like our traditional foods. Thank you so much, Dr. Unnikrishnan and his team, for this wonderful platform.
Thank you so much.
Thank you. And this has been a wonderful session for the audience, especially doctors who are interested to learn about nutrition, because I think nutrition should be taught and practiced by nutritionists. And we as doctors learned a lot. And of course, Dr. Rucha Mehta is an exception. She's also a fitness-focused endocrinologist. And I always look forward to Dr. Rucha, because she has got a lot of interest in physical fitness, exercise. Wonderful speaker. Thank you all for being here.
Thank you so much, Rini. Thank you for the opportunity. It was great. I learned a lot also. Yeah.
Thank you.
So welcome to Dr. Vinod Abhichandani. And may I request Dr. Savita to introduce Dr. Vinod?
Let me seize this opportunity to say a good morning to all of you. And I am very grateful to CDI IDS Scientific Committee for allotting this topic to me. Thank you, sir.
Thank you so much. And I would like to invite my co-chairperson, Dr. Manish Bhutle. Can we have the CV of Dr. Manish Bhutle? Yeah, Dr. Manish Bhutle is a consultant diabetologist at our Chellaram Diabetes Institute, Pune. He has done his undergraduate training in medicine from KSMA KR. He's also done his fellowship in diabetology. He's also done his fellowship in diabetology at Dr. Mohan's Diabetes Center. He has got special interest in management of diabetic complications. He's published original article on HbA1c and albumin dynamics in Indian Journal of Endocrinology and Metabolism. A very warm welcome, sir. A very warm welcome to Dr. Abhichandani also. Thank you, sir. Can we have the CV of Dr. Abhichandani? I request Dr. Manish Bhutle to kindly introduce the speaker to our audience.
Thank you, ma'am. Good morning, all of you. It gives me immense pleasure to introduce Dr. B.K. Abhichandani. Sir has done his postgraduate and diploma in endocrinology from the UK. He's done the diabetes and endocrine physician since January 1985 at the He's a principal investigator in severe phase 3 trial post-marketing survey involving the insulin, oral anti-diabetic agents, and the cardiovascular molecules. He is the member of AACE, American Association of Clinical Endocrinology, and the European Society of the Endocrinology, as well as the European Association for Study of the Diabetes. He is a lifetime member for the RSSDI, lifetime membership for the RSSDI. He is a guest speaker at both regional and the national level diabetes conferences. Regional faculty at Ahmedabad for the CCGDM. He's published many chapters, book chapters, management of diabetes, nutrition of insulin, diabetes clinical case series. It was published in January 2016. He published the stress-induced diabetes in the textbook of diabetes. Recently published following articles like human pancreatic alpha cells in the health and diseases, in a clinical perspective review article published in the Journal of the Clinical Diabetology. He published preventive heart attacks, what you should know about diabetes magazine. Next is the thyroid dilemma diabetes, published in Diabetes Health, October 2018. Next is the human placental in based glycemic pregnancy Journal of Clinical Diabetology in April 2019. Many more papers on his name. So can we have his presentation now? Welcome, sir.
Thank you. Thank you very much. Both honorable chairpersons. Thank you. Honorable chairperson and all esteemed colleagues, over next 20 minutes, I'm going to present case studies on de-intensifying diabetes during a reversal program. Individualizing glycemic goals and de-intensifying treatments are concepts well accepted by physicians treating diabetes. Although in the past, diabetes has been called chronic and irreversible, the paradigm is changing. This slide captures some of the earliest studies which highlighted the importance of very low-calorie diets in addressing the dual epidemic of diabetes. In 1976, Bistrian and colleagues reported that a very low-calorie, protein-sparing modified fast, akin to something that we call intermittent fasting nowadays, could allow for insulin elimination in 7 of the obese patients whom they were treating, obese patients with type 2 diabetes. Then in 1984, a study involving obese type 2 diabetes patients found that LCD, that is low-calorie diet, and gastric bypass surgery were equally effective in achieving weight loss and improving glucose and HbA1c levels in the short term. So that was a short-term fix. And then in 1988, a study by Bowman and colleagues showed that a low-calorie diet of 900 kilocalories, including 115 gram of protein, led to significant improvement in glycemic control that was mainly attributable to improvements in insulin sensitivity, that is correction of insulin resistance. Evidence, and lot of evidence exists that remission of type 2 diabetes is achievable using bariatric surgery, low-calorie diets, or carbohydrate restriction. Both the ADA and the EASD now recommend a calorie-restricted eating pattern and support the short-term use of low-calorie diet for weight loss. The twin cycle hypothesis postulates that chronic calorie excess, as shown in this cycle with 2 wheels, chronic calorie excess leads to accumulation of liver fat, with eventual spillover into the pancreas, islets of pancreas. These self-reinforcing cycles between liver and pancreas eventually cause metabolic inhibition of insulin secretion after meals and onset of hyperglycemia. But if a person adjusts the handlebar to get rid of the excess caloric intake, then which is a driving factor of positive caloric balance, then the twin cycles can be very efficiently interrupted. The direct, that is the diabetes remission clinical trial weight management program, involved consuming a liquid 850 calorie total replacement diet of processed soups and shakes, along with non-starchy vegetables for 3 to 5 months. Thereafter, anti-diabetic and antihypertensive drugs were withdrawn in cases who were successful in reaching HbA1c of less than 6.5, at least continuously for 2 months. And a step food reintroduction thereafter was spread over 2 to 8 weeks initiated. Structured support was offered for long-term weight loss maintenance. Against this background, I present my first case, Mr. MHV, a 38-year-old Indian male. He was diagnosed 3 years ago with type 2 diabetes and dyslipidemia during a master health checkup offered by a national lab in his company. His family history was strongly positive. Both parents and elder sister were positive for presence of type 2 diabetes. Unfortunately, he had lost his father, who succumbed to coronary artery disease at the age of 60 years. Now, these were the vitals of the gentleman when his diagnosis was found in March 2019. He was carrying a weight of 90 kg, BMI of 30.8, blood pressure of 130/80. His fasting postprandial and HbA1c rate 147 milligram per deciliter, 231 milligram per deciliter, and 8% of HbA1c. He had typical atherogenic dyslipidemia of type 2 diabetes, which read as elevated triglyceride, low HDL, mildly elevated LDL levels with normal total cholesterol. And at that point of time, his renal function, liver function, and thyroid status were all normal. His presenting complaints in 2019 were easy fatigability and mild erectile dysfunction. He used to smoke and have lunch at his office canteen 4 days a week. And Mr. MHV was motivated by his healthcare practitioner to give up smoking, junk food, and his sedentary lifestyle. After 4 weeks of partially successful attempts at modifying his sedentary lifestyle, he was initiated on a fixed dose combination of sitagliptin 50 milligram and metformin 1 gram twice per day before major meals, and a FDC of atorvastatin 10 milligram plus vitamin D 1000 units once after dinner. And Mr. MHB continued the same protocol right through 2020 up to December. In fact, first couple of weeks of January 2021, when he voluntarily and suddenly decided and entered a diabetes remission program consisting of very low calorie diet, 900 kilocalories, and daily exercise, and that he entered during the end of January 2021. Now, this slide captures the vitals before he entered, that was just before end 2021 January, and then 6 months into the active program, what happened to him. So if we see what were his parameters before he entered the remission program: height 171 centimeter. He had just lost 2 kgs over 1.5 years of effort, from 90 to 88. BMI 30.1, BP 134/78, and his fasting, postprandial and HbA1c marginally better than what they were in 2019, 128, 227, and 7.8. He had by now some elevation of SGPT and GGT, 2 markers of possible NAFLD. But sonography was not available, not done at that point of time. And his triglycerides and lipids remain in that atherogenic range, and they were in fact marginally higher than what they were in 2019. And his ED had worsened by then, and he was feeling very tired, and easy fatigability was evident. So with this background, he entered the remission program, and 6 months into the program, active program, you can see some miracle happening to him. He lost from some 16 kgs of weight. His BMI came down from 30.1 to 24.6. His sugars improved quite impressively: 101, 147 fasting PP, and 6.4 HbA1c from earlier pre-program, 7.8%. All his labs turned normal. His USG abdomen was done this time, it was normal. He felt fit, his ED seemed to have resolved, and he desired the intensification of his ongoing prescription. So in August 2021, and that was almost, he started in end January, and then completed 6 months. And then we interfered with his prescription as desired by him, and as he was meriting change in his prescription. His sitagliptin, metformin 1 gram BD, FDC was tapered to just metformin XR 1 gram after dinner. Sitagliptin totally removed from the prescription. And his fasting, postprandial, and glycated albumin after 3 weeks were requested. They were very nice reports, very normal, 90, 118, and 12.8%. So glycated albumin is a good marker to monitor the effects of changes in therapy in patients with diabetes. And it reflects the blood glucose concentration over 2 to 3 weeks. And a standardized, at least 2-3 labs in my city do offer a very standardized glycated albumin test. And subsequently, metformin also we completely withdrew on basis of this 3-week data. And FDC of atorvastatin and vitamin D was left untouched, continued. And by December 2021, his fasting, PP, HbA1c was still very rosy. In fact, his HbA1c was the best ever, 6.1%. Fasting and postprandial were very much within normal range. He had stabilized at around 71 kgs of weight with a BMI of 24.3. We reinforced all our advice to him regarding lifestyle, diet, and exercise. And he remains compliant and continues to do well. So what are the varied virtues of intentional weight loss? See, if I am overweight and if I am able to knock off around 5% compared to my baseline, within a period of 3 to 6 months, I'll be able to perhaps address my hypertension and hyperglycemia more efficiently. If somebody is knocking off 5 to 10% of weight from his or her baseline, he can effect prevention of type 2 diabetes, polycystic ovarian syndrome, NAFLD, and dyslipidemia. A further weight loss, more successful weight loss of 10 to 15% will enable a person to avoid cardiovascular disease, offer some relief to urinary stress incontinence, improve parameters of NASH, that is steatohepatitis, non-alcoholic steatohepatitis, improve symptoms or give relief of obstructive sleep apnea syndrome, improve symptoms of GERD, which is a reflux disease, and improve picture of knee osteoarthritis. And if someone was like our first patient, he was able to knock off more than 15%, he is good at preventing or inducing type 2 diabetes remission, preventing cardiovascular death, and warding off HFpEF, that is preserved ejection fraction, heart failure. Now, coming to my second patient, he presented to me at the age of 45 in January 2021 with history of diabetes since previous 2 years, hypertension and dyslipidemia since previous 3 years. He had on presentation normal BP and a decent BMI of 26.8. The treatment history he gave included, told me that he was on telmisartan amlodipine fixed dose combination once per day for hypertension, or rosuvastatin 20 milligram once a day for dyslipidemia. The doctor treating him earlier gave him a 3-month trial of lifestyle and thereafter initiated him on metformin 500 milligram BID with a baseline weight of 90 kg. This dose was escalated almost after more than a year in July 2020. So that clinical inertia is evident in this case. To 1 gram BID when the HbA1c rose to 8.2 and practically the weight was unaltered. And out of sheer frustration, the doctor and the patient then ultimately decided there is a step up required, and a fixed dose combination of EMPA 10 milligram and LINA 5 milligram was added in October 2020 when the HbA1c had marginally further risen to 8.4% and the weight continued to languish at a high of 88 kilograms. And when he came to us, we obviously ordered fresh tests, and some of them read like this. His HbA1c had come down from 8.4 in October 2020 after addition of EMPA, LINA, FDC to 7.7. Fasting plasma glucose was 143, postprandial was 187, LDL 90, and eGFR around 87, just below the 90 to 120 cutoff of normal eGFR for persons with type 2 diabetes. So in Feb, when he again met us, he was unhappy with the corrections of his weight, which had come down to now to 85, just 3 kg weight loss after 4 months of an expensive addition of fixed dose combination of EMPA-LINA to his prescription. And neither he was happy with the BMI or the fasting sugars on SMBG, which hovered around 130 to 140. And it desires at this point of time in our conversation, it desired to enter a well-explained evidence-based diabetes reversal program and agreed to our proposal of a restricted 1,000 calorie predominantly liquid diet, low in carbohydrates, and mixed daily with 30 grams of raw green jackfruit powder. He successfully he implements the same very successfully, religiously for subsequent 5 months before being reintroduced to a closely monitored gradual solid food intake spread over subsequent 4 to 6 weeks. He was also additionally offered structured support by a qualified nutritionist and an exercise instructor for long-term weight loss maintenance. In July, a couple of weeks after we finally saw him, he came with very, reassuring and encouraging results. HbA1c had dropped to 6.2, BMI to a very normal 22.3 weight from a peak of 85 before he entered the program to now 15 kgs weight loss. eGFR had improved, fasting PP, all very much, and including LDLC, which again dropped below 70. So in principle, as his BP was also very well corrected, we had a conversation and decided to withdraw all his oral anti-diabetic agents, and even antihypertensives were withdrawn. Rosuvastatin dose was tapered from 20 to 10 milligram per day. Mr. HK was again counseled again and again to stick to the recommended, now not only low carb, low calorie, but restricted diet, as we had put him on his anti-diabetic. And in September, out of curiosity, we recommended that he should undergo AGP study, and these are his actual readings. 22nd September 2021 to 4th October. You can see most of the time he is in the recommended time in range, almost nearly 100%, almost like a non-diabetic person he was doing that singularly well. And that confronted me with a question: have we successfully directed and retuned Mr. A.H. Khan's type 2 diabetes? So Professor Roy Taylor, in order to give this simple flow chart to explain what is the importance of reducing carbohydrate intake and overall calories. Once we do that, we can reduce circulating insulin, reduce liver fat, make our patient lose some weight. In turn, that will take care of or reduce insulin resistance and help in remission of type 2 diabetes. At the same time, reducing circulating insulin levels will probably give some rest to the pancreatic beta cells, and it will augment insulin secretion. It will also reduce pancreatic fat, islet fat deposits. In turn, there will be an augmentation of insulin secretion, which will help in remission of type 2 diabetes. And around 10% of people with type 2 diabetes have a BMI that puts them in a healthy range, below 27, like our patient, Mr. A.H. Khan, when he presented in 2021 January. Internal fat around the pancreas and liver could be one of the reasons why these people develop type 2 diabetes. The Retune study is testing if people with a BMI below 27 can lose internal body fat and go into remission by following a low-calorie weight loss program. That is why I have clubbed both the landmark studies in this query, directed and retuned Mr. A.H. Khan's type 2 diabetes. I feel we have done that so far successfully. And this is the third and last patient, lady with diabetes. I'm going to present for today's presentation. And see in Mrs. RDP, 47 years old. In 2012, she was bereaved of her husband, developed depression and lethargy, initially on antidepressants. Hypothyroidism was ruled out. It's not there, but the history I remember. And 4 years thereafter, she was diagnosed with type 2 diabetes with initial HbA1c of 7.7, and she was put on MNT, medical nutrition therapy, lifestyle intervention, and a fixed dose combination of acarbose and metformin twice per day before major meals. This is how her weight progressed from, in 2012, a very nominal weight of 63 kg increased to by 10 kgs in next 4 years, and by another 9 kgs in next 3 years. So by 2019, 82 kgs. And consequently, the BMI also inched up from a decent 24 to a bothersome 31.2 by 2019. In tandem, HbA1c increased. In 2012, 5.8% was ignored. Perhaps that's at that point of time, she was in pre-diabetes range. But anyway, that was not taken cognizance of. In 2016, we saw she was picked up as type 2 diabetic with 7.7% HbA1c, which increased to 8.8% in 2019. So in July 2019, she was shifted to triple FDC of glimepiride 1 milligram, voglibos 0.3 milligram, metformin 500 milligram, 3 times per day before major meals. Antidepressants were completely withdrawn. She was counseled and we succeeded in removing that bunch of medicines. And between July and November 2019, we continued to motivate her, to counsel her that she should embrace specific diet. So ultimately, we could convince her to adhere to a 1,000-calorie low-carb diet with moderate intensity daily exercise regimen. So almost 5-6 months thereafter, in April 2020, she weighed a low of 66. Her BMI came down to 25.1. HbA1c was 6.7. And even at 6.7 HbA1c, she was experiencing in prior weeks hypoglycemia, which were occasionally confirmed by SMBG. And hence, she desired the intensification of her prescription. So triple FDC was given earlier 3 times per day, was changed to just once before breakfast. In order to fine-tune the whole process, tablet metformin XR 500 milligram was added after dinner. So sudden withdrawal is not very workable in day-to-day practice. And a 7-point SMBG was requested for next 7 days. So in month of May, this was the excellent 7-point SMBG, very meticulously done by the lady and shared with us. So we were quite enthused and encouraged to further try and bring down her medications. So a fortnight after reviewing the 7-point SMBG readings, her therapy was further de-intensified. Triple drug, totally, FDC was totally discontinued. And Mrs. RDP was offered tablet metformin, IPR, instant and preferred release 850 milligram total once after lunch. And again, she was requested to maintain a staggered SMBG record for the following 7 days. And look at that, all green, all rosy, all lovely, absolutely normal reports, thanks to the weight loss predominantly in this lady. So in June 2020, staggered SMBG profile was extremely encouraging. And in July, then we, in conversation with the lady, as she was very compliant, we mutually agreed to stop that 850 milligram IPR totally, completely. So no anti-hyperglycemic agent anymore. And look at her follow-up profile, January 2021, 6-7 months thereafter, 6.45 HbA1c. Earlier was at the time of saying a goodbye to all medicines, 6.4, inched up to 6.45. Over the 6-7 months, she had gained 1.7 kg weight. But she was meticulous in following all diet and lifestyle advice and felt very fit. And this is again January 2022, this year, okay? Only a month and a half ago. Her HbA1c surprisingly was all-time best, 6.3, BMI 24.8, and that she had lost some 700 gram weight over the year. So much disciplined lady. So an exceptionally motivated and adherent Mrs. RDP persists with her diabetes remission even after 18 months. One of the rare success stories. It requires a lot of motivation and determination to do this. So the direct study at 1 and 2 years, this is almost approaching the end of my presentation. If you see the standard NHS treatment protocol ended up with just 4% remission rate at the end of first year and 3% at the end of second year, compared to very low calorie diet proposed by Professor Roy Taylor and his team, which yielded around 46% remission rate at the end of first year and a robust 36% out of the same population followed over for the next year in 36% remission rate over the period of 2 years. So this result suggests that significant weight loss can help in remission of type 2 diabetes and result in regular insulin activity. Because of insulin resistance, it's precipitately out. The sensitivity improves greatly, and whatever endogenous insulin secretion is taking place is able to control the sugars. And this happens even if the individual has been diagnosed up to 10 years ago. So that is now expanded time slot. It's not that only 3, 4, 5 years of duration of diabetes will respond. Most of my 3 cases have been short duration diabetes, but maybe in future we can share more. So summarizing my presentation, ladies and gentlemen, the aim with type 2 diabetes is to go into remission and then move as close to a healthy HbA1c level as possible. Healthy lifestyle and behavior changes are most essential to achieve and sustain weight loss and consequently remission of diabetes. Life without diabetes, a truly groundbreaking concept that is being passionately pursued, very passionately pursued by so many of our patients. And we are so happy to see this happen. And this motivates all of us as HCPs to help such persons with diabetes adopt successfully an evidence-based diet plan of their choice. Please remember that. We should not enforce. We can give them a platter of diet plans available, evidence-based, and they can handpick one that is most suitable to them and lose enough weight over the time and stop their diabetes medications in a safe manner. Sometimes a person is having underlying retinopathy. It may not be a great idea to precipitately bring down his or her sugars. That can worsen that. So we have to have very good pharmacovigilance, and we have to follow the patient very, very diligently, meticulously, and make sure everything is hale and hearty, and person realizes his dream of life without diabetes. So thank you very much for your patient hearing. Any questions, comments, or criticism, everything is well. Thank you.
Sir, very excellent presentation, sir. I do have a few questions. Sir, in your daily practice, sir, what is your personal experience that how many patients underwent successful remission of that diabetes? And how many patients are again diagnosed with the diabetes after the remission?
So there is a relapse of hyperglycemia. So the first part I will address first. Let me give you a very, very honest answer. Maybe out of 100 patients in whom I have attempted, and in concurrence, both of us, he as my patient and I as his HCP, I would say around 10% people have succeeded, because it's a tough call. And out of those 10, at least 3 to 4% are no more able to yield to their gustatory, responses or their taste buds. So they are overcome and they regain weight and come back again with hyperglycemia. And that is why I like the word remission rather than reversal. So reversal is, I think, giving a false security to my patients that they are done for good and they don't need any treatment, no doctor, no follow-up, no follow-up checkup for possible complications. So that's how I approach.
Reversal means so many patients think that it is gone for a lifetime. There is no need of the medication further. So next question is that what is your target level during the remission period? Suppose any patient today you are starting from 9 HbA1c 9%, and patient underwent remission is HbA1c today after 3 or 6 months is 6.5 or 6.4. Then when you start the medication once again, suppose 7 or 8, when you think about the restarting the medications?
Yeah, so I would restart as soon as he crosses 7. I would not wait for it again to escalate to 8 or 8.5. I think I would be very observant and quickly address that hyperglycemia.
What about the follow-up, sir? During remission period, frequently follow-up, how you
ask? So I every 2 months. Every 2 months. And technically, because if I say do your HbA1c every 6 to 8 weeks, they may not like the idea because Dr. Google teaches them it's just a three-month story. So having said that, every 3 months HbA1c is mandatory.
And it is only the newly diagnosed patient you suggest to remission program or any diabetic patient? Suppose any patient having newly diagnosed.
Coming to that, yes, I will. You can kindly finish your question, then I will try to answer.
Just means any patient having 2 or 3 years of diabetic history, that patient you would like to prefer for a remission, or suppose any patient having the 10 year of history but having only oral medication during his treatment. So both the patients you would like to try for a remission? Or
I would say I would try for both the patients, but patients who are already on insulin depleted, on insulin support, they are difficult to reverse. or difficult to bring into a remission, honestly. But having said that, there were 3 landmark studies: Counterpoint, Counterbalance, and the direct study from Professor Roy Taylor's group. And each one of them had a different duration of diabetes patients included. So Counterbalance had the longest duration, 0 to 23 years old. And some of them, even people who were more than 10 years old in terms of the duration of diabetes, but on OADs only, no insulin, minus pioglitazone, that was the exclusion criteria for that. So they were doing, some of them did go into remission. So I think we can go on trying. It's always an aim that people would love to be off medicines. I'm sure most of our patients will be very happy to be off medicines.
And suppose any patient having multiple drug combinations, example, metformin plus sulfonylurea plus DPP4 or AGLT. So which patient we should select for the remission? All of them or few?
You see, in clinical practice, deviating from the textbook definitions of remission and cure and resolution, all those terms are still, playing truant with most of our patients. I would be happy even if I am successful in reducing his pill load from 4 to 2, even from 4 to 1. I would be very happy. Even I would consider that as a partial success in our story. So,
practical approach to that.
Yeah.
Thank you so much, sir.
Thank you very much. Thank you. Thank you, madam. Yes. And thank you, Dr. Unni, sir, for including me in this wonderful journey. Thank you. I'm really indebted to all of you.
That was an excellent presentation, sir. Thank you so much. Very informative. Thank you very much.
Thank you. Thank you.
For the next chairperson to join, please. Since we are not able to connect with Dr. A.K. Bhattacharya, I will chair the session. I'm Dr. Suraj. For people who don't know me, I'm a consultant physician at Chalaram Hospital. I've been with this hospital for more than 5 years. We've been treating a lot of diabetic patients, and now it's become a multi-specialty hospital also. We've been expanding quite a bit. And I'm happy to let you all know that we've been conducting this ideas for the past 5 to 6 years. And each year we are getting better and better and trying to reach out to more people so that we can get to the latest technology and let the people know the cutting edge of treatment for diabetes. So without further ado, I will go ahead and introduce our first speaker, Dr. Roy Taylor. He is going to be talking to us about impact of retune upon understanding the etiology of type 2 diabetes. A brief introduction about Dr. Roy Taylor. I'm sure a lot of you might have heard about him. He is the doctor who had done a lot of research, especially on remission of diabetes. So remission of diabetes goes with Dr. Roy Taylor's name. Let me go ahead and read what's in the introduction. He's a qualified physician in medicine at the University of Edinburgh. He's been a professor of medicine and metabolism at Newcastle University and Newcastle Hospitals. He developed a system now used to the United Kingdom for screening for diabetic eye disease with major reduction in blindness rates. He founded the Newcastle Magnetic Resonance Center in 2006 to develop innovative techniques for all medical specialties, but especially diabetes. In 2011, he showed that type 2 diabetes was a simple reversible condition, as I mentioned in the introduction, reversible condition of excess fat within liver and pancreas. And this led to a series of studies, including the Diabetes Remission clinical trial, demonstrating that type 2 diabetes can be put into remission in routine primary care. So without further ado, sir, I request you to go ahead and start your presentation on impact of weight gain upon understanding the etiology of type 2 diabetes. Thank you, sir.
Ladies and gentlemen, I'm delighted to be speaking at this Children Diabetes meeting and talking about a really important topic, that is of remission of type 2 diabetes. This concept is slowly gathering momentum and becoming accepted throughout the world. But today I'd like to discuss one aspect which is relatively infrequently discussed. That is the etiology of type 2 diabetes in view of all we know about the response to weight loss. So particularly, I'll be talking about the Remission study. Now, this is a study that I don't have final results for, but we do have considerable insight already. So what is the impact of this? Well, disclosures have no relevance to this lecture, and we can get straight to the central question. What is type 2 diabetes? Well, many investigators describe it as a complex heterogeneous condition, but in fact, that is incomplete and incorrect. It is in fact a simple homogeneous condition, but happening in complex heterogeneous individuals. Specifically, type 2 diabetes is a state of excess fat inside the liver and inside the pancreas. How can I come to say this so confidently? Well, several references are listed at the side of the slide here, but really, those statements rest upon the outcomes of four main studies, four pieces of research which has changed our thinking. First of all, the dramatic breakthrough was in 2011 with the Counterpoint study that asked the question, is this twin-sidal hypothesis of the etiology of type 2 diabetes possibly correct? We moved on to further expand on knowledge in the Counterbalance study and in the Pancreas study. And finally, we looked at Remission, which has taught us a great deal about the etiology for the detailed metabolic studies we carried out on a subset of the Remission population, of the direct population. So what do these studies tell us? Well, in a word, Counterpoint showed us that fasting plasma glucose normalizes rapidly on an 800 calorie per day diet. And it also taught us about the mechanisms. It provided the proof of the twin-sidal hypothesis. Counterbalance showed us that remission actually depends upon the duration of type 2 diabetes. It's most easily reversed to normal with short duration diabetes. And although it's never too late to say never, beyond 10 years, remission becomes much, much less likely. But Counterbalance also showed us that remission did not depend upon staying upon this very low calorie intake. It merely reflected a change in the state of body weight. And provided that body weight was maintained constant, as happened in this study, it was shown to be durable over time on a normal diet. The Pancreas study taught us a very important point, that the fat inside the pancreas falls with acute weight loss only in people with type 2 diabetes. There is no change in the intrapancreatic fat in people who have normal glucose tolerance over the first 8 weeks. And then direct. Well, direct showed us remission could be achieved in routine clinical practice by the nurses. It's not a technical, complicated procedure, but remission could be achieved by the practice nurses in almost half of the whole sample at 1 year. That was 149 people at 1 year. And as I mentioned before, the mechanisms were able to be explained. But throughout the discussion of the cause, I've referred to the twin cycle hypothesis. I have described this before in lectures to this meeting, but I'll briefly recap. The twin cycle hypothesis suggested a very simple etiology for the beta cell dysfunction of type 2 diabetes. Excess liver fat would cause excess fat export to the whole body, and that would build up in all the ectopic sites, including the pancreas. And at some point, that excess fat inside the pancreas would cause a beta cell dysfunction. But this is a hypothesis, and we needed to test it, which is where the counterpoint study came in. And the counterpoint showed each of these 4 points to be correct. And moreover, it showed that with weight loss, and by weight loss, I'm talking about substantial weight loss, not just a few pounds, but really getting a hold of the fact that in adult life, many people put on a large amount of weight. We need to lose a large amount of weight to get back to a healthy state. I calculated 15 kilograms, and in counterpoint, people lost an average of 15.3 kilograms in 8 weeks. And this is what happened with that weight loss: normal glucose control. And each of these points was shown to be correct. So we had a proof of the hypothesis, but we needed to learn far more. And indeed, the work of others has shown us really what's going on inside the beta cell. It was Roger Unger who, way back in 1994, showed that chronic excess fat to the beta cells of susceptible rodents would produce a loss of acute insulin response. So what's going on? Well, here we have a healthy beta cell under metabolic stress and losing its specialized function. Not dying, just losing it. And we now know this process is reversible. But if this metabolic stress is carried on for too long, we learned from Counterbalance, people can go over the edge of being able to be reversible, and the beta cells become null cells. They demolish all the endocrine secretory apparatus. So there is a point at which type 2 diabetes is likely to become irreversible in any one individual. What do we see sitting in the clinic? Well, we can see that some people are at this part of their journey. Other people are a long way to becoming irreversible, and there will be an uncertain period of changeover. Now, the point of this study, this talk, is to discuss particularly the Retune study, a study which is still in progress. But I'd like to describe the thinking behind this study and the implications so far. The aim of Retune was to test the personal fat threshold concept, that an individual became diabetic if they exceeded their personal fat threshold. Nothing to do with BMI. It was an individual matter. Now, that was partly drawn to my attention by what happened in Direct. Some people came from a BMI of 45 down to 42. They were non-diabetic and metabolically healthy. Some people came from a BMI of 27 down to 25. They too became metabolically healthy. So here we have people of very different BMIs running along. We tested this concept that people who develop type 2 diabetes have stored more fat than their own body can manage. And more than that, we decided to try and identify that threshold. So how did we do this? Well, this was a study of the mechanisms in people with a body mass index under 27, because in Direct, we studied people from a BMI of 27 all the way up to 45. So we wanted to complete our series. We set about achieving weight loss first of 5%, then keeping it steady for 8 weeks, then of 10%, another steady period, and then of 15% if needed, then another steady period. And we assessed the glycemic control after each stage. Would these people go back to normal glucose tolerance? Would they go back to a non-diabetic state? Well, we also measured the important factors that our work had previously shown to be critical for diabetes: the amount of fat inside the liver and inside the pancreas. We took great care to get the best possible data from our magnetic resonance studies, which were carried out in a specialized center by magnetic resonance physicists, carrying out very detailed analysis. It's not something that's being done as a routine radiological investigation, although liver fat is now far simpler than it used to be. Pancreas is still challenging and requires expert input. Now, what kind of people were involved in Retune? To discuss this, I've shown the different characteristics of people involved in direct and those in Retune. And you can see that the ages were generally similar, in the late 50s. There was a slight underrepresentation of females, which is interesting and reflects the fact that type 2 diabetes is in fact commoner in males at any one BMI level. And duration, slightly less in Retune, but HbA1c approximately similar, a bit less in Retune. We compared these people with appropriate controls who did not have diabetes within these weight categories. And you can see that the weights were reasonably well matched, 58, 61, 53, 55, and the proportions of male and female approximately similar. Were we successful, first of all, in achieving the weight loss? Could these people who'd always regarded themselves as being of normal weight actually follow our advice and lose weight? Well, yes, they could. Here are the several stages of the study. Baseline, after the attempted 5% weight loss, after the attempted 10% weight loss, and a small group went on to 15% weight loss. Many people had already decided either they'd lost enough weight or they'd achieved freedom from diabetes. So there are only 10 people in this 24-week group. But everybody possible was followed up at 1 year. And you can see that there was no weight regain over this time. Let me tune you into these by referring to the body mass index. Here we see a plot of the BMI for the same data. So the average BMI was just over 25, just under 25, and it fell in the way that you would have expected to be just over 21. Now, a body mass index of 21 might seem a bit light. Is that too thin? Not a bit of it. At this weight, everybody was still a few pounds heavier than they were in early adult life. That is a good guide for an individual as to when the weight was the healthiest. Now, I'm well aware that comment has got a time expiry date on it, because in today's world, people entering adult life are already much, much heavier than they used to be for these people aged about 50. But for the moment, as doctors, we have a reasonable guide. Are you heavier than you were at the age of 21? That is a clue to the need for weight loss. Now, I can just show you some preliminary data that in fact was presented to the European Diabetes meeting last autumn. HbA1c fell from a baseline of 54 millimole per litre to 48 at 1 year. So that average means that a substantial number of people were in remission. And this is the whole group that were being studied. Fasting plasma glucose fell from over 7 to just over 6. There is no doubt that blood glucose control improves with weight loss, despite these people being labeled as being of normal weight. What happened to the liver fat? Well, let me set this up by discussing the direct data. In this BMI group, 27 to 45, you can see that liver fat fell from more than twice normal down to just inside the normal range when there was 46% remission. In retune, you can see that, perhaps surprising at first, the liver fat was in the normal range. Now, does this invalidate the hypothesis? Well, no, it doesn't, because we must realize that we have to compare like with like. And the non-diabetic controls for these people with diabetes and this range of BMIs is shown here. And once again, liver fat is more than twice the healthy limit in this group of people. How about the pancreas fat? Now, here are the data for direct, and you can see that the pancreas fat fell by the modest amount typical of loss of this intracellular fat compartment in diabetes alone, and it fell towards the non-diabetic range, and you can see that it was elevated considerably and significantly compared with the non-diabetic. In retune, we see an excess of pancreas fat in type 2 diabetes. This is seen in any study of type 2 diabetes, which is carefully set up with appropriate controls and appropriate technology. And this difference is approximately a similar proportion to that difference. But if we remove the fat from the beta cells here, we know that we'll get a degree of remission. What do we know about this? Well, here we have a reversal with 15% weight loss in direct. The reversal in that group was about 60%. Once we have the final result of retune, we will be able to say just how this matches. It appears to be heading for that similar sort of level, but it's too early to make a call on the results. The final results will be presented later this month at the main Diabetes UK meeting in London. Now, I've referred throughout to the personal fat threshold hypothesis. This is something I've talked about before, but I would like to just reiterate the essence of this important matter. If we consider the population distribution of body mass index, the BMI distribution, usually this is shown as a smooth curve. That's what epidemiologists talk about, because they're talking about populations. And of course, body mass index is a very useful index for populations. However, we're talking about individuals in the clinic, and for this reason, I show each individual stacked up. And in this population, the median body mass index is about 27. They all have type 2 diabetes. Let's just pop them up there and imagine what it was like, what it would be like if they all lost 15 kilograms. Now, every blob would move to the side, and we know that most would become free of diabetes, indicated by the blue. But we can say, let's take individuals such as you and I have in the consultation, and this person lost weight and became non-diabetic. So did this person in the merely overweight range, and so did this person in the non-diabetic range. And each appears to have crossed a personal fat threshold, such an important concept for you and I dealing with real people in our clinics. And this threshold operates particularly at the level of susceptibility in the beta cell. We know that there are some people who will not get diabetes no matter how overweight they become. They are the majority, in fact, around 70% of the population in the UK. But others have varying degrees of susceptibility to the excess fat. So let me just reiterate that type 2 diabetes is a state of excess fat inside liver and pancreas, and if Retune confirms the same pathophysiology and similar remission, then there are major implications for clinical care. Thank you.
That was an excellent talk, Dr. Roy Taylor. Before introducing the next person for the speaking, I would like to introduce our chairperson who has joined, Dr. A.K. Bhattacharya. Dr. A.K. Bhattacharya is a senior consultant physician at Aerobic. He has been a member of ACP, API, and several other reputed organizations. He has been certified in diabetes. He is also an AAM certified in epilepsy management. He's been certified in thyroid diseases. He's been a faculty in many national and international conferences. He has also a lot of publications in reputed journal. He has special interest in hypertension, diabetes remission, thyroid disorders, epilepsy, headache, and he has special interest in technology and medicine. Without further ado, I'll go ahead and have Dr. Ashish Bhattacharya welcome once again. So please do introduce our next speaker, Dr. Om Lakhani, please. Can we have the CV of Dr. Om Lakhani on the screen, please? Dr. Bhattacharya, please go ahead.
Would you like me to introduce Dr. Om? Dr. Bhattacharya, can you see the screen?
Yeah, I can see it. I can see it. I'm very sorry. I'm very sorry. These are some things beyond our control. Yeah, I can see it. Yeah. Good afternoon, and thank you very much, Dr. Unnikrishnan and Dr. Vedavati and the entire team CDI for this honor. And it's a privilege to introduce stalwarts today. Dr. Om Lakhani is a well-known speaker across many forums, and he did his DNB in endocrinology, and he is presently a consultant endocrinologist at the Department of Endocrinology inside this hospital, Ahmedabad. And among his achievements, various achievements are, he is winner of the President NB Gold Medal in endocrinology, national winner of ESL TYSA in 2016, second runner-up at the Gandhi Award in 2017, winner of 2 gold medals in MD, winner of 5 gold medals in MBBS, and winner of API Dr. Vittal Rao Nadagowda for best thesis in MD medicine. So I now request Dr. Lakhani to please start his lecture. Thank you.
Welcome, Dr. Om, and Dr. Om Lakhani, one of my favorite speakers, and also Dr. Roy Taylor, one of the most eminent people in diabetes reversal in the world. And it's a star-studded show, and welcome to Dr. Om.
Thank you so much, sir. Thank you. Can we have the... Hi, good evening, everyone. So thank you to Dr. Unnikrishnan, sir, for this opportunity to speak on such an important topic in such an important meeting. And I think in front of the experts in this field, I think this is a very, very big opportunity for me to really talk on this very interesting topic. Now, the future of diabetes management really lies with consideration of diabetes remission. But to really consider diabetes remission as a possibility, we need to define what exactly is our clinical endpoint, or in other words, to define what exactly do we mean by diabetes remission. So that is in the next few slides, I'm going to discuss the current definition of diabetes remission, possible alternatives, and we'll also dissect the definition to really understand the meaning behind the same. So, as William Shakespeare said, what's in the name? That what we call as a rose by any other name, would that smell as sweet? Well, perhaps, the rose would continue to smell sweet, whether we call it a sunflower or a rose. But when we talk about definitions, or when we talk about words like remission, these have clinical importance, because at the end of the day, when we are correctly coding our patient, or in terms of insurance purposes, or most importantly, in terms of clinical research, if we are in line with the same definition, or if you're in the line with the same criteria for defining a clinical endpoint, we are able to conduct better clinical research, and we are able to kind of talk about the same thing when we are discussing in terms of different clinical research. And I think the field is now open for more research in this field of diabetes remission. And unless we define the endpoint, which is very clear, our definition for diabetes remission, if it differs in different clinical trials, we might end up trying to talk about different things instead of the same thing. So let's set some ground rules before we define diabetes remission. So the first thing is, when we are talking about diabetes remission, I'm talking about type 2 diabetes remission, and we are not talking about other forms of diabetes. So we are not talking about type 1 diabetes at present. Again, it's very important to understand that the correct word to use here is remission and not reversal or cure. So these are some wrong words, I think, chosen by a lot of people in social media sphere. So I think the use of the term reversal is wrong. There is nothing like diabetes reversal. The right word is diabetes remission. There's nothing like diabetes cure, because there's no cure. It's in remission state. And most importantly, and I think this is something which we all need to understand, that the ultimate goal of therapy for diabetes is to reduce or to prevent diabetes-related complications. And it is not stopping or reducing anti-diabetic medications. So the end goal is to prevent complications. That's the ultimate goal of therapy. And whether we do this with medications or we do it without medications, at the end of the day, the clinical endpoint must be preventing complications and not stopping medication. So that should be an important point we should try and understand. Now, let's talk about the current definition for diabetes remission as per the consensus report of the experts. So we have today one of the experts, Dr. Roy Taylor, with us today, who is part of this consensus report. This report was published very recently in 2022 in various journals, including the Journal of Clinical Endocrinology and Metabolism. And this is what is the current definition which all the experts agree to. And this is the definition we'll be using further in the rest of our presentation. So the clinical definition includes three important criteria. One is that the patient's HbA1c should return to a value less than 6.5%. So return to the value of 6.5, meaning that the patient earlier had a value more than 6.5%. Now, this can occur either spontaneously or following an intervention. And it should persist for at least 3 months after withdrawal of any glucose lowering pharmacotherapy. So this is the criteria. We'll come back to this criteria again, but if you're listening to this presentation, this is the most important slide of this entire presentation. In fact, this is the only slide you need to really understand. But we'll dissect the small finer points of this definition further as we go along. So let's dissect this definition. The first thing it says is HbA1c returning to baseline. But as we understand that in certain places, the HbA1c test may not be very reliable, or in certain clinical situations, like for example, somebody has a hemoglobin HB variant, or maybe sickle cell anemia, or any other condition where the HbA1c report may not be reliable. Or let's say the patient has undergone a recent blood transfusion, patient is on dialysis, any other such situation where HbA1c cannot be used as a criteria. What do you do in such situation? So the guidelines or the recommendation says that a fasting plasma glucose less than 126 can be used as a surrogate marker. A CGM, GMI, that is the glucose management index, or the estimated A1C from the same can be less than 6.5. So you can use the CGM criteria also for the same. So these are two other alternatives which can be used other than HbA1c for defining diabetes remission. Now, the definition also talks about spontaneous remission versus remission secondary to any intervention. So a lot of you will ask me, is spontaneous remission actually possible? It is possible, and we have seen this in clinical scenario in many situations. These are some examples. For example, glucocorticoid induced hyperglycemia. So let's say the patient is on steroids for a reasonable period of time, and that develops because of that, the patient develops hyperglycemia, and then the steroids are withdrawn, and then the patient goes back to a normal situation. So this is one situation where this can happen. Sometimes you have hospital stress hyperglycemia. Again, we have seen this a lot of cases during COVID-19 where COVID-19 induced hyperglycemia was very common, and this often may revert back to normal. Another phenomena we see commonly in clinical practice is gestational diabetes mellitus, where again, there is a transient hyperglycemia, which again reverses back to normal after the delivery. And sometimes, unintentional weight loss due to some other condition, like for example, GI disease or a surgery or some malignancy. In such a situation, we're not talking about obesity surgery here, but other surgeries, which can lead to potentially spontaneous remission. So these are all situations where spontaneous remission can occur. Such a situation also occurs in certain patients who go to end-stage renal disease or patients on dialysis. Sometimes that also leads to spontaneous remission. So these are all conditions where a natural remission can be achieved. So this also continues to be part of the definition. So this remission can be either spontaneous or can be following an intervention. It doesn't matter. Then, of course, the question comes about anti-diabetic drug use. And the criteria says that the patient should be off an anti-diabetic or a glucose lowering therapy for at least 3 months. Only then can we say that the patient is in remission. So let me put this question in another way. Let's say the patient is on an anti-diabetic drug, which is indicated for some other reason other than diabetes itself. And this drug continues to be used. For example, a patient is on SGLT2 inhibitor and it's being used for heart failure. Will this patient still be considered to be in remission? Answer to this question is actually no. So according to the current definition or the consensus of the expert, the patient will not be defined as having remission. So the patient should be off all medication. But if the clinical situation dictates that the patient is on an anti-diabetic medication for some other reason, for example, it could be patient could be on GLP receptor agonist for weight loss, right? Or patient could be on a metformin for PCOS. In such a situation, would you consider the patient to be in remission? Answer is no. So if you're using a genuine glucose lowering therapy for some other indication, and the patient continues to be maintain the HbA1c in the target range, in such a situation, it unfortunately would not qualify as remission. So again, this is important when you are doing clinical studies, and hence, this, explanation is important. Then, of course, let's look at an opposite scenario. So if there's an opposite of above, so if the patient is on a drug which can have a potential glucose lowering effect, but it's not a primary indication for the same, and it's not an anti-diabetic drug. For example, let's say a patient is on an orlistat, which is used for weight loss, right? We know that orlistat can have a small effect on glucose lowering effect. So it can, but then would that patient still qualify as having remission? Or let me put another drug in context. So let's say hydroxychloroquine, right? We know hydroxychloroquine has been used by rheumatologists often for certain joint disorders. And hydroxychloroquine has glucose lowering effect. So let's say a patient is on a hydroxychloroquine or a patient is on an orlistat, and the patient is in, has all the other criteria which fulfills for the remission. Would the patient still be considered to be in remission? Answer is yes. So in that case, the patient would be considered to the definition of remission would be applicable. So there's a drug which has potential anti-diabetic effect, potential glucose lowering effect, but it's not being used for the same, or it's used for some other indication. It's not an approved drug for diabetes treatment. in such a situation, the definition of remission would stand. So how soon after an intervention should you start testing for remission, or is the definition of remission be really applicable? So generally speaking, if you are considering lifestyle measures, generally you start testing 6 months after the intervention. And remember, the drugs, the anti-diabetic drugs should have been stopped for at least 3 months after the same. Again, if the patient is on certain medications, for example, often, SGLT2 inhibitors or GLP-1 receptor agonists often lead to diabetes remission because of weight loss. So again, you need to start checking 3 months after stopping the drug, and that is when again you can consider the patient is having remission. And if the patient has undergone an obesity or a bariatric surgery, you again start, defining or start testing 3 months after the surgery or 3 months after stopping the anti-diabetic medication. So this is the time period when you should consider potential remission, and these are the reasonable time frame when remission can be potentially applicable. So an important message, however, which must go to all the people who are listening to this. The question is, can diabetes-related complications continue to occur in a patient who had hyperglycemia exposure in the past, but now is having diabetes remission? So let's say the patient had, HbA1c of 9 or 10 in the past, and then, through medications, interventions, maybe obesity surgery, the patient has undergone remission and the remission definition is fulfilled. Can we still say the patient is free from complication? Answer is actually no. So the diabetes-related complications continue, can happen in the future as well, even if the patient has undergone remission. Of course, the chances of that happening are less. But for example, let's say diabetic nephropathy or diabetic glomerulopathy can occur in patients with past history of diabetes, but currently in remission. So such a situation can occur, which means that you will need to continue screening your patients for diabetes-related complications, even if the patient has undergone remission. Now, we understand that HbA1c has a U-shaped curve for mortality, and both the lower and higher HbA1c is associated with increased mortality, right? So again, former may be because of, the lower HbA1c, the higher mortality may be because of hypoglycemia. So remember, again, the lower end of the spectrum or the higher end of the spectrum, both of which have mortality issues. And this is something you should be aware of when we are dealing with such patients. I'm not saying that you don't lower the HbA1c to a normal value, but the point is that this is something we should keep in mind. Of course, should you continue to screen your patients for diabetes-related complications even after remission? This we already discussed. Answer is yes. Remember, there is a metabolic memory, and if the patient had a prior history of hyperglycemia, the patient can continue to have diabetes-related complications in the future even after remission. So it is important to screen the patient for both micro as well as macrovascular complications. So it doesn't mean the patient is in remission. It doesn't mean that the patient is free from diabetes-related complications, and we need to continue screening these patients for the same. Can sometimes, trying to attempt remission in certain patients have any adverse effect? Yes. So remember, there could be, for example, certain microvascular complications can have a transient worsening after rapid glycemic control. For example, retinopathy, right? So such patients, patients having especially proliferative retinopathy, sometimes it can worsen after rapidly improving the glycemic control. So in such situation, it's very important that we, select the right patients who should be candidates for remission and not try and attempt in every single patient. So this is the definition which has been given by the current experts. This is a current consensus definition. There are, of course, other definitions which have been used in the past, and some of them continue to be used in the present as well. So I'll just go over some of these definitions. Some of them actually have clinical relevance, so we'll discuss that a bit as well. So this is the prior definition which was used in a criteria which was given by ADA in 2009. This was known as the Induce criteria for remission. This is not being used anymore. So we do not use this definition, but this definition was very interesting because they used to use the word partial remission, complete remission, or prolonged remission. Partial remission was when the remission was for at least a duration of 1 year. Complete remission, when you had completely normal blood glucose, again for a duration for more than 1 year. And prolonged remission is that for more than 5 years after stopping the anti-diabetic medication, the patient continued to be in remission. So these were some of the older terms which are used, but we do not use this terminology at present. So we'll not go into too much detail about these because they have been replaced by the current definitions. Then there is Nagy et al., who have given a definition for diabetes remission, which is used, which is popular in the UK. So this is given by the British Clinical Diabetologists Association. The criteria which they say, it's very similar to the current consensus criteria. So again, it's aligning in a way. They say that the weight loss should be achieved, obviously. The HbA1c should be less than 6.5% or 48 millimoles per mole. And the fasting plasma glucose should be less than 126 milligram per deciliter on 2 occasions separated by 6 months. So the only difference between the current definition and the definition used in the past is the time period. And the time frame here is 6 months, but now the current definition gives it a period of 3 months. And this should be following complete cessation of all glucose lowering therapies. The glucose lowering therapy should have been stopped, as we discussed with the current definition. Then there is a definition which is given by Dr. Sanjay Kalra and et al. It's a very interesting paper where they've given alternative definitions for remission. And again, the definition by Dr. Kalra also is similar in line with the Nagy et al. Definition, where they say that the glycemic levels should be below the targeted level, which is of course based on shared decision making. So let's say, HbA1c target of less than 6.5 may be appropriate for a young patient, but for an older patient who is with comorbidities, perhaps an HbA1c level of more than 7, of less than 7 may be a better definition. A patient with a high risk of hypoglycemia with CKD, end-stage renal disease, maybe a HbA1c less than 7.5 may be more appropriate. So what they're trying to say is that the HbA1c level should not be set in stone, and it can be variable depending on the clinical situation and based on shared decision making, which makes this definition extremely attractive. And I find this definition perhaps a better definition in a sense of the way, and it's an Indian definition also, something I think we can all adopt. However, the time period they've said is 6 months. Again, this is in contrast to the current definition of 3 months. So this is again a slight difference between what we, what the current consensus criteria says and what has been given by Dr. Kalra. There are more aspects of this. We'll discuss this in the next few slides. Then you have IDF, which is given a definition that the remission is defined by most guidelines as HbA1c more than 6%. Here the criteria is slightly lower without medication for 6 months. So again, this uses a time frame of 6 months. So again, there are differences in definition, more or less. The time frame given by these definitions are somewhere between 3 to 6 months. And the HbA1c levels are generally 6.5 or 6%, depending on the criteria which you're using. We'll go with the current consensus criteria because that is the most evidence-based, based on the most recent evidence. So that makes it most attractive. A term which is given by Dr. Kalra, which is called drug-sensitive remission. So what he says is that let's say a patient is having HbA1c of 6.3%. Now, all the other anti-diabetic medications have been stopped, but for some reason, maybe a single anti-diabetic drug continues to be used. For example, the patient continues to be on metformin, or perhaps patient continues to be on an SGLT2 inhibitor, a single drug. So this he considers a form of partial remission, and this is a drug. This is a terminology which he says can be called a drug-sensitive remission. So the patient is on a single drug, a single anti-diabetic drug, and the other criteria for remission are fulfilled. So this is the drug-sensitive remission. I think this is perhaps very useful because this is something which is most practicable. If your patient is on remission, instead of stopping all the drugs, perhaps the patient can be continued on a single drug like a metformin or an SGLT2 inhibitor that these are pleiotropic benefits, and this patient can continue to enjoy the benefits of these drugs or a long term, at the same time maintaining good glycemic control. Then of course there are other definitions. For example, Dr. Kalra says there is a terminology called metabolic remission, where there is a reversal of insulin resistance or the secretory defect. There could be biochemical remission, which is something to do with the HbA1c and the biochemical parameters normalizing. There could be clinical remission that is free from diabetes-related complications. Perhaps this is the most important remission which we need to consider. And then, of course, pharmacological remission, where there is absence of need for drug therapy. So these are alternate terminologies, which are, again, very, very practical and can be used in clinical practice to define remissions in different clinical situations. So to summarize, and some important take-home messages for you, the correct word to use is remission and not reversal or cure. Remission is the right word, and that's based on the current consensus report. The ultimate goal of therapy, remember, is to reduce or prevent diabetes-related complications. And stopping therapy or reducing anti-diabetic medication should not be the goal. The goal is to prevent complications. Now, whether you do it with anti-diabetic drugs or without it, that's the idea. Ultimately, the idea should be to prevent complications and to promote good health. The current definition given by Riddle et al. Is HbA1c less than 6.5, occurs spontaneously or after an intervention, and persists for at least 3 months after withdrawal of any glucose-lowering pharmacotherapy. So this is the current definition. Now, what we have done is we have made your life very simple. We have made a small application, small app based on the Riddle et al. Criteria for determining remission. I'll share the link for the same. You can use that link. It's a freely available thing, so you can use it for defining remission. The idea here is to really collect data of how many patients really do we have in real life situation for remission. So this is the small app that we have developed, which ask the question is my patient having type 2 diabetes remission? So you punch in the values. I'll just show you a demonstration of the same. Right, so you enter your details here, and let's say you push the HbA1c. So HbA1c is 6 here. Now it gives you all these criteria, which you can see here. Is my patient on an anti-diabetic medication currently? Whether the patient is on metformin. So all these things which we have discussed, they are part of this small app. It's a web app. Okay, so let's say you select that the patient is not on anti-diabetic medication at present. It probably was on it in the past, but currently the patient is not on an anti-diabetic medication. Then you select when was the anti-diabetic medication stopped. So less than 3 months ago, more than 3 months ago. Right. So let's say we select more than 3 months ago. So it gives you the interpretation that your patient is having type 2 diabetes remission. And then of course, we just collect a little bit of more data. How was the remission achieved? Was it spontaneous using lifestyle measure, using medications plus lifestyle, medications alone, and so on and so forth. Right. And you can then enter the what you want to use, right? Let's say, and submit. Right? This gives you the final. Right? So there's a small app which you can use, very useful for you in your practice. And this is the link, so you can this is a QR code, so you can scan this QR code to download this application, right? And then of course you can use this link also. There's a link we have given here. So you can use this link to download this application, to use this application on your browser. You don't need to download anything. It's available on your browser. Right? So it will help you. So let's say you have a patient where there is potentiality for remission. You can then check the criteria to see whether you can define your patient as having remission. We also have the notes in endocrinology app. A lot of people, you are aware of this, right? And we'll upload everything, the notes about this presentation on this notes in endocrinology app. You can go through that to look at more details about what we discussed. So thank you for a patient listening. And once again, thank you to Dr. Unnikrishnan sir and the Cheryl Sales Diabetes Foundation for this wonderful opportunity. Thank you.
Thank you, Dr. Lakhani, for a very detailed and informative talk, as was expected from a decorated speaker like you. And you dwelled on a very relatively complex idea. And very well said, very well done. Thank you. Thank you, sir.
Now let's move on to the next speaker. I would like to invite Dr. Roy Taylor again to go ahead with the second part of the speech about practical management of type 2 diabetes in non-obese people, insights from a region study. Again, for those who missed his introduction, everybody knows Dr. Roy Taylor and diabetes remission clinical trial go together. Once again, I am very proud and happy to invite Dr. Roy Taylor for the second part of the speech. Please go ahead with the recording.
It's a pleasure and honor to have Dr. Roy Taylor with us. And Dr. Roy Taylor, you know you have so many fans in India. And Dr. Om Lakhani made a fantastic presentation as well. Over to you, Dr. Roy Taylor.
Ladies and gentlemen, I'm delighted to be talking to you a second time this afternoon. And that is moving on from the theory, from considering the etiology of type 2 diabetes in non-obese people, to talking about practical management. If research has any relevance, it must impinge upon what we advise, what we do in the clinic, and it must be shown to be effective. So how about preliminary insights from the Retune study and also from clinical cases that I've observed just in professional practice? Well, here we see Newcastle upon Tyne. Here's our so-called Newcastle from about 1084, and our cathedral, together with a typical Newcastle blue sky. Disclosure's not relevant. And let me cut straight to the heart of the matter. How do we get people to lose weight? Well, unfortunately, there have been many myths and incorrect assumptions made. And for decades, it's been suggested that the best way to lose weight is a gradual reduction in what you eat from day to day. Death of 1,000 cuts. You're hungry every day. You know you're missing that extra portion of rice, that extra chapati. It's not great. And we know it works in a tiny, tiny proportion of people. Indeed, many people put on weight when given the conventional advice. So how can we do better? Well, we clearly need an approach that is simple. Simple, that implies it will be robust. But is it practical, that people can do it in everyday life? They may need to travel for work, staying in distant towns and cities. At work, they may be exposed to what their workmates eat. It has to be practical. One really important thing is that the spouse or partner, the nearest and dearest, has to be on board with the effort to lose weight. Often that is completely forgotten about. All too often, it's an individual that's referred to a dietitian. Individuals don't take diets. Families eat diets. It's all a matter of the environment as well as the specifics. And importantly, duration limited and planned. So you know you're doing this for 2 months. You can plan when to start. You know when it's going to end. You're in a position of certainty. You, the patient, are in the driving seat. And good news for many people. Please do not start an additional exercise program during the weight loss phase. Now, I need to explain very carefully what I mean here. Often people follow the thoughtless advice to adjust their lifestyle. How pompous is that as a medical suggestion that we can interfere with the lifestyle of individuals? No, we need to focus on what actually matters. And all our work has shown it's the weight loss that matters. How do we get weight loss? Reduction of calorie intake, which is a huge effect on calorie balance. Exercise in the overweight and older group is a non-starter for weight loss. Let's get real about this. But in the same breath, I have to point out, for avoidance of weight regain, then yes, additional exercise built into everyday life is one of the most important things. So we need to be quite clear in seeing the role of exercise. And exercise has no part in getting from A to B with weight loss, because it will induce compensatory eating in many people, and that renders the exercise program counterproductive. So for the counterpoint study, I had to devise a system of losing weight which would be simple, robust, practical. And this is what dropped out. The first step of weight loss with a low-calorie diet. A second step with a stepwise return to normal. And a third step with long-term support to try and avoid weight regain. And here you see encourage increased daily physical activity. This shows the specifics. Low calorie was about 600 calories per day of a liquid formula diet in our original work, together with non-starchy vegetables in addition. That made up towards a maximum of 800 calories a day. We have tried 800 liquid formula diet on its own, and that's fine, it works, but constipation is more of a problem. Then a stepwise return to normal eating. Well, at the end of the weight loss period, we replace one liquid formula diet with normal food, but with a very specified amount and type of food that the individual likes, in order that we get the quantity right to reintroduce food. And ultimately, we aim for about 1,500 calories a day. Longer term is exactly what it says there, and that is difficult. This is a picture of the diet we used in Counterpoint, and in fact, as it proves so successful, even though we've tried other approaches, we use this approach in Retune. It is far superior to others. We use a sachet of prepared diet, which allows a high protein intake and complete nutrition. And this is made up in a pint of water. So this is one meal. And here is the entire day's allowance of non-starchy vegetables. It looks rather bare to doctors, but in fact, for individuals, it proves surprisingly effective. And I'll show you some quotations shortly. Then, step through to reintroduction, then the long-term challenge. And I put this on the same slide because all the attention tends to be directed towards this eye-catching business of losing 15 kilograms in 8 weeks, focusing upon this. But in fact, people tell me that this is not the difficult part. The return to normal eating is far more difficult, and the long term has its own challenges into the future. Let me jump straight to a study in Maharashtra state. And this makes a very clear point that it is possible to achieve remission of type 2 diabetes with a liquid formula diet. It was formulated to be a rather higher formulation because it was felt that maybe 800 kilocalories would be too low. I think personally that was an error, but nonetheless, what we need is the general approach to be rolled out. It's not the details that are that important. And you can see that the fasting glucose fell into the normal range, fasting insulin fell dramatically. And that with just about 7% weight loss. So there are messages here for India in respect of a population that was not particularly overweight. Now, in our various studies, especially in the counterbalance study, we had independent feedback with a psychologist carrying out interviews to find out from people how it was for them. And these are some of the representative quotes that are published in this paper. The first week or so, I was probably feeling hungry, but after that, absolutely fine. I did think, how am I going to manage on 3 drinks a day? But absolutely fine. Now, that was a 69-year-old man who was used to eating 3 square meals a day and had done throughout life. And he'd had duration of diabetes 3.5 years. This lady, somewhat younger, said, I was so surprised. Compared to what I was eating, to what I've been eating over the last few weeks, I would have thought that I would have been hungry from the moment I opened my eyes to the moment I closed my eyes, but I wasn't. Now, this is important because doctors assume that people will feel hungry on a diet. It's only the first 36 hours or so of the low-calorie diet that is associated with hunger. Thereafter, the body habituates to this, and hunger is genuinely far less of a problem than doctors imagine it would be. And more feedback. I find it very easy. Now, few people say that they find it easy. I think this person really meant they found it simple. And indeed, it is simple. It had to be simple to be robust. I started to see weight loss fairly quickly, and that's encouragement in itself. There is a really important point. Using a plan of rapid weight loss, people feel better in a short period of time. The average weight loss in the first week is 3.5 kilograms. Now, people are then able to chase after their grandchildren. They can run upstairs. It's a dramatic revelation of the beginnings of the return to health. And the fact that they feel so well adds to motivation. And finally, it was fairly hard to start with, but it got easier. I could walk further and stand up and sit down and dig the garden. It's great now. Now, there's this great British hobby of gardening, and this man was able to go out and do heavy work in his garden. And he is 44, and yet his weight and his diabetes had prevented him from doing what he enjoyed. So we should shed any medical preconceptions about the difficulty of a low-calorie diet, provided it's explained well to our patient in advance, and move forward to therapeutic success. And the important factors for success, I would highlight these. Many people may not be interested in getting rid of the diabetes. They would like the tablets and they want the doctor to take responsibility. We can do that for those people. But a substantial proportion of people are really determined to get rid of their diabetes. And that, of course, gives motivation for the substantial weight loss and success. And as I mentioned before, I'd like to re-emphasize family support. If the family is not supportive, then weight loss will not happen. That is very important to realize. Returning to the central topic of this lecture, how about weight loss in the non-obese? What do they think of it? And how about the ease of doing this in people who've always regarded themselves as being normal weight, and indeed have been told by doctors and dietitians, you mustn't lose weight because it's unhealthy in the normal BMI range? What complete nonsense. An absolute misrepresentation of what has gone on inside the bodies of these individuals, which is to gain weight throughout adult life, even though they're still within or close to the normal BMI range. Our observations over the years and preliminary observations in Retune suggest, first of all, the obvious. There is less absolute weight to lose. We may get remission with a lower weight loss than the 15 kilograms we need to aim for in many people. Also, it seems to be genuinely less difficult to achieve targets. In Retune, in the early part, it's been very clear that people achieve what we ask them to do with their weight loss. And so we had over 5% weight loss in the first spell, we had about 10% weight loss in the second spell, etc. And so far, there's been minimal weight regain in this long period from finishing the weight loss period, which was about 24 weeks, all the way up to 52 weeks. People did not gain more than a trivial amount of weight. And that's quite different than, for instance, in Direct, when there was quite reasonable weight gain, about 4 kilograms of weight gain between 5 months and 12 months in Direct. And I just put at the basis of this modified pyramid the fact that the major barrier to the success for people of near normal BMI and type 2 diabetes is a lack of clear information. Of course, this comes on several levels. First of all, doctors are unaware of this hidden gain. This gain from early adult life onwards. They look at their patient and they see people who look slim compared with the rest of their patients. But that's a wrong approach. We need to shed that and get our eyes tuned in to our individual in front of us. So the major barrier is lack of clear information for doctors. Then we have the matter of getting over to the general population that, in fact, even though body mass index might be normal, that may not be enough for some people. Other sources of practical information are our website, which explains more about how to lose weight and also discusses many of the issues I've touched on this afternoon. And also this book, with all profits going to Diabetes UK, because it was Diabetes UK that had the foresight to fund the Counterpoint study that started off this whole line of research and has engineered a sea change in type 2 diabetes. In the United Kingdom, the NHS, which is a notoriously conservative body, has already introduced a widespread weight loss program, rolling it out into primary care, and remarkably, in the first 2,000 people, it's produced weight loss of 13.4 kilograms. That is an amazing achievement on a population basis, and that is because the information was there. Why are we bothering to do this? Why not just leave people with their diabetes? Well, let's just consider the side effects, so-called side effects of diabetes, otherwise known as personal catastrophes. Well, serious adverse events were much less common in the intervention group in DIRECT compared with those who had best care according to NICE guidelines. What were these major events? Well, here they are for the control group. There's a fatal heart attack, 2 CVAs, atrial fibrillation, aortic aneurysm, amputation, terrible. And 5 cancers, incidentally, all of them weight-related. Well, there's a funny thing. What happened with weight loss? In the intervention group, 149 people, the same as controls. In the 2 years, there was only 1 non-fatal MI. There were no weight-related cancers. A dramatic difference, even at 2 years. This has never been seen in any other study because the effect size produced by this weight loss is far in excess of anything fiddling around with medications or other approaches such as exercise, which achieves no such effect. So let me summarize. Weight loss may be easier to achieve in normal or near normal weight people. In type 2 diabetes, liver and pancreas fat are higher in non-diabetic people when we compare that weight matched with the non-diabetic groups. And weight loss of about perhaps 10% can bring about a decrease of liver and pancreas fat. That seems to be the message from the early data of Retune, and certainly remission for some people who were previously regarded as having a normal BMI. So that takes me full circle back to the Angel of the North, which I showed on the first slide of the first lecture this afternoon. And you may wonder what messages the angel has for all of us. Well, type 2 diabetes is a state of excess fat inside liver and pancreas. It is that simple. The personal fat threshold, not BMI, determines what is excess for any one person. So the angel may well say, the writing is on the wall. You too can achieve remission for your patients who have type 2 diabetes, whatever their BMI. Thank you.
Thank you. Thank you, Professor Dr. Roy Taylor. Your talks have been the highlight of CDI meetings through the various iterations. And you are indeed the pioneer of the diabetes reversal or remission process. And I'd just like to add that unfortunately, OptiFast is not very well available, very freely available in India. With some difficulty, we have to get it from Amazon. You can get it from Amazon online. A 4-day course will cost you around 1,200 rupees INR, and it's available with difficulty. Thank you, sir. Thank you so much.
Open for questions. Do we have any questions in the chat box? Excellent presentation. Both Dr. Om and Dr. Roy Taylor. I have a question for Dr. Roy Taylor. Of course, you excellently presented as to what motivates the patient to lose weight and the difficulty that they face. The question I have is, usually they regain the weight that they lose in the first year. So how do we keep them motivated to continue to maintain the weight loss, sir?
This is a very good question. And the matter of weight maintenance, avoidance of weight regain, is exactly the point I made. The most important factors in minimizing weight regain are advising people that they should weigh themselves regularly, that they should engage with family, friends, and colleagues in letting them know why they don't want to be offered a piece of birthday cake at people's birthday parties. So they need to make it clear what they're doing. And this is such an important thing because we need to get this message out there. It's not just people with diabetes are too heavy, it's much of the rest of the population. And the other factor I'd mention is most important. Life events happen. People run into problems, disasters, family issues, illness, financial, and during these issues, individuals will gain weight because they can't focus upon the matter of keeping their weight down, eating in a certain way. And that's just normal. But they need to know in advance that if this happens, it's not a failure. Once the problem is over, then they need to actively engage in losing weight again. Now, during Direct, we achieved really quite reasonable maintenance of the weight loss, but exactly half the population had actually experienced this very thing. They'd had what we call rescue packages of help with getting their weight back down again. So it's something we need to do on an ongoing basis, and telling people about it in advance is really important. But finally, I just make the really important point that in people who are not particularly overweight, the necessary weight loss to get rid of diabetes is easy to maintain. They are a different population. Now, if we start with someone who is very large, these people are blessed with athletic appetites. They are very good in that department, but because of their appetite, largely genetic, as beautiful studies have shown, They're just starting from a different place and they're battling a different size of problem. Now, doctors tend to be affected in their overall judgments by dealing with the most difficult patients they deal with. And our minds tend to be filled with the difficulty of getting very large people to lose weight and keep it off. That is very hard. In the population range I've been talking about today, it is a much smaller problem. And indeed, there was no weight regain in the final 6 months of Retune during normal life, normal eating, just with the basic advice. These people had not been told to do it before. And so we were working with easier people, virgin territory.
Thank you, Dr. Ram, for your excellent explanation. There's one more question for you from Dr. Vasanthi Tote. Does not metabolism slow down when patient is on 800 and 1,000 calorie diet? Please also tell whether hyperinsulinemia is because of multiple snacking.
Metabolism doesn't actually slow down. Of course, it stays the same, but what's changed is the size of the body. And so because we talk about metabolism in terms of kilocalories per kilogram, then of course, the total number of kilocalories required just to maintain the body over 24 hours genuinely goes down. And so we can say, yes, basal metabolic rate does go down. But hey, this is something people just need to know, that if they were previously used to eating, say, 2,500 calories a day, then they need to know in advance that they will have to reduce that by around a quarter. So they need to know that instead of this size portion of rice, it just has to be enough to fit on the palm of a hand. That sort of practical information. And they need to know that is what they ought to eat, the quantity that they ought to eat to keep their weight down into the future. So we can deal with these things in a very simple way. And sometimes dressing things up in scientific language and worrying about why this happens. Of course, the basal metabolic rate goes down when the body mass goes down, but people need to understand that and just deal with it. Now, some people have more difficulty of dealing with than others. That's fine. We work with individuals. But if the doctor understands this clearly, then there's a good chance of achieving the best outcome for our patients.
Thank you, sir. I have a question for Dr. Om Lakhani. Sir, in your experience, could you tell me how many of your patients were able to go in for diabetes remission?
Sorry, could you repeat that, please?
Dr. Taylor, this question is for Dr. Om Lakhani, the other speaker. I was just asking about, in his experience, how many of his patients have turned or revived remission, diabetes remission?
Yeah, I think, a lot of things which Dr. Roy Taylor said, are very true. Two things. One is the timing. I think so, you need to catch the patient early on. And if you have the right patient at the right time, their chances of remission are much higher. And I would say that percentage of patient would be, the right candidate would be a relatively young patient, a patient who is, recently diagnosed to have type 2 diabetes. I think those are the right candidates for consideration for diabetes remission. And then, if you work with them, I think, a large proportion of them would go into remission if they are able to achieve the personalized weight, threshold, which Dr. Roy Taylor very rightly said. And, if they are able to do so, almost, 60 to 70% of them are able to achieve remission and maintain that. But, if you take a whole number, I think, it wouldn't be more than 5 to 10% who achieve remission and then they are able to maintain it. But, I have a kind of a question to everyone, and I think, sort of a comment as well. One of the challenges of, weight loss in India, at least in my area, I'm not sure whether it's the same everywhere. Weight loss is, especially those with near normal or normal weight, is seen very negatively by Indian patients. Now, I don't know why this is so, and is there some mentality which is persisting? But a lot of patients of ours, when we work with them, when they do lose weight, they come back and say that, I'm not comfortable with this weight loss. And when you ask them, you talked about spouse, but if you talk about the society as well, the society sees weight loss in a very negative way. So they often say that, I went to a family function or to a marriage, and then a lot of people who commented saying that, you look unhealthy because you lost too much weight, So this is a common challenge which we face in a lot of these patients, and they are very anxious to gain some of their weight back. And I think that there's perhaps a society threshold also for weight loss. I think that is also something, especially in India, that we perhaps need to look at as well. Because if you go below certain threshold, your relatives probably would not accept you, as a healthy person.
Yes, you raise a really important point, Dr. Lakhani. Now, let me just point out that the situation in Western Europe and America is beginning to change, because this was also true here. But if we look at the chief executives of big companies, at one time, they were all big people. Now, chief executives need to look lean, just having come back from the gym. We've got a new approach to power politics. And so we have leaders who are slim. That works down through society. Now, I'm well aware that in India, yes, there is this ethos of one's power being expressed with one's size. All I can suggest is that especially men who lose weight, who don't want to look scrawny around the neck, it's very easy for them to start resistance exercise, just lifting everyday objects several times a day. So that aspect shouldn't be overlooked, but we do need to educate. And let me say that part of my work has involved gestational diabetes. Now, we did a study published in Dietology demonstrating that moderate weight loss in type 2 in gestational diabetes has dramatically better outcomes. And so we did this, but we were very careful to collect information. Was it difficult for these women to stop their mothers telling them, you mustn't lose weight in pregnancy, you're eating for two? And we discovered that providing the precise information removed the block. Now, at the moment, I'm engaged in helping run a multi-center study of this. So it's a sort of direct equivalent, but for gestational diabetes. I think provided we put out the information and persuade all doctors to grasp this important concept, we can break through that.
Thank you.
We have one more question, sir. Can you explain about new ideas for reversal building on retune study? Any explanation on this aspect, sir?
Sorry, I missed the
thrust. New ideas for reversal building on retune study. So can we discuss some details about this, sir? Any ideas, sir?
On the retune study?
Yes.
Yes. Well, in retune, we set about the weight loss by explaining to people, same as usual. Now, we used a different diet product, which, in answer to the point that Dr. Bhattacharya brought up earlier, we used Exante. Now, Exante is easily available over the web in the UK and North America, but there are many other products. And provided these products are a complete nutritional mix, meaning the micronutrients are all there, especially the protein content is high. About 25% of the calories must come from protein. That helps satisfy the appetite. So I would suggest that, yes, there will be local products that can be sourced. It's quite important that we have one sachet per meal, because if the powder is provided in a big tub, then people have all the problems of decision making. Is that a level teaspoonful? Well, I was working hard, I'll have a little more. No, one sachet. And so the packaging of the product is really quite useful. But the clear explanation from doctors that this is simpler to do than anyone might imagine. Yes, the first 36 hours need support, but then they will find minimal hunger and they will start feeling better within certainly 2 weeks. Many people say 1 week, and the fasting glucose falls to normal in people with short duration diabetes in 7 days. So these are really important points to bear in mind. But I think finding a practical way ahead is just so important. And I suppose finally I ought to say, there's no magic to using the liquid formula diets. It's just that it takes away the day-to-day burden of decisions of what to eat. And so it has that simplicity which contributes to its almost universal success in our studies. Ordinary foodstuffs can be used. And when we collated all the information we got back from patients, that I got a torrent of emails about this, and I have had over the last decade, 50% used the prepared liquid formula, 50% just used ordinary foods, just eating a lot of protein foods, very little carbohydrate or fatty foods. And of course it's possible. It's just about energy supply. And so individuals can really pick and mix what they would like to do. But if someone's having difficulty, the liquid formula is by far the simplest.
Thanks again, sir, for explaining very well. Now we are almost at the end of the session. So we would like to conclude and thank both Dr. Omar and Dr. Roy Taylor for being here. It's a pleasure having you over, and very much looking forward to having both of you for our next year's sessions as well. Thanks again, Dr. Ashish Bhattacharya, for helping us and sharing the session. Once again, wishing you all a wonderful rest of the Sunday. Thank you.
Thank you so much. Thank you.
Thank you so much. Thank you.
Now let's move on to the next session. We will be talking about the SGLT2 inhibitors in clinical practice. I would like to go ahead and introduce our next chairperson, Dr. Sachin Yadav. Dr. Sachin Yadav is an MD physician from PJ Medical College. He has done his diploma in diabetes from Cardiff University. He is a medical director of Chintamani Hospital and Cardiac Center at Bhiwadi in Pune. He's working as a consultant physician and diabetologist as well as a critical care consultant in Chintamani Hospital, Pune. He has been a lecturer in Bharati Vidyapith Medical College, past president of Pune Doctors Association. He is an active member of Hospital Board of IMA. Without further ado, sir, I would like to invite you to our program, and please go ahead and introduce our first speaker, Dr. Sachin Yadav. Over to you, sir.
Yeah, thank you, ma'am, for giving the kind introduction. I will be happy to introduce our today's eminent speakers. So this session is regarding the SGLT2 in the clinical practice. So as all of us know, SGLT2 inhibitors, they are the integral part of management of type 2 diabetes, because most of the guidelines now they recommend the SGLT2 inhibitors as a first line or the second line drug for the patients of type 2 diabetes who have the high risk cardiovascular disease. So to throw the light on this, we have the three eminent speakers, Dr. Shailaja Kale ma'am, who will be speaking on the on the metabolic diet promise of the dapagliflozin, Dr. M. Chenyan, who will be speaking on the diabetes is equivalent to heart failure, what is the logic of early intervention with dapagliflozin, and Dr. Sanjeev Shah, who will be speaking on why dapagliflozin plus DPP4 inhibitor make a great combination. So I will introduce Dr. Shailaja ma'am. So Dr. Shailaja Kale, who is MD Medicine from Pune, she's diabetologist and she's having the diabetes and specialty clinic in BPRD, which is near to my hospital. So ma'am will be speaking on the diuretic promise of the dapagliflozin. So over to Dr. Shailaja ma'am.
Thank you so much, Sachin. Thanks
Yeah,
a lot. So I will just, I think I am audible.
Yes, ma'am.
Yes. Go ahead. Yeah, so I'm just sharing my screen. I can't see the screen. The screen sharing is paused.
Just for a second.
So should I stop and join again? Share screen again?
Just give us 2 minutes now.
Okay, no problem.
You're fixing the problem, ma'am. Just a minute. Yes, ma'am, you can go on.
Can you see my screen?
Yes, ma'am, visible.
Okay, thank you so much.
Yes.
So why these SGLT2 inhibitors are different? Because of their metabolic, cardiac, and the diuretic action, which make them different for patients with high cardiovascular risk. And that's what we'll see in next 10 to 12 minutes, because I don't want to repeat the things which I just highlight some important aspect of a molecule dapagliflozin. So this is more familiar to us now. So I personally feel the clinical research programs of SGLT2 inhibitors, whether it was canagliflozin, empagliflozin, or dapagliflozin, this maybe it was because of US FDA mandate that cardiovascular outcome trials started, but all our knowledge, understanding, and insights, not only of the molecules, but about type 2 diabetes, its cardiac issues, its kidney issues, everything has taken a paradigm shift. It has improved, and we understand diabetes, we understand kidney, we understand heart in diabetes much better because of this research. So thanks for all those researchers who really believed in this molecule, and the science has been taken forward. So let's thank you all of them who believed this and really took the initial research programs ahead. I remember one of the SGLT2 inhibitor molecule when it was under the phase 3, I was the investigator from India, and it was in between, it came that you need to re-consent of all the patients because of some issues of side effects related to some malignancy. So you have to explain to the patient these molecules may produce something, but still I am consenting to continue in this. So I think we have come a long way from that, and really thanks for everyone who believes in science. So we have come. So these are the wonderful molecule because of these 3 effects. And so metabolic effects, myocardium effects, vascular effects, and in the kidney, which is different than all the molecules which we are using. So glucose controls, I may not repeat. Very good as a monotherapy. It's a superb when you add it to metformin. Though we say it's mainly acts differently from the octet, whenever you are adding a molecule like dapagliflozin to insulin, or a patient on sulfonylurea, when we add dapagliflozin, there is an additional benefit which we have all seen. We have seen that when I add this molecule to my patients on insulin, so many times I stop insulin because the sugars improve so much. And so these are the patients where one should be careful about hypoglycemia when I am starting, especially when a high cardiovascular risk patient, maybe heart failure, and patient is already on insulin and SUs. and I'm adding a dapagliflozin or a SGLT2 inhibitor, one needs to be careful and evaluate the patient for hypoglycemia. So its effect on A1C is quite robust. And in clinical practice, we see it more because the reduction in A1C always depends on the baseline A1C. So the baseline A1C is more 9 or 10, the reduction will be much more. Baseline A1C is 7.5, the reduction may be 0.6. But if it is 9 or 10, it can go up to 1.5 or maybe up to 2% many times, which we have observed. All of us have seen that. So I think dapagliflozin molecule first started a beautiful clinical research program across the variety of patients. I think here the dapagliflozin scores over other EMPA or CANA in the clinical research program, 100%. So it was the first molecule which got approved for our use. I still remember the meetings when we used to talk our German colleagues, and they were using this molecule left and right for a few months, and it was not available in India. We all were doing just clinical research programs, and they were so happy. So I remember the excitement that time. Still, it has not gone down because of its every corner. This molecule is showing some fantastic, intriguing effects on the type 2 diabetes for the heart as well as the kidneys. Body weight, yes, within first week, you saw some loss, which may be because of the diuretic effect, but yes, and there is a sustained weight loss. There is a fat mass which goes down with dapagliflozin. I think I remember the first clinical research program where we saw these weight changes, and there was a special efforts to add the DEXA to measure the body fat, that it's not only because of the diuretic effect, but this molecule is actually reducing the fat mass. And that's how the DEXA was added in that clinical research program. And we really actually calculated how much fat mass is going down. So it is a wonderful molecule which has a significant weight loss. We have seen patients when you put them on SGLT2 inhibitors that there is a significant reduction in blood pressure. So many times we need to reduce antihypertensive doses of the patient when the patient we add on dapagliflozin. CV protection, I need not go into the details as you are going to hear about heart failure from a cardiologist, but preload and afterload both are reduced. Oxygen demand is improved. There is a good action in the kidney, in the glomeruli, at erythropoietin, on the podocytes, on the small vessels of heart, as well as the myocardial muscle itself. And it improves oxygenation in the myocardial cell. And that's why we have seen so many good effects, which are not only on the atherosclerosis, is a direct effect on the myocardium, direct effect on the glomeruli, which improve this glomeruli cardiac connection, and all the good effects of dapagliflozin, which we are seeing in all its cardiac small kind of a trials where its a mechanism of action is kind of explored, as well as cardiovascular outcome trials, heart failure trials, myocarditis trials. There's so much of this. We all know also that dapagliflozin was used in patients with COVID, those who were in ICU, and it was a DARE trial because it was really daring to use dapagliflozin there. But it was, though it doesn't show positive, it was good, and it has some good kind of information came out. DECLARE, we all know the most important part of DECLARE that 60% of patients in the DECLARE primary CVOT cardiovascular outcome trial were the patients which we routinely see every day in our clinic with simple multiple risk factors. So they do not have evidence of cardiovascular disease. The answer is ASCVD, no. And these are the patients where dapagliflozin has shown significant improvement in mainly heart failure. And if you remember, all DECLARE, CANVAS or EMPA, out of all patients, only 10% of patients were known case of heart failure. 90% of patients, there was no heart failure in the beginning. Still, there was so much of significant reduction in heart failure, which came later on in other DAPA-HF and everywhere, that these became heart failure drugs rather than drugs for diabetes. So it's a superiority over other oral anti-diabetic agents, which reduces cardiovascular risk, no doubt about it. And that's why all guidelines from ESC 2019 have changed it. And we can use SGLT2 inhibitor as a monotherapy if my patient is having a high CV risk because of its superiority, and it really reduces the cardiovascular risk for the patient. Then, of course, heart failure, the DAPA-HF design, Again, one most important is diabetes and without diabetes. So both patients were tested with dapagliflozin, that how it reduces the heart failure, reduces the mortality, reduces the symptoms. There is an improvement in the patient's daily lifestyle, the lifestyle scores, which is the questionnaire which is used for evaluation of any heart failure intervention trial. And DAPA-HF showed that dapagliflozin has a significant reduction compared to placebo over and above whether patient has diabetes or patient has no diabetes. So this means these drugs are doing something different directly to the myocardium, directly to the vasculature, directly to the kidney, which improved heart failure outcome, which I'm sure you will listen in the next talk from, of course, a cardiologist. So DAPA-HF showed significant improvement in death, in hospitalization, also in patients without diabetes. So they came as a heart failure drug, which was a big exciting thing after ERNI. So we have now something, I know all of us have experienced, within a week, a patient says that I'm feeling much better. I just feel better. So I think that's very rewarding, and we get very few moments like this in the medical practice, especially in type 2 diabetes, that these moments are to be cherished when patients come back of heart failure and say, Madam, I'm feeling so much better just within a week. So yes, these are heart failure drugs. So just one very important aspect of this is heart failure, reduced ejection fraction, that all these detrimental factors which are listed on the right side of the slide are improved with dapagliflozin, and that's why they are heart failure drugs. So if you see the heart failure treatment, the drugs that reduce mortality and reduced ejection fraction are ARBs, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists going to come a big way again. And then, of course, the SGLT2 inhibitors. So they are doing something different in glomeruli, and it's not only anti-hyperglycemic effect, but they have lots of metabolic effect, reduced fat, improves insulin sensitivity, reduced A1C. They have good effect on hepatic steatosis. Then we know that they reduce uric acid. The NASH, there is a histological improvement when the patient is on dapagliflozin. Then the cardiovascular effects, so many of them, and there are articles and articles written, which our understanding of diabetes is improving with these kind of a research, and of course the renal effects. So one of the very important is decreasing glomerular pressure with the afferent and efferent arterioles both, decreasing proteinuria by improving podocyte kind of a function in glomeruli. There is a good effect on erythropoietin, and the CKT progression goes down, which we all have seen in kidney trials. This slide is very interesting because it compares the effects of SGLT2 inhibitors and a loop diuretic, how they are different. And you can see that SGLT2 inhibitor decrease interstitial volume, which is twofold greater than the blood. They don't reduce so much of blood volume. So there is not much of a constriction and hypotension and the deleterious effect of a feedback, which is not seen with SGLT2 or dapagliflozin. But interstitial fluid volume goes down much better. So patients start feeling better without having a side effects which we see with loop diuretics. With loop diuretics, the interstitial volume goes down. At the same time, blood volume also goes down. And we all have seen, especially in patients with reduced ejection fraction, you need to reduce a bit of diuretic dose when the patients are on ERNI, plus I am adding on dapagliflozin molecule, slight reduction in diuretic drugs. So many times we just stop diuretics after a few weeks. So this is a very interesting effect, a diuretic effect over and above the metabolic effect of dapagliflozin. This diuretic effect of dapagliflozin is different than the loop diuretic effect. It is more beneficial for the whole vascular tree. It's a protective for kidney, and that's why the improvement in the heart failure or other things is much better with SGLT2 inhibitors than any loop diuretic. So we have seen just a few words about DAPA kidney, which we all know. There is a juxtaglomerular apparatus, and this feedback system, because of the sodium loss in the initial part of the loop of Henle, has a good effect on the afferent arteriole. So the intraglomerular pressure goes down. Any type 2 diabetic person, there is a hyperfiltration. it gets dilated, efferent arteriole. There's so much of volume inside the glomeruli. There's an increase in the pressure, which increases proteinuria. Just by a simple kind of this mechanism, by blocking SGLT2 receptors, it's not only diuresis, not only glucose filtration, but changes in the sodium and potassium. There is a feedback loop, and then we also that there's an intraglomerular pressure goes down, proteinuria is lost. So it's a great thing when you combine them with ACE and ARBs because it has an efferent arteriole. So this combination is actually helping our patients for protecting kidneys as well as for the heart failure. And that's why when we combine ERNI, where there are ARBs like valsartan, which has a great effect with dapagliflozin, our patients are doing so much better. So there is after a great trial of DAPA kidney, which again patients of diabetes as well as non-diabetes were included, and these both patients improved. Progression of chronic kidney disease reduced. There's the protection of kidney. Mortality was reduced. Not only proteinuria or reduction in GFR was halted, but also the mortality, not only cardiovascular mortality, which was reduced, but also other cause of death or other mortality really improved with dapagliflozin in diabetic as well as non-diabetic. So we all know that GFR more than 30, I think it's also for the DCGI, the US FDA it is 25, one can use dapagliflozin. And now all the nephrology world is saying that that after this interesting trial of DAPA kidney, just remember patients of type 1 diabetes were excluded from this trial, though there were other patients, those who received dapagliflozin with the GFR between 25 and 75, with the proteinuria more than 200 till 5 grams. And there was a significant improvement in protecting kidney. There is a GFR decline was arrested, end-stage kidney disease was reduced, renal death or cardiovascular death was significantly reduced, other cause death was also reduced. So that was the conclusion of DAPA CKD. So though the 25 GFR is cut off by US FDA or 30 by ICMR, still the nephrology world is now saying that whatever residual function, even in patients who are having a GFR below 25, if I use dapagliflozin, it may be protecting that residual kidney function, though at present it is not it's off-label use. We are always need to evaluate patients for hypoglycemia, patient for acute kidney injury, and patient about the volume restriction. Whenever I am adding a drug like these SGLT2 inhibitor to a patients with a compromised GFR or kind of a sick population. So, but once we know what are the problems, we use these drugs judiciously in these sick patients. These wonderful molecules are helping much more in the sick population than the patients with, of course, with kind of a normal GFR, they have a great effect. In actually, there is a less number of patients who develop proteinuria. So it's very, very early we are arresting and we are helping kidneys. But even in the other spectrum, at the end stage kidney disease, above the 25 GFR, they are really helping for the overall mortality as well as all the kidney outcomes. So because of this overwhelming benefit, it was stopped early, the DAPA kidney program. And we all know that now how the practices have changed. Our focus on the cardiac and the kidney whenever there's a type 2 diabetic patient sits in front of us had changed because of these wonderful scientific kind of a program. So a patient sits before A1C, I want to see his cardiovascular risk assessment. I want to see his renal status. Then I go how much is A1C before I design my treatment. So SGLT2 inhibitors are recommended with other comorbidities. I go one step ahead because in between I have done a paper published which says that how SGLT2 inhibitors are much helping even in primary prevention. It's kind of a meta-analysis was done and I published that. So early use of dapagliflozin may protect kidneys better. Patients with compromised GFR, yes, they do help kidneys as well as patients on heart failure or a cardiovascular risk. So all of the benefit of dapagliflozin is conferred because of the diuretic effects, help in excretion of glucose as well as sodium, correcting the metabolic faults, improving the cardiac action, as well as its direct effect on myocardium. And I think that is the most important aspect of this, whatever hypothesis we have seen, this mechanism of action, making these drugs class apart from other drugs. Thank you so much.
Thank you, madam, for giving the excellent overview regarding the metabolic plus diuretic effect of the SGLT2 inhibitors. We all know the diuretics, in fact, cause the metabolic worsening of all the parameters like the lipid profile, serum uric acid, whereas the SGLT2 inhibitors, they actually improve all the cardiovascular parameters which are detrimental to the health. So they are really the disease modifying drugs. So they are new class of disease modifying drugs. So thank you, ma'am, for giving the excellent overview regarding the dapagliflozin. We will move to the second session. We will take the questions later on.
Yes, yes. I need to go. I have so much of work. So thank you so much. I think Sachin, you are there, and I think your other eminent speakers are there. So I take your leave. Thank you so much. Hi, Sanjeev. How are you? Bye. 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 Bye.
Thank you, Dr. Kai, for joining us and giving us inputs.
So second, Dr. Shah, we'll take the...
Dr. Cheniappan's lecture, sir.
Has it joined?
It is recorded, sir. We can play, or if you want to have, we can take Dr. Sanjeev Shah's lecture. No issues at all.
Okay. Yeah. So we'll move to the second session. So Dr. Sanjeev.
No, take it in the order what is printed.
Okay.
Sure, sir. Sure.
So we'll move to the second session. So Dr. M. Chenniyappan, who is cardiologist at the Trichy. So he is practicing as a cardiologist since 1989. So he's a multiple gold medalist and has won numerous awards throughout his career. So he's a fellow of the American College of Cardiology and the Royal College of Physicians. So he will be speaking on the diabetes equivalent to the heart failure. What is the logic of early intervention with the dapagliflozin? So we'll move to the second session.
I thank the organizers for giving me the opportunity to talk about this topic. My topic is in two forms. One is to talk about heart failure and diabetes mellitus, and then give important information about the most important drug today, that is dapagliflozin, in the treatment of heart failure with a reduced ejection fraction with or without diabetes mellitus. So first of all, we ask the question, why do diabetics die? We mostly concentrate on the pipe diseases like arterial occlusions and venous occlusions, like myocardial infarctions and stroke and so on. And we also concentrate on filter, which is the diabetic kidney disease. And of course, most often, we do not concentrate on the most important problem of death in diabetes mellitus, is the pump problem of heart failure. So just look at some of the information about the heart failure in diabetes mellitus. We all know the most important cause of death in diabetic is cardiovascular disease. And the most common cause of cardiovascular disease which causes death in diabetes mellitus is heart failure. So when you compare all the other diseases like coronary heart disease, stroke, or peripheral vascular disease, especially in diabetic women, you can see the most common cause of cardiovascular disease which causes death and disability in diabetes is cardiovascular disease, is heart failure. So if you look at the epidemiology of diabetes and heart failure, in looking at the Framingham study, so when compared to non-diabetic males, diabetic males have 2 times the risk of developing heart failure. It is 5 times in diabetic females. It is 4 times in young diabetic males and 8 times in young diabetic females. With diabetes, heart failure develops at the rate of 3.3 per year. And it is related to the degree or the severity of diabetes mellitus. For each 1% elevation of HbA1c leads on to 15% increase in risk of heart failure. So this is about some information about the epidemiology. But in spite of all these factors, as you can see, the huge incidence of heart failure in diabetic males and females, many of the trials in diabetes mellitus have excluded heart failure in their endpoints. They always looked at coronary heart disease, angina, myocardial infarction, stroke, and they excluded the most important complication of heart failure. So even in those trials, which included heart failure, it is not the primary endpoint, but it is only a secondary endpoint. So what about revascularization? Okay, I can undergo a PCI or CABG. Still, heart failure does not leave a diabetic. In spite of revascularization, be it a PCI or CABG, the mortality due to heart failure is higher in diabetics when compared to non-diabetics. So this happens even after revascularization. So this is the scenario of heart failure in diabetes mellitus. Because the heart failure is not fitting in for microvascular and macrovascular complications. We always look at microvascular and macrovascular complications in diabetes mellitus. The heart failure does not come in either of them. So despite its frequency, the heart failure's frequency, morbidity, and high mortality rate, it is relegated to inferior position in the hierarchy of the diabetic complication. So diabetic complication, we always think of macrovascular diseases and macrovascular diseases rather than heart failure. Another important drawback is all the majority of the glucose lowering drugs, they lower glucose, but most of them can increase heart failure. And they fail to reduce long-term complication of this important complication of heart failure. So that's why the diabetes pharmacotherapy on the development and the progression of heart failure is still very difficult problem. And also so that's why the treatment of diabetes in heart failure and the treatment of heart failure in diabetes becomes a difficult one. So when you look at why a diabetic develops a heart failure, it is called cardiotoxic tetrad. So diabetics, because of the hypoglycemia, insulin resistance, hyperinsulinemia, it causes atherosclerotic cardiovascular disease, thereby producing LV dysfunction heart failure. Majority of diabetics may have hypertension, which can also produce systolic and diastolic dysfunction of the heart. And diabetics such a majority of diabetic heart switches over to free fatty acid metabolism rather than glucose metabolism. And there is a disturbed intracellular function where there is a myocardial dysfunction, mitochondrial dysfunction, as well as impaired handling. And there are structural alterations such as cardiomyocyte hypertrophy and advanced glycation end products deposition. And there is a cardiac autonomic neuropathy, as well as the most important problem is the fibrosis, primarily due to diabetes itself, as well as myocyte hypertrophy due to neurohormonal activation of renin-angiotensin aldosterone system. All these things can cause an independent diabetic cardiomyopathy in addition to coronary heart disease and hypertension, which can lead on to heart failure. So this is called, the one is the coronary heart disease, 2 is hypertension, 3 is diabetic cardiomyopathy itself, and the 4th important problem is the volume overload, which can cause heart failure in diabetic mellitus. So these are the 4 important causes of cardiotoxic tetrad. So what happens when you treat diabetes diabetes as it is, and what is its impact on heart failure? So majority of your anti-hyperglycemic drugs are most often, although they lower glucose intensively, but they can increase incidence of heart failure. So that's why it is very difficult to treat diabetes mellitus in heart failure, because majority of our anti-hyperglycemic drugs are likely to increase heart failure, and rather than treating heart failure in diabetes mellitus. So that is a problem. So we are not concentrating on the most important complication of diabetes mellitus, which is heart failure. And secondly, that the drugs we use in the treatment of diabetes itself is going to aggravate heart failure. So that is the scenario we were in. So this is the classification of heart failure as far as American College of Cardiology is concerned. They divide heart failure into 4 stages. Stage A is patients who are in high risk of developing heart failure. Stage B is asymptomatic LV dysfunction. Stage C is symptomatic heart failure. And stage D is refractory heart failure. If you look at stage A of heart failure, you can look at the most important cause is diabetes mellitus and pre-diabetic states such as obesity and metabolic syndrome. So having diabetes, even though the patient does not have any symptoms and signs of heart failure, he is in stage A of heart failure. So with this information about heart failure and diabetes mellitus, we go for the treatment of heart failure. First of all, what is the definition of heart failure? So this is the latest definition of heart failure. Symptoms and signs of heart failure caused by structural or functional cardiac abnormality, which is plus structural disease, maybe a valvular disease or cardiomyopathy. A functional disease may be a long-standing arrhythmia itself without any structural disease. It should be accompanied by either increase in natriuretic peptides or symptoms and signs of pulmonary or systemic venous congestion. Now the heart failure is divided into 4 important types of heart failure depending upon the ejection fraction. Heart failure with a reduced ejection fraction is less than 40% ejection fraction. Heart failure with a mildly reduced ejection fraction or heart failure with MREF is 41 to 49. Heart failure with a preserved ejection fraction is when ejection fraction is more than 50%. And there is an entity called heart failure with the improved ejection fraction, where your baseline ejection fraction is equal or more than 40%, but on treatment, it increases by equal or more than 10 points. Our focus of attention today is heart failure with a reduced ejection fraction. What are the aims in the treatment of heart failure, especially heart failure with reduced ejection fraction? First of all, we have to increase the quantity of life. We have to decrease the mortality in heart failure, either because of sudden death or because of progressive heart failure. We have to increase the quantity of money with the patient by reducing repeated hospitalizations, which increases the expense to the patient. So increase the quantity of money with the patient by reducing repeated hospitalizations. Improve the quality of life of the patient by giving symptom relief to the patient, such as relieving dyspnea and edema. And of course, we have to also protect the kidney, quiet kidney, by giving a renal protection. So can a single drug can achieve all the 4? So when you look at the drugs we have today, it can be RAS inhibitors, beta blockers, ARNI, hydrolyzine and nitrates give that quantity of life. They decrease mortality. Whereas loop diuretic, digoxin and ARNI give the quality of life and they give symptom relief. And here, because the patient is living longer, the doctor is happy. Because here the patient does not have symptoms, the patient is happy. Now, with this, all these drugs, there are 2 problems. One is there is a significant residual risk. Secondly, all these drugs act little later. You can see that the curve is diverging more only after 100 or 120 days. So it takes 100 or 120 days for this drug to show a benefit in heart failure. In spite of these drugs, there is a significant residual risk in heart failure. That's why we need one more drug. So when SGLT2 came as the treatment of diabetes mellitus, it was primarily introduced for diabetes mellitus. Then we understood because it prevents the reabsorption of glucose and sodium, it can produce a significant kidney protection or reduces the oxygen demand of the kidney. And of course, it gives you a favorable tubuloglomerular feedback. And it produces decrease in preload and afterload, and it increases erythropoietin and increases the oxygen delivery to the myocardium. As I told you, it switches over to a better energy substrate such as glucagon and ketones, so it gives you more energy. And because the hydrogen sodium ion transport is inhibited, there is a significant myocyte calcium alteration, which also benefits the heart. So it is not only the effect on the heart, it is metabolic effects, renal effect, other renal effects, and primary renal effects, and vascular and hemodynamic effects. All of them are acting on the heart, and they reduce significantly the heart failure. So then we understood that they are not only an anti-hyperglycemic drugs, they are very good drugs for heart failure. So once these drugs came, the the trials which were done in diabetes mellitus with variety of drugs like empagliflozin, canagliflozin, dapagliflozin, and so on, they showed a significant reduction in hospitalization. That is a significant reduction in first hospitalization for heart failure. That means in patients who do not have heart failure, they prevented heart failure or they postponed the heart failure, or in those patients who already had heart failure, it prevented readmission. This was in diabetes. So people wanted to know whether these drugs will yield the same benefit in non-diabetics also. That's why the trials like DAPA-HF came, which tried dapagliflozin in those patients who had New York Heart Association class of 2 to 4 with ejection fraction of less than 40%, with a significant increase in NT-proBNP, and they excluded significant kidney disease, hypotension, and type 1 diabetes mellitus. And they were divided into 2 arms, in which in one arm, the people were put on dapagliflozin of 10 milligram, and the other arm is placebo. And the primary endpoints are cardiovascular death, hospitalization, and of course, urgent heart failure visit. And the placebo patients are not those patients without any drugs. They are very well protected by all standard of care therapy for heart failure, such as the AC inhibitors, ARBs, and ARNI, even devices like ICD and CRT. So when they looked at the primary outcome of cardiovascular death, heart failure, hospitalization of heart failure, and urgent heart failure visit, there was a 26% risk reduction. When you look at the individual endpoints of the primary endpoint, there was a significant reduction or 30% reduction in worsening of heart failure event, and there was significant reduction in mortality due to heart failure. So it is not a soft endpoint which drove the primary endpoint. It is also the hard endpoint like cardiovascular disease, cardiovascular death, which drove the primary endpoint. So all-cause deaths was also reduced with the dapagliflozin. With this, it gave the quantity of life, they decreased the mortality. When we looked at the heart failure hospitalization, the heart failure hospitalization was reduced, urgent heart failure visit was significantly reduced, and outpatient intensification of heart failure therapy, such as increase in diuretics, also reduced. Thereby, it reduced the repeated hospitalization, so it increased the quantity of money with the patient. And of course, when they looked at the symptoms by a very important cardiomyopathy score, there was a significant improvement in the symptom relief of the patient, irrespective of whether he is a diabetic or a non-diabetic. And you see that number needed to treat is so low. So with this improvement in symptoms of the heart patient, it gave the quality of life to the patient. When they looked at the kidney, the renal adverse events were less with dapagliflozin. Severe renal adverse events were less with dapagliflozin. And the most important thing is doubling of serum creatinine was also decreased with the dapagliflozin. In this, it gives you the quality of kidney. And of course, other important news about this trial is that these benefits were seen within 28 days of starting the drug. So that means it is the one drug which gives the earliest benefit of the reduction in mortality and hospitalization at the earliest. As I told you, other drugs may take 100 days, whereas this drug may give you a benefit at 28th day onwards. And of course, irrespective of that severity of diabetes mellitus, we have seen increase in diabetes mellitus will increase heart failure. So irrespective of increase in the HbA1c, both the primary endpoint and cardiovascular death showed the benefit. So whether the patient was diabetes or non-diabetic, the benefits were same. And whether the patient was ARNI or without ARNI, the benefits were same. So irrespective of diabetes, irrespective of ARNI, the benefits were there with the dapagliflozin. So when you look at the adverse events, no adverse events was increased with the dapagliflozin. And of course, the volume depletion was little higher with the dapagliflozin, but it's also not statistically significant. The diabetic ketoacidosis is also not increased. The amputation is also not increased. So this slide showed that the benefits were seen with this amount of safety. And of course, the similar results were there for the other important drug class, empagliflozin. But the difference between empagliflozin and DAPA-HF is the empagliflozin showed a non-significant decrease in mortality, whereas dapagliflozin showed statistically significant reduction in mortality. The other important advantage of the dapagliflozin is it is only single-step titration. You start 10 milligram and be with that. Whereas for MRA or medulocortical receptor antagonist, spironolactone or eplerenone, you have to start with 25 and go to 50. And of course, there are 3 or 4 step titration for AC inhibitors, ARB, RNE, and beta blockers. So one step titration, immediate acting. And of course, we have a drugs jam in heart failure. We have diuretics, we have digoxin, we have aldosterone inhibitors, we have AC inhibitor and ARBs, we have digoxin, and of course, we have RNE and oral anticoagulant, anemia, metabolic drugs, and of course, we have colorful SGLT2 inhibitors, and of course, the Versquat and also omecamtiv is also coming. With this, if you go to the conventional sequencing according to the history of invention, we start with AC inhibitor, then beta blocker, then MRA, then the RNE, and then AC GLT2, reaching the maximum dose and going to the next drug will take 6 months for all these drugs to be in place. Whereas the idea is rapid sequencing of this drug so that you get the earliest benefit. So
should I mute?
Yeah, it's the time. Sorry to interrupt. Can we wind up in a minute or so?
Hello. Thank you, Dr. Chenyappan sir, for giving the excellent overview of dapagliflozin in the heart failure patients. So we'll take the questions after the third session.
Yes, sir. Thank you.
Okay. So we'll move to the third session. So Dr. Sanjeev Shah will be there. So Dr. Sanjeev Shah, who is attached to the Apollo Sugar Clinic in Mumbai. So he's practicing since last 42 years. So he will be speaking on why dapagliflozin plus DPP4 inhibitor make a great combination. So over to you, sir.
Good afternoon, friends. This afternoon, it's a symposium on dapagliflozin. You have already listened to cardiac benefits, organ protection, and you are going to listen to the next speaker in the same hall further on cardiovascular benefit. A diabetic drug intended to control glycemic control now has created multiple opportunities. I am going to highlight how dapagliflozin plus DPP4 inhibitor combination make a great combination, especially there is a synergy for glycemic control. When we treat diabetic patients, our goal is to achieve good glycemic control to minimize cardiovascular risk. Each 1% increase in HbA1c level increases initial cardiovascular event, subsequent event, a major adverse CV event, and cardiovascular mortality to significantly high level. When we look at the glycemic control in Indian population, an average A1C is more than 8.5%. Large majority of type 2 diabetic patients require a tight glycemic control, which we fail to achieve with available agents. The traditional treatment included using a single drug. When one failed, you go to another drug. Another fails, you use a combination. And we allow a period in between when the patient remains uncontrolled. In this period, there is physician inertia and there is a patient inertia. A long period goes uncontrolled. Rather, we should treat them differently and we should use a combination much early in the course of a disease. That would sustain glycemic control for longer period of time. Till now, the most popular oral agent combination contains sulfonylurea and metformin. This used to be a pillar of treatment. Most patients still continue to receive this combination. Probably in the years to come, we are going to change this combination into something different. I'm going to suggest a new combination. The major risk of sulfonylurea-based combination was hypoglycemia. That would limit the intensity of glycemic control. Any event of hypo will have negative impact and would result into down titration of treatment. As a result, patient will remain uncontrolled for a longer period of time. Same patient and a same physician would be reluctant to intensify treatment using same sulfonylurea. If there is insulin on board, the reason would still be more clear because the incidence of hypo would still be higher with insulin and SU. When the drugs change, the order has to change. Now, there is an opportunity to have different combination. From the time vildagliptin has gone off patent, large majority received that. In a year and a half, we have used dapagliflozin like anything. So think of a different combination, think of a different possibility, and think that we are going to use a different combination, which is effective, synergistic, and they address different pathophysiologic defect. If we look at role of DPP-4 in Indian phenotype, Indian diabetic patients have low adiponectin level, higher visceral obesity and insulin resistance, low GLP-1 response to meals, and enhanced DPP-4 activity. When you use gliptin, they increase adiponectin level, they improve insulin resistance, they increase a prandial GLP-1 response and thereby insulin secretion in response to meal. And this DPP-4 inhibition gets me GLP-11 back to physiological level, threefold higher than a disease state. And that improves the glycemic control. Once a day, very safe to use. If we look at SGLT2 inhibitor in that same Indian phenotype, they reduce body weight, they reduce waist circumference, thereby a visceral adiposity gets reduced, insulin resistance gets reduced by a reduction in weight. There is an improvement in leptin level and there is an improvement in glucose disposal. Now, if you look at both these agents, they work independent of beta cell stimulation, they work independent of beta cell secretory defect. So, the unique synergistic action addresses multiple pathophysiologic defect in the etiology of diabetes. In a way, SGLT2 inhibitor throw away 70 grams of glucose in urine, thereby 20% calories get eliminated from blood circulation. And that results into weight loss. In addition, improvement in systolic blood pressure by 4 millimeters. A rapid control will eliminate glucotoxicity. DPP-4 inhibitors are weight neutral and so obviously synergistic with SGLT2 inhibitor. If we look at an additional disadvantage point of SGLT2I, they increase glucagon level and they decrease insulin. While on the other side, DPP-4 inhibitors decrease glucagon level and increase insulin. So they make a great combination and the combination appears to be rational. This both synergistic effect have cardiorenal benefit through multiple pathways, multiple effect. I will not go into the details of cardiorenal benefit because the organ protection has been already highlighted in a previous talk. If we look at recommendation, the guidelines have been repeatedly revised, and a 2020 guidelines by American Association of Clinical Endo recommend weight reducing agents as the first and a second choice. GLP-1RA and SGLT2 remain as a first and a second choice. And you can very well see right in the middle that DPP-4 inhibitor falls exactly below SGLT2 inhibitor. In our country, not many people can afford GLP-1RA, and injectable therapy is not acceptable right when initial years of diabetes. So your obvious choice then remains next to SGLT2I is DPP-4 inhibitor. So this combination is the right one as per the guideline. If we look at clinical evidence, this is a paper where patient was initially treated with sitagliptin with or without metformin. You are aware that gliptins came about 7 years earlier than SGLT2 inhibitors. And so in large majority of the patients, sitagliptin, teneligliptin, and vildagliptin are on board. And now we are adding dapagliflozin. In this particular study with 432 patients over a 6 months period, dapagliflozin versus placebo showed 0.5% reduction in HbA1c, 24 milligram reduction in post-fasting glucose, and close to 50 milligram reduction in prandial. Gliptins are primarily prandial agent. When you add dapagliflozin, you make a combination acting in a basal state as well as a prandial state. And they both are reasonably well tolerated as a single agent to be used in a single pill. You can look at a ready combination of dapagliflozin and saxagliptin available globally. And this has been also evaluated in clinical trials. If we look at this particular study of adding 5 and 10 milligram of dapagliflozin on a background of metformin and DPP-4 inhibitor therapy in a grossly uncontrolled diabetic state, you can see the baseline A1C of 9.9% reduced gradually to 8.5, 7.5 at the end of 9 and 12 months, more than 2.4% reduction. If you look at fasting glucose, right from 9.7 millimole, close to 180 milligram, resulted into normalization of fasting glucose, close to 127 milligram. So there is a great reduction in both HbA1c and fasting glucose. This is 7 different studies, and a meta-analysis has shown that this combination achieves better glycemic control, greater weight reduction without increasing the risk of hypoglycemia, and in combination when initiated also does not increase the risk of genitourinary infection. If you look at the simultaneous combination which is initiated instead of a sequential therapy, you can see the combination is in favor of reduced risk of hypoglycemia. As you can see, also the risk of genitourinary infection for peculiar reason when SGLT2 inhibitor is used alone is higher, but if you used a combination initiated together offers a lower risk of genitourinary infection. And this has been well talked about, well experienced, and well highlighted, because during last few years we had been using a combination of empagliflozin and linagliptin as a fixed dose combination in Indian population. Well, till now, a small number of patients have received that kind of a combination. In 2022, with availability of multiple combinations with dapagliflozin, a larger number of patients would receive a combination of two great class. If we compare dapagliflozin and DPP-4 inhibitors side by side, it makes an ideal alliance. There is a clear-cut benefit in HbA1c reduction, tolerability. One is weight-reducing agent, another is neutral. Systolic blood pressure is reduced and another is neutral. Both preserve beta cell function, both improve insulin resistance, both are cardiovascular safe. One is beneficial in heart failure, hospitalization, and cardiovascular mortality, and renal function improvement in terms of albuminuria and decline in eGFR. So which combinations are possible with dapagliflozin? All of them. Vildagliptin either twice a day or once a day, teneligliptin once a day, sitagliptin once a day, linagliptin once a day. All four DPP-4 inhibitors reduce HbA1c by 0.7 to 1% A1c based on what is baseline A1c. When you combine both DPP-4 inhibitor and dapagliflozin, you reduce glycated hemoglobin to the tune of 1.5 to 2%. So that makes a great choice using immediately after metformin failure. In a patient who is newly diagnosed with HbA1c more than 9%, you have a choice to select a combination. And in future, I won't get surprised if a DAPA and gliptin combination replaces metformin as a first-line agent to be used with cardioprotection benefit, weight benefit, and renal benefit. Tolerability will not be an issue like what metformin has in newly diagnosed patients. So finally, a take-home message, a fixed dose ready combination with dapagliflozin and DPP-4 inhibitor is a synergistic combination for better glycemic control, significant weight loss, lesser side effects of genital urinary infection, and better cardio-renal outcome. There is a potential to reduce or delay the disease progression of type 2 diabetes. In the past, progression was studied with a different agent. Now, if you use an agent which protects beta cell, probably the disease progression could be different. It might eliminate clinical inertia, what is visible if you start this combination early in the management of diabetes. All this is possible because there would be improvement in compliance and there would be reduction in the cost of treatment. There is now a new possibility and new way of managing the patient. Thank you for listening.
Thank you, Dr. Shah, for giving the excellent overview regarding the combination of dapagliflozin and the DPP-4 inhibitor. So one question to Dr. Shah, which is the best DPP-4 inhibitor for combination with the SGLT2? Because there were some incidences regarding the increased chances of heart failure with the DPP-4 inhibitors.
Dr. Sachin, I am audible?
Yes, sir.
In the past, we have seen that one DPP-4 which was investigated was saxagliptin in a SAVOR-TIMI trial. In fact, internationally, combination is already launched with metformin and dapagliflozin. But if you look at the data in a close analysis, many cardiologists believed that saxagliptin marginally increased the risk of heart failure, while a further analysis by Harvard TIMI group, Dr. Deepak Bhatt, subsequently clarified it through a lot of papers that it was probably by chance or it was not true causality. But anyhow, saxagliptin was a weaker agent in terms of reducing glycemic control. And over the last 5 years, it has become unpopular due to availability of a newer and a better DPP-4 inhibitor. So Dr. Yadav, you would agree that most of us do not use saxagliptin these days. So we used more of teneligliptin. In last 15 months, we have used extensively vildagliptin. I'm talking about all over the country, not two of us. And in the future, when sitagliptin goes off patent from July, I am sure you would know that there would be large many who would receive sitagliptin. At the same time, all of us are also using linagliptin, but they are not available in a fixed dose combination. But the possibility is going to change in a couple of months. Vilda and DAPA will come, Sita and DAPA will come in the future, Teneli and DAPA will come, and whatnot will come along with dapagliflozin. I see that most prospective lady like metformin is dapagliflozin, who is going to marry with all the possible drugs.
Thank you, sir. Thank you, sir. So one question to Dr. Chenyapan. Actually, the dapagliflozin did not show the benefit in the patients who had the preserved ejection fraction. So there the empagliflozin scored over the dapagliflozin. So what is your take home for this?
I think that trial with the dapagliflozin is still on. So we just had Emperor Preserved, which showed some benefit on hospitalization of heart failure. So we are that heart failure with the preserved ejection fraction with dapagliflozin. At this point, we don't have the data. So we cannot say that the dapagliflozin's effect on HFPEF, and you have to wait for the dapagliflozin with preserved ejection fraction. At this point, we have a trial only with empagliflozin.
Thank you, sir.
Thank you, Dr. Shailaja Pai, Dr. M. Chenyapan, and Dr. Sanjeev Shah. It's a very wonderful speech. And thank you, Dr. Sachin Yadav, as a chairperson. Thank you, sir.
Thank you. Thank you very much.
Thank you.
Thank you. Thank you.
Now I would like to invite Dr. Sandeep Tamne as a chairperson for the next session on diabetes prevention today and tomorrow. And I would like to invite Dr. Ramchandran as a speaker. Dr. Sandeep Tamne is a MD Medicine, MRCP from UK. He is a fellow, Geriatric Society of India. He is consultant physician and geriatrician at Dinanath Mangeshkar Hospital, Pune. Currently, he is a chairman of Geriatric Society of India, Pune chapter, and he is a faculty of API call, GSI call, and MAP call meetings. He has presented scientific papers at the 9th Congress of the European Union Geriatric Medicine Society, held in Venice, Italy in 2013. And he is the organizing secretary for forthcoming annual conference of Geriatric Society of India 2018, GSI Con 2018, to be held in Pune from 26 to 28 October 2018. Thank you. Over to you, Dr. Sandeep.
Thank you, chairpersons, for this nice introduction. Talk that I'm going to chair is by Dr. A. Ramachandran, who is going to speak on diabetes prevention today and tomorrow. Brief introduction of Professor Ramachandran. Professor Ramachandran is MD, PhD, and FRCP both from London and Edinburgh. He is president of the India Diabetes Research Foundation and chairman of Dr. A. Ramachandran's Diabetes Hospitals in Chennai. He is internationally renowned for his work on epidemiology of diabetes. We all know his project, the Indian Diabetes Prevention Program, has been accepted and welcomed internationally. His pioneering work on use of mobile technology in primary, in primary prevention of diabetes is well known, and he has more than 400 original research papers. So over to you, Dr. Ramachandran. A very, very important topic. We always say prevention better than cure. and a lot of things are happening in the field of prevention of type 2 diabetes. So let's listen from you. Over to you, sir.
Thank you. Thank you very much. And it's a recorded talk. Can you just start?
Welcome, sir.
Hello, hi everybody. Again, I would like to thank Dr. Unnikrishnan for having invited me, especially for the keynote address. I also congratulate him for having organized such a fantastic meeting with very good faculty. I think that it's a proof of his organizational caliber and the popularity of his program. What I'm going to talk to you is about primary prevention of diabetes, strategies in Indians today and tomorrow. If you look at the global scenario, these are the major diabetes primary prevention program. One of the first one was actually in China in 1997, and then came the Finnish diabetes prevention program by Jaakko Tuomilehto, which was published in 2001. And then the United States DPP program, which was published in 2002. And then we have a few studies from India, the IDPP1 and the Indian SMS study, the DCLIP study, and very lately the Kerala prevention study. So I'm going to just concentrate on only the Indian studies, which are more relevant for us from a practical point of view. The agenda for the talk would be to first talk about just a glimpse into the IDPP program, and then the SMS study, and the post-trial sustainability of these trials. We also would like to just talk about the UK-India collaborative prevention study. And very recently, we analyzed the concordance of subjects screened either by OGTT or by HbA1c in the incidence of diabetes. And lastly, discuss whether these studies can be scaled up into a national program for prevention strategies in the total population. To recapitulate, the Indian Diabetes Prevention Program, which was published in 2006, was the first Indian study and one of the first studies from South Asia, where we randomized patients, people with impaired glucose tolerance into 4 arms of the study, lifestyle modification metformin and a combination of lifestyle modification metformin and a control group. By the end of 3 years, we had a 55% cumulative incidence of diabetes in the control group, while the group with the lifestyle modification had a cumulative incidence of 39%, metformin 40.5%, and a combination of lifestyle modification metformin had a cumulative incidence of 39.5%. In other words, the relative risk reduction by each of the strategies were following. Lifestyle modification, the relative risk reduction was 28.5%, metformin 26.4%, and a combination of lifestyle modification plus metformin did not have any added benefit. In other words, all the strategies significantly reduced the risk of development of type 2 diabetes and were useful strategies in preventing diabetes. So the lessons learned from the IDPP were lifestyle modification, even moderate nature, will reduce risk of diabetes. The reason why I'm telling you moderate was because it was moderate when comparison with the Western studies of the Finnish study as well as the American study. Lifestyle modification works even in subjects without obesity and even without a significant weight loss. And that is also where the difference between the Indian study and the studies from the Western countries. And lastly, we also proved that a combination of strategies may not have additional benefit. The next study that we did in by our team was to see that whether information technology can be used or the internet technology can be used for change in behavior to see whether we can have a health outcome. So the primary objective of this study was to evaluate whether mobile phone messaging by the short messages, encouraging lifestyle changes could reduce incidence of type 2 diabetes in people with pre-diabetes or impaired glucose tolerance. And this is a study in collaboration with Imperial College in London, and which is actually funded by the UK-India Educational Research Initiative. And this is the recruitment strategy. We screened almost 8,700 people, and 2,744 were eligible, and they underwent oral glucose tolerance test. And finally, 537 subjects were randomized into either just simple lifestyle modification, and the other one is lifestyle modification and reinforced with short SMS messages on the telephone. So this is the design of the study. It was a 1:1 ratio randomization, standard care plus motivational messages through mobile phones, only standard care. And they were followed up for 2 years. Every 6 months, there was a follow-up visit. And the analysis that was done to see whether there is any difference in the incidence of diabetes between the two groups. And this shows you the intervention strategy, and where the short-term messages were changed according to the change in their behavior. We used what is called a trans-theoretical model in order to see whether behavioral change can be followed up, and then according to the change in behavior, the messages were actually modified. And surprisingly, we got a better relative risk reduction in 2 years' time, which is shorter than the original IDPP, which was a 3-year intervention. Here, the intervention was only for a 2-year period, but there was a relative risk reduction of 36% in the intervention group. In other words, SMS through mobile phones really changed their behavior to reduce the risk of diabetes by 36%. And this shows you the relative risk reduction plus the absolute risk reduction. The incidence of diabetes was 27% of the control group, 18% in the intervention group, giving an absolute risk reduction of 9%. And the number needed to treat to prevent one diabetes during the trial period was 11, which is pretty powerful strategy. So the lessons learned from the Indian SMS diabetes prevention program was that mobile technology can be used to change behavior of people with pre-diabetes and can reduce the risk of diabetes. This is the first time demonstrating a clinical outcome using information technology. This is a scope of scalability larger population because it is a very cost-effective intervention. One of the studies which has been published again from India, again done in Chennai, was what is called the DCLIP study, in which patients were randomized into two groups. The novelty of this study was that those patients or those subjects who were not showing any improvement were started on metformin on the way. So therefore, they found that there were large proportion of patients required metformin to prevent diabetes, and in addition to lifestyle modification. They also compared the difference between the incidence of the relative risk reduction in preventing diabetes in the groups with isolated fasting glucose and isolated IGT, and they found that it is more effective in patients with IGT compared to impaired fasting glucose. There is another study which is called the Kerala Prevention Study, which is published in 2018, and this is published from by Thangappan et al., where a peer support lifestyle intervention for preventing type 2 diabetes was tested in a cluster randomized control trial. And what they found was by the end of the period, they found a low-cost, community-based peer support lifestyle intervention resulted in a non-significant reduction in diabetes incidence in this high-risk population at 24 months. They did it for 2 years. Unfortunately, the reduction was not statistically significant, although there was numerically reduction in the incidence of diabetes. There are significant improvements in some of the cardiovascular factors and physical functioning score of the subjects. Now, the next question that probably comes in our minds as clinicians is that when you do a trial, you do the intervention for a short period of time. For example, in the primary prevention IDPP trial, we did the intervention for 3 years. In the SMS study, we did the intervention for 2 years. And at the end of the trial period, you do the analysis and show the results. Now, the question is there evidence of long-term sustained benefits of prevention strategies among our people, even after the trial is over? And that is called the post-trial follow-up was done for the SMS prevention trial. Now, as this is a slide which I already shown you that in 2 years, there was a 36% relative risk reduction during the intervention period using the SMS program. The question is whether there will be a continued, sustained reduction in the incidence of diabetes even after the trial is completed. So we followed up these individuals for the next 3 years. And we found that during the post-trial follow-up up to 5 years, there was still a separation between the two groups, and there is a relative risk reduction of 30% even at the end of 5 years, which shows that even at 2 years of intervention has sustained effect up to 5 years in preventing the incidence of diabetes, even after the aggressive and intensive intervention is completely stopped. So I think behavioral modification has got a long-term effect. So the lesson learned from the post-trial follow-up was a 2-year intervention has long-term sustained effect up to 5 years. The other one which I want to talk to you is about now after finishing the Indian studies, when we had collaboration with the Imperial College, they wanted to see whether the trial with SMS can also be used in London or in the British population. So therefore, this is another program which is actually funded by both ICMR as well as the MRC in the United Kingdom, in which we took up almost 2,000 subjects, 1,000 in India and 1,000 in UK, and they were randomized into 2 groups. One group got standard care and the other groups got standard care plus the short messages. The only difference in this particular study was that we used an HbA1c in order to detect impaired glucose tolerance. So an HbA1c of 6 to 6.4 was taken as the upper limit of the impaired glucose tolerance for randomizing. So in other words, this is a study in which subjects were recruited by doing an HbA1c and not an oral glucose tolerance test. During the 2-year follow-up period, the incidence of diabetes in the control group was 22.7%, intervention was 21%. Therefore, there was definitely a non-significant reduction in the proper incidence of diabetes was higher in the Indians in India, 30.3, and intervention 26 points. So there was definitely a difference in the incidence of diabetes in the Indian population, while in the UK group, there was not much of difference at all. In fact, in the intervention group had slightly higher incidence of diabetes. In other words, the SMS, when we did it both in London and in India together, we found it was effective again in India, but not in the British population. This is the forest watch showing the difference between the countries and also the gender. And what we found was that if you look at there is 11% overall reduction in the incidence of diabetes in the population, but it was not statistically significant. And in India, the reduction was 16% compared to the total of 11%. And there was a significant reduction in women compared to men. So there was many lessons learned from this particular study. One of the lessons that probably we learned was that there could be differences in the results of the same intervention depending on the ethnicity, probably due to socio-cultural factors. Differences in the recruitment of prediabetes itself would be one of the differences. For example, in the IDPP and the SMS study, patients were recruited by doing an oral glucose tolerance test, while in the India-UK study, patients were recruited using an HbA1c measurement. The next question that we asked at this point of time was whether you recruit patients depending upon the HbA1c or oral glucose tolerance test, is there a difference in the incidence of type 2 diabetes during the course of the follow-up? And this is called concordance in incidence of diabetes among persons with pre-diabetes detected using either oral glucose tolerance test or glycosylated hemoglobin. So there are two cohorts, one detected by OGTT and followed up, and diabetes outcome also was measured by OGTT. In the other group, pre-diabetes was diagnosed by HbA1c and diabetes also was diagnosed by HbA1c. And what did we find? There is absolute concordance. There was no difference in the incidence of diabetes between the two groups, either at the end of 12 months or at the end of 24 months, whether you use HbA1c or oral glucose tolerance for diagnosing pre-diabetes as well as diabetes. So that is a lesson learned, no difference in the incidence of diabetes among pre-diabetes recruited either by oral glucose tolerance test or HbA1c, and the outcome diagnosed by the same test. The last thing I want to talk to you is the scalability to the population and national study. This is a big study which was actually in collaboration with the WHO, and the WHO office, regional office in New Delhi was involved, and also the Ministry of Health and Family Welfare, Government of India, along with our institution in Chennai. And the methodology was to register a large number of people in the population using mobile phones or by website, and then categorize them into people with diabetes, with pre-diabetes, and then see whether health behavior changes can be obtained by using SMS messages. We did an impact evaluation at the end of 3 months and 6 months, and another evaluation at the end of 1 year with stakeholders in review. We sent about 130 million text messages, and a total population of more than 1 lakh were registered. We had 64,000 registered by a missed call and 43,000 actually registered by on the web with the website. And what did we do? We sent text messages both in English and Hindi, and text messages were healthy diet, physical activity, and also adherence to medications in people with diabetes. And totally about 90 messages on alternate days for 6 months duration. What was the effect? What did you find? Impact of evaluation of the 6th month found that patient who had diabetes tested for diabetes 67% of them within that period. Patient who had high risk of diabetes tested for diabetes almost 52%. Improvement in dietary habits was seen in almost 57%. Improvement in physical activity was seen in 72%. So within a short period of 6 months, giving SMS messages in mobile phones, people with diabetes went for a checkup, 67% of them went for a checkup. People who have been diagnosed to have high risk of diabetes through the mobile phones. Almost 52% went for diagnosis test for diabetes. So it is pretty effective. We also found there was changes in behavior of people. So the lesson learned from the national study was that mobile technology is scalable and may help in national programs. Its efficacy is demonstrated and can be cost effective in the long run. So to sum up my talk, the story of primary prevention trials in diabetes in India so far has been that prevention and postponement of diabetes is possible using lifestyle modification and metformin. Use of mobile technology in primary prevention in India has been shown in 2010 to 2013 studies. All these studies had also shown there is a post-trial effect for up to 5 years. The primary prevention study with mobile technology done both in India and the United Kingdom showed that there can be ethnic differences in the outcome. We also showed that mobile technology may be useful as a national program, and this is called the M-Diabetes program in India, which actually showed that using mobile technology, you can actually recruit patients, recruit subjects with high risk of diabetes, and change their behavior for better health as well as to prevent diabetes. I want to acknowledge my research team, my clinical team, and some of the collaborators abroad, Jaakko Tuminato from Finland, Chris Johnson from Imperial College London, and Professor Nick Verum from MRC in Cambridge. Thank you very much. And for clinicians who are listening to this, we have an app called DiHome, which is a diabetes treatment app that can connect you with your patients online. Soon, DiHome will be available to you for connecting with your patients online, and diabetes treatment can be offered online. Thank you very much.
Dr. Tamade, you need to switch on, put on your audio, sir.
Oh, yeah. Am I audible now? Yeah.
Yes, yes, you are audible.
Thank you very much, Professor Ramachandran, for a very lucid and practical talk on primary prevention of diabetes. I have two small questions for you, if you don't mind. In addition to metformin, is there any study with acarbose or alpha glucosidase inhibitors for primary prevention? That's my first question. I think I had heard about this study. And second question is, we all know about metformin. It causes weight loss by mainly causing anorexia. But are there any other mechanisms which result in weight loss with metformin?
Good question. The second part of your question is whether metformin produces reduction by anorexia. No. Actually, metformin, the major mode of action is it's an insulin sensitizer. So it improves insulin sensitivity. So I didn't show you all the mechanistic studies that we have published. Soon after the IDPP was published, we have published about the mechanistics of how diabetes was actually, the prevention of diabetes was achieved mostly by improving insulin sensitivity as well as, of course, improving insulin secretion. Now, this can be achieved by lifestyle modification as well as with metformin, but improvement in insulin sensitivity is much better with metformin. So that is the major mode of action with metformin, not anorexia. The second question they asked is about acarbose. Of course, there have been good trials. You know, the STOP NIDDM trial, one of these trials done in Europe was using acarbose, and they found a 25% risk reduction using acarbose. They also found there was also a significant reduction in cardiovascular outcome. However, the next study, which is called the ABC trial, which is a very large trial done only in China, using acarbose by Rory Holman and Oxford group, found that, in fact, that was a primary cardiovascular outcome trial, which showed there was, in the primary outcome was not significant. There was no difference in the cardiovascular outcome. However, there was a 16% reduction in type 2 diabetes. So incidence of diabetes can be reduced using metformin, using acarbose, and there have been other small studies using glitazones. For example, we used prednisone. There is an Indian study using prednisone, and we found there was no significant reduction. But the ACT NOW study, which is done by DeFranco in the United States, showed there was a pretty drastic reduction, because they found almost 60 to 70% risk reduction in the incidence of diabetes. So mainly insulin sensitizers are probably the primary drivers which can reduce the incidence of diabetes, for the simple reason that in patients with impaired glucose tolerance, the major pathophysiology is insulin resistance. So therefore, there are other drugs which can be used. However, metformin is probably the best drug of choice, because this is a drug which has got minimal side effects. Thank you.
Thank you, sir. Dr. Unnikrishnan, sir, you have to say something or ask some questions.
Yes, of course. It's an honor to be in the presence of Dr. Ramachandran.
Yes.
That is a great honor for me. So your views on, there's a question that by a doctor that, this behavior change through SMS, and of course the behavior change in the Indian Diabetes Prevention Program study that you did. How was it compared to the DPP studies in the US? What is the cost difference of that? And there are a group of people like you also said that prescribing a metformin is probably cheaper than making people invest in diet and exercise and training and phone calls. So your views on the Indian aspects of lifestyle for prevention of diabetes and the economics of it.
Okay, you've got two parts of your question. One is the difference between DPP and IDPP in the behavioral outcome. The major difference was that there is a significant risk reduction in body weight, because I have a slide to show you that, but I have not shown you in the presentation, that both in the Finnish diabetes prevention program as well as in the American DPP program, the mean BMI of people who were recruited were 31 to 33, while the mean BMI of the patients who were recruited for the Indian diabetes program was only 25 to 26. And at the end of 3 years, we did not have a significant reduction in the body weight. Still, we managed to get almost 28 to 30% significant risk reduction in the incidence of type 2 diabetes. So the major difference was that. And then there was an intensive lifestyle program in those patients, while ours was a very moderate lifestyle program. So these are the two major differences between the IDPP and the DPP and the DFS from the effectiveness and the changes in lifestyle. The second part of your question was, what about cost effectiveness? There's a paper published again in 2011 in Diabetes Care about the cost effectiveness of interventions in primary prevention in India. And we have compared in one table the cost of preventing diabetes. The cost of preventing diabetes by a lifestyle modification alone is approximately $15,000 in the DPP, while ours is only $1,000. That is the difference. So as you rightly said, our interventions are much more cost effective. Definitely, of course, you don't have to compare the salaries of people we are using, but even otherwise, our intervention has been moderate, and probably one of the best ways of handling the diabetes epidemic in a country like ours, which is low middle income country, and the most cost effective way is perhaps preventing diabetes. So somebody asked me, what is the best way of preventing complications of diabetes? The answer was that the best way of preventing complications of diabetes is preventing diabetes. Thank you.
Thank you.
I completely agree. And I'm just reminded of one paper you published in a WHO consultation on the metabolic syndrome. And you had said that, there's no need for a term called a metabolic syndrome, and it's important to target only the complications. So, only the components, like, for example, hyperglycemia, dyslipidemia, hypertension. Could that be applied to pre-diabetes as well? That that concept that don't look for metabolic syndrome. If somebody has got borderline blood glucose levels, let's approach pre-diabetes individually, or do you think we should look at it overall?
Well, you don't have to call it a metabolic syndrome. But the reason why they were calling people with metabolic syndrome was good in actually predicting type 2 diabetes in future, as well as cardiovascular events in future. Unfortunately, there are other diabetes scores which can actually predict diabetes even better than metabolic syndrome. In fact, if you take just family history of diabetes, age, as well as body mass index 3 alone, that alone will actually give you a better prediction for type 2 diabetes in future. The other point is, as you rightly said, you do not have to worry about metabolic syndrome as a disease. If somebody has hypertension and hyperlipidemia with a little high blood glucose, probably has got insulin resistance. There are other surrogate markers which can go for it. So there is no sanctity or there is no great clinical diagnostic value in putting a name as metabolic syndrome, rather than look at the components and treat them accordingly. Thank you.
Okay. There is a question in the chat box from Dr. Suresh Shinde, sir. Sir wants to ask, how about proactively addressing the first-degree relatives of type 2 diabetic patient for diabetes prevention? Any efforts in this direction?
Yeah, of course. I can answer that in many ways. If you want to actually do a very large prevention program, it is not even necessary to actually screen people. You just use the risk model. For example, if you have a family history of diabetes, if somebody is obese and above the age of 30, 35, you apply the strategy for preventing diabetes. You don't have to test him. If you want to test him, that is an individual interest. But from the public health point of view, it is not necessary to test people who have risk factors. So if you have in the population people with positive family history of diabetes, obesity, and sedentary life habits, tell them you have a risk of diabetes. At any point in your lifetime, you can check your blood glucose and find whether you're pre-diabetes or you already got diabetes. But you can start intervention at a very early time. Absolutely right. Because screening for diabetes itself is expensive. But instituting intervention is simple, much simpler than that. So you don't have to brand people as pre-diabetic, but you can tell people you're at a high risk and then actually institute interventions. When you want to do and identify people by doing a test and then yield good results, then it is always better to test people who have a risk factor. For example, let us say the person who asked me that question wants to identify people with pre-diabetes in order to do a prevention. Let him not go and do tests for a lot of people, because you'll be wasting a lot of time, money, effort, and test strips. The best thing is use first the risk factors. Do you have a family history of diabetes? What is your BMI? What is your age? What is your type of work? You use these 4. If any 2 are there, test him. And then you will have better yield of abnormal people, which can be recruited into a prevention program. Okay, we have learned lots of lessons, so I can give you all the statistics for all this. Thank you.
Any other comments?
We have one more question in the chat box, sir. It is from Dr. Jayesh Shah. He wants to know. Sorry, sir?
It's covered, no? I think Dr. Unnikrishnan has.
I think the question is specifically on SMS, the behavioral changes on SMS for the diabetes prevention program that you did. So that's the paper you published on text messaging, mHealth, and diabetes prevention. The doctor is asking for the details of the behavioral changes you had given.
Okay, there is another paper which I published in Diabetes Research and Clinical Practice, which has scored the behavioral changes and looked at the different incidence of diabetes according to the score of the behavior. Please look at, and this is similar to exactly what was published in New England Journal by Jaakko Tuomelato in the Finnish study. Both in the Finnish study as well as the Indian study, the incidence of diabetes decreased as the behavioral changes improved. So there's a score given for behavioral change. Please look up I don't know who is the first name in that, Ram Jagannathan et al. In Diabetes Research and Clinical Practice. and Google for prevention of diabetes, you will get that graph, or I can send it to you. Yeah, the score, or better the behavior change, lesser was the incidence of type 2 diabetes. A beautiful correlation.
Thank you, sir. It's been, as usual, wonderful listening to you, and hope to meet you in a face-to-face meeting. Thank you, of course, Dr. Sandeep Tamhane. And may I hand over the mic to Dr. Rutuja and Dr. Shubhangi for the next session. Wonderful to have you here with us, Dr. Ramchandran sir and Dr. Tamhane.
Thank you, sir.
Thank you. Congratulations on the fantastic conference, and all the best.
Thank you, sir.
Thank you, Dr. Ramchandran. Thank you, Dr. Sandeep Tamhane, for your inputs. Thank you all.
Bye.
Thank you. Bye. Bye. So we shall move on to our next session. The next session will be conducted on cardiovascular care in diabetes. Dr. Abhijit Joshi will be chairing the session. May I invite Dr. Abhijit Joshi for the 6th International Diabetes Summit 2022 as a chairperson for this session. Dr. Abhijit Joshi is DNP cardiology and is well-known international cardiologist in Pune. I think everybody knows him. His special interest includes coronary interventions and heart failure management. He practices and also does coronary intervention at Chellaram Hospital as well as in other hospitals, Pune. I welcome Dr. Abhijit Joshi, and I request him to introduce our speaker, Dr. Sriram Godbole, for this session.
Yeah, thank you very much for the kind introduction. Firstly, or at the onset, I would like to congratulate entire team of Chellaram Diabetes Institute, Dr. Unnikrishnan, Dr. Purandare, and everybody for the wonderful conference, very knowledgeable conference, and we gained a lot in last 2.5 days. May I introduce a very renowned endocrinologist and diabetologist of Pune city, one of the pioneers, Dr. Sriram Godbole. He did his graduation and post-graduation from AEM Hospital, Mumbai, and then pursued his postdoctoral course in endocrinology at All India Institute of Medical Sciences, New Delhi. He has his clinic in the Institute of Treatment and Research in Diabetes and Endocrinology in Pune, also attached to Jahangir Apollo Hospital. He has been co-author to many books, especially Full Life with Diabetes, and he has been awarded with many awards, especially at S.N. Cooper Award Oration in Ophthalmology Conference, as well as Baliram Dubey Memorial Oration on annual conference at Nagpur. So Dr. Godbole is going to give us a very good insight in patients of diabetes who are at higher risk of coronary artery disease. Those who may not have suffered the event, but they are at the high risk of CVD. How we can prevent it with the use of newer medicines like SGLT2 inhibitor. Dr. Godbole, please.
Welcome.
At the outset, I must thank the organizing committee for inviting me here to speak at the International Diabetes Summit. And I shall be speaking on the use of dapagliflozin in high-risk cardiovascular patients and what the evidence foretells. Cardiorenal disease works in a continuum of which type 2 diabetes, which I'm going to focus on, is a cardinal point. Cardiorenal disease very often occurs on a background of various risk factors, which include diabetes, hypertension, dyslipidemia, obesity, smoking, altered nutrition, and through possibly various mechanisms that include, but not limited to, endothelial dysfunction, progresses to subclinical atherosclerosis and myocardial dysfunction on the other hand. And very often endothelial dysfunction is manifested as microalbuminuria, which is counted as a structural kidney disease. And then this progresses through stages of left ventricular remodeling, vascular stiffening, and finally ends up with coronary artery disease or diabetic cardiomyopathy on the one hand, but also in parallel leads to a loss in the eGFR with albuminuria, chronic kidney disease, ending in heart failure and cardiovascular death. If you look at the various randomized studies with SGLT2 inhibitors, they cover the whole gamut of patients, right from the multiple risk factor patient to the end stage heart or the renal disease patient. So you have Declare-TIMI 58 involving dapagliflozin, involving both types of patients, the primary and the secondary prevention cohort. You have the Canvas program doing a similar sort of cohort with patients. And then you have more sicker patients in the DAPA-CKD trial, in the Credence trial, and also in the DAPA-HF and the Emperor-R, which had reduced ejection fraction. In between, you had in the Emperor outcome trial, which dealt with essentially the secondary prevention cohort. Now, what I'm going to discuss is how does dapagliflozin fit into your high-risk cardiorenal patient? And we talk of high-risk patients in type 2 diabetes. You could have patients who are metabolically at a high risk, and this risk is very often defined by increased age, so elderly patients, as well as people with obesity, with high BMI and increased waist circumference. You could also have patients with cardiorenal high risk, which include patients that also have hypertension, a prior history of heart failure, chronic kidney disease, or some other cardiovascular event. Coming to age, now it is well recognized that we cannot have one uniform stringent goal for all patients who are elderly with type 2 diabetes. So probably you would aim for a more stringent goal like 6.5 or 7 to 7.5 or A1C in an elderly patient who is otherwise has a healthy functional status, who has no comorbidities, and who has a relatively short duration of diabetes. On the other hand, this goal is likely to be flexible anywhere between say 7.6 to 8.5 in an elderly patient who has a tendency towards hypoglycemia, a short life expectancy, comorbidities, various geriatric syndromes, a tendency to falls and fractures, disabilities, various functional impairment, and who's also on polypharmacy. If you look at the Declare-TIMI trial, you had patients in different age groups, and the data I'm showing you is the changes in the HbA1c, body weight, and the blood pressure as per the different age groups and the treatment allocation. So the line in blue is showing patients who are less than 65 years of age, the lines in red between 65 to less than 75, and the lines in green are patients who are more than or equal to 75 years of age. Now you find that the HbA1c, if you look at the top left panel, the HbA1c at baseline was relatively low in the elderly and the very elderly patients. But the change in A1C that occurred from the baseline was something similar in all the age groups. You can also see a similar trend in the changes in the body weight as well as the systolic and the diastolic pressure. Remember, Declare-TIMI trial had two primary endpoints. The one was, of course, the 3-point MACE, which did not show statistical significant benefit. But the other co-primary endpoint was the composite of cardiovascular death and hospitalization for heart failure. Now, in this primary endpoint, the dapagliflozin reduced this composite consistently in all the age groups. So even in the very elderly patient who are more than 75 years of age, this risk reduced by about 6%. If you now look at the Declare-TIMI trial, according to the BMI categories, and we are looking at data for hospitalization for heart failure, you're looking at different categories of BMI from normal through overweight, moderately obese, severely obese, and very severely obese. The red, of course, is the placebo. The blue is for dapagliflozin. And you find that as the BMI category increases, the risk of heart failure as seen in the placebo arm keeps on increasing. Now, if you look at how dapagliflozin impacts this risk of hospitalization for heart failure, throughout the different BMI categories, the relative risk reduction is fairly similar. But if you look at the absolute risk reduction, say, for example, 5.8 in the highest risk category or the very severely obese, you find that the absolute risk reduction for hospitalization for heart failure is best. The benefit is highest in those with the highest BMI categories. Now you come to the duration of diabetes. Remember, Declare-TIMI trial had a total of 17,160 patients, of whom around 2,206 had a duration of diabetes more than 20 years. And if you look at the first co-primary endpoint, which I already spoke about, the composite of cardiovascular death or hospitalization for heart failure, you find that in patients with a duration of diabetes of more than 20 years, the dapagliflozin significantly reduced the risk of this composite by 25%. And that was in keeping with the trend seen in the other subgroups according to the age less than 5 years, 5 to 10, 10 to 15, 15 to 20, and what I'm showing you is more than 20. But what's interesting is the right panel, the 3-point MACE, which was also a primary endpoint. Remember, the 3-point MACE did not significantly show benefit in the DECLARE-TIMI trial, possibly because of the nature of the cohort. They had patients both from the primary and the secondary prevention cohort. But what's interesting is that in those patients with a duration of diabetes more than 20 years, in fact, the risk of 3-point MACE also significantly reduced by as much as 33%. And this was statistically significant. This was not so in those with, for example, a duration of diabetes less than 5 years. Now, this significant benefit in those who had a duration more than 20 years was largely driven by the benefit for myocardial infarction and ischemic stroke. And this benefit was irrespective of whether the patient had a prior history of a myocardial infarction or any other sort of multiple risk factors. Coming to the effect of dapagliflozin on systolic blood pressure, which is, I think, fairly well known. This is data from a prospective double-blind placebo-controlled study involving 52 patients, of whom half of these patients were also monitored in the first 6 hours after they had received a single dose of dapagliflozin. And also the parameter was checked at the end of 12 weeks. So we have both an acute change as well as a chronic change. Now, both after a single dose, there was a reduction, a significant reduction in the systolic blood pressure by 7 ± 3 millimeters mercury. That's an acute change, but there was also a chronic change at the end of 12 weeks, which is something similar, 7 ± 2 millimeters with dapagliflozin. And they also checked certain levels of other parameters, for example, cyclic GMP, which is a vasodilator, and the level of cyclic GMP increased acutely following a single dose of dapagliflozin. So conclusion of this study was dapagliflozin administration in type 2 diabetes resulted in both acute and chronic reduction in systolic blood pressure, a reduction in vasoconstrictors, increase in vasodilators. Looking at another study done in 80 patients, this is a single center open label study, a randomized prospective study. You're studying, the patients are randomized 40 in a dapagliflozin arm, 40 in sitagliptin arm, and you're looking at these various parameters of lipids at the end of 12 weeks. Now, if you look at the lower panel first, you see that the LDL cholesterol in the dapagliflozin arm really does not change. Though I'll tell you later that out of 20 patients, out of 40, they did show an increase in the LDL. But this is important. The small dense LDL cholesterol reduced in the dapagliflozin arm by as much as 20%, and the large buoyant LDL cholesterol increased by 18%. These are all statistically significant changes. And in those patients, 20 patients in whom actually the total LDL cholesterol increased, actually the highest increase in the large buoyant LDL cholesterol was seen in this subgroup of patients. If you look at the changes in the HDL cholesterol, again, there is an increase in the HDL cholesterol by about 18%, but this change is rather in the 2C fraction, which is the cardiometabolically favorable marker, rather than in the 3C subgroup. So dapagliflozin suppresses the potent atherogenic small dense LDL cholesterol and increases the HDL 2C subgroup, and it does not increase the atherogenic risk. You know, heart failure is always a risk. If you have a history of heart failure, you're likely to have significant morbidity and mortality. So the risk of death rises sharply when the patient is admitted to the hospital for a decompensated heart failure. In the days after discharge, the patients with heart failure with a reduced ejection fraction are at a high risk of dying, and each successive hospitalization is associated with a greater risk of death in the long term. If you look at the DAPA-HF data, this involved, of course, patients who were diabetic as well as non-diabetic who had all reduced ejection fraction. And this is the placebo arm on the left and the dapagliflozin arm on the right. And the dark blue is showing cardiovascular death as the first event. and the hatched blue is showing cardiovascular death, which occurred as a subsequent event preceded by some other event. And heart failure hospitalization as the first event, and the hatched orange is showing heart failure hospitalization as a subsequent event. Now remember, in the total events, you find that dapagliflozin reduced the total events by 175. Whereas if you look at first hospitalization, there were 105 lesser first event as a hospitalization for heart failure in patients who were on dapagliflozin, and even heart failure hospitalization as a subsequent event was significantly reduced in these patients, from 97 events in the placebo arm to 78 in the dapagliflozin arm. So the number of extra cardiovascular deaths and hospitalization heart failure is significantly reduced with dapagliflozin. Now, this benefit of dapagliflozin in the DAPA-HF study was irrespective of the presence or absence of diabetes. It was irrespective of whether the eGFR was more than 60 or less than 60, across different ranges of systolic blood pressure, across different background heart failure therapies and various devices that were being used in those various patients, whether diuretic therapy was a part of that therapy, whether they were on background sacubitril valsartan or not. And also it was independent of the baseline ejection fraction, the heart failure etiology, whether ischemic or non-ischemic, and the baseline NT-proBNP level. So consistent effects across all the subgroups were seen in the DAPA-HF study. Coming to another study, the DAPA-CKD study, which was in a high-risk population, the primary endpoint was a sustained at least 50% eGFR decline, ESKD, and renal or cardiovascular death composite, and then you had various secondary outcomes. And this study actually had to be stopped early because of overwhelming benefit of dapagliflozin. So dapagliflozin in this study cut the incidence of worsened chronic kidney disease by an average of 39%, with the number needed to treat of 19 to prevent one primary outcome event after a median of 2.4 years. You can see the overwhelming benefit: 39% relative risk reduction for the primary outcome, 31% for all-cause mortality, 29% for the composite of cardiovascular death, heart failure, hospitalization, and 44% for the specific renal endpoint composite. So dapagliflozin has been proved to be a game changer. And in fact, it has been included as the guidelines have included dapagliflozin as a first-line drug in diabetic patients, type 2 diabetes, with established atherosclerotic cardiovascular disease. And with the DAPA-HF results, the DAPA-CKD results, the various international organization guidelines have now been updated. So this is actually now, in the Indian setting, the only affordable SGLT2 inhibitor for glycemic control, for heart failure with reduced ejection fraction, and chronic kidney disease. When you discuss the various SGLT2 inhibitors, you have three drugs: empagliflozin, canagliflozin, dapagliflozin, all with good, best assured utility in terms of benefit for renal events, myocardial infarction and stroke events, heart failure events, and even quality of life and life years. But then very often drugs with the best utility necessarily are not always cost effective. So in the Indian setting, actually, there was a very interesting questionnaire addressed to about 844 endocrinologists, diabetologists, cardiologists, family physicians. And in fact, 54%, majority of these physicians said that there's an issue of affordability with their patients. And therefore, they had to use drugs which were cost effective, but really do not have evidence. I'm referring, of course, to remogliflozin. So you obviously need a drug which is not just cost effective amongst these agents, but also, the best assured utility, but also cost effective. And now that generic dapagliflozin is available in the Indian market, I believe this was now soon becoming a mass drug treatment for all patients, including the categories I just spoke about. So take-home messages from my lecture. For decades, the good glycemic control was the only way to reduce the cardiovascular and renal risk in diabetes patients. Dapagliflozin has impacted type 2 diabetes, heart failure, chronic kidney disease guidelines across the globe to define a new standard of care to use it as a first-line treatment in patients with high risk and established atherosclerotic cardiovascular disease. In treatment-naive patients, dapagliflozin, of course, well tolerated, effective in reducing A1C, fasting plasma glucose, and weight. And now with the introduction of low-cost generic dapagliflozin, we now have an effective, safe, reasonable choice for treatment of type 2 diabetic patients with multiple risk factors and diabetic comorbidities. So dapagliflozin should be initiated in high metabolic, high cardiorenal risk patients as a first-line therapy. Thank you so much for your patient hearing and your kind attention. Thanks a lot once again.
Thank you very much, Dr. Godbole, for very excellent talk with overview of all the beneficial effects of dapagliflozin in cardioprotection, renal protection, metabolic improvement, and overall mortality reduction in heart failure. I have some questions. Can I ask you one question, Dr. Godbole?
Please, thank you.
Yeah. How would you change your prescription in a primary prevention, diabetes with primary prevention of high-risk ASCVD versus patient who have already had an event? So diabetic prescription I'm talking about.
So I would first look at the nature of the event, whether the event is primarily a heart failure event or it's primarily stemming from atherosclerotic cardiovascular disease. So for heart failure, I would prefer an SGLT2 inhibitor. For a patient with an atherosclerotic event, I would rather prefer a GLP-1 receptor agonist. So that does not prevent me from using the other agent as well amongst these two agents. Both the agents are complementary to each other. So I think a combination of the two would be the best. So in patients with a proven event, I would actually see that I use these two agents irrespective of the HbA1c at entry or irrespective of my HbA1c target. So patient may well be having an HbA1c of 7, but if he has a history of such an event, I would withdraw other drugs, for example, sulfonylureas, but rather add these two agents. So the type of agent would be a priority when there is already a history of event. And in fact, that would hold true even if the patient has multiple cardiovascular risk factors. I think my prescription would be exactly the same as if the patient has already had an event, if he has got multiple risk factors, but not exactly an event. So to me, these agents are very useful for this type of high risk profile of patients. But if a patient has got just 2 or 3 maybe risk factors, maybe I would be focusing more on the HbA1c with, of course, the hypertension, the statins, and so on and so forth.
Thank you. So if patient has a heart failure as an event, the first choice would be SGLT2 inhibitor.
That's right.
And if atherosclerotic cardiovascular disease as an event, that is MI or stroke, then you would be more towards DPP to start with, and you add SGLT2 in addition.
GLP-1 receptor.
Sorry, GLP-1, GLP agonist
Yeah.
and SGLT2 as a combination.
I might be using both as well.
As a combination. Okay. In Declare TIMI 58 trial, there was a very important message. If those patients who have had a MI within 2 years benefited in preventing their further MI than those who had MI beyond the 2 years, and those who had an MI benefited more than those who did not have MI. So your comment on this?
Yeah. So that was seen in the overall analysis of the Declare TIMI. The slide I showed you was specific to duration of diabetes, more than 20 years. But yes, what you said also was a pre-specified post hoc analysis where as you said, the benefit was best for myocardial infarction within 2 years, with the event being a myocardial infarction. Those patients benefited the most with dapagliflozin.
Yeah, thank you. Thank you very much. Over to you, CDI.
Yes. Any more questions? I don't see any questions in chat box. So, and we conclude after such a elaborative talk by Dr. Cheryl Sales. As always, sir, we are lucky to have both of you over this conference, and we'll see that we meet next time in person for the CDI. Thank you for your inputs, both Dr. Abhijit Joshi as a chairman and chairperson, and Dr. Sriram Godbole as a speaker. Excellent.
Thank you very much.
Thank you so much. Thank you. So we'll be moving on to the next lecture. We will conduct a speech on home glucose monitoring in 2022. To chair this session, I invite Dr. Rahul Dubey. He is MBBS Diploma in Diabetology from Mumbai University, consultant diabetologist, Group A Diabetes Care and Thyroid Clinic in Siagatol, Pune. And he also visits Noble Hospital, Pune, Diabetes and Pregnancy Clinic, Diabetes Unit, KM Hospital, Pune, Relax and Bhutani Hospital, Pune. I welcome Dr. Rahul Dubey for the 6th International Diabetes Summit today, and I request him to introduce to our speaker, Dr. Sachin Chittawar, today for this topic of meaningful glucose monitoring. Over to you, Dr. Dubey.
Yeah, thank you, Chelaram Diabetes Institute, for giving me this opportunity to chair a very important session, that is meaningful glucose monitoring. And to elaborate on this topic, we have Dr. Sachin Chittawar, who is an endocrinologist from Bhopal. He has done his MBBS and MD from Bhopal, then DM endocrinology from AIMS in 2012. He is attached to Department of Medicine, Gandhi Medical College, Bhopal, as assistant professor since 2004, and he's undergraduate and postgraduate teacher. He has, to his credit, 20 research publications in index journals, and he was awarded A.V. Gandhi Award in 2012. He has also got Rising Star Award, that is IDSI Mayo Clinics in Mumbai 2018. So over to you, Dr. Sachin Chittawar, and welcome to Pune.
Thank you, sir. Thank you for the kind introduction. Today I've been given the opportunity to talk about something which is, sir, good afternoon. Late
Welcome.
noon,
Welcome, Dr. Sachin. Welcome. I'm in 3 halls, so I just rushed across to say hello to you. Welcome and greetings.
Sir. Thank you, sir. So, dear friends, I've been given the opportunity to talk about meaningful glucose monitoring. So, at the outset, I will like to thank CDI, Dr. Unikrishnan sir. Thank you, Dr. Rahul Dubey sir, for introduction. The scenario of diabetes is changing very fast. So I'll be talking about the history, test, and a little bit about SMBG, CGM, and FGM, the flash glucose monitoring, which is the most updated thing which we have. So it all started by testing of the urine, usually a physician looking at the container of urine, using his senses of sight, touch, hearing, smell, and sometimes they used to test it. And they used to say, this is what the Western data is. And in our Charak Sanhita also, the Madhume word actually came from the sweet urine only. The clear test was introduced by AIMS in 1945 and utilized a copper reagent tablet that contained all the reagents required for a urine glucose test. This was very typical, blue solution, green, orange, and this. And that used to predict the amount of urine in the basically the amount of glucose in the urine. And this is something where it all started. The first glucometer was actually, it used to measure the blood sugar in the urine. So, and the bright start, the first blood glucose meters was somewhere around about 70, 80. And this again, AIMS went for this reflectance meter. And then later the dextrometer was launched in 80. And it could be operated by battery or mains power, and good correlation and precision were reported. And it was suggested that the dextrometer was suitable for home monitoring also. So not before 80, we had a glucometer kind of thing at a place where we can see the blood sugar at home. So that was way back in 1980. So with the 21st century emergence of smaller meters, because definitely whenever we develop something, we upgrade it. The same happened with our mobile phones, and definitely difference. Why not? This is even more important than mobile phones because it is measuring one of the vital signs. I will say the 5th vital sign in the human body is blood sugar. So the blood removal step was eliminated. Smaller amounts of blood was required. Electrochemical strips were developed. Wider range of hematocrit were permitted. New enzymatic test was there. So there was so many plus things, and it was launched by One Touch Ultra from Johnson & Johnson. So the evolution of CGM is that is the continuous glucose monitoring. Now it is taking us towards the insulin pump, and very soon the closed loop system, which has got AI-based algorithm, I will say the bionic pancreas. So definitely we are heading towards something where it will give more autonomy to our patient, and the procedures will be very convenient with respect to blood sugar recording. This is the freestyle liver flesh glucose monitor, hybrid between glucose meter and CGM, and does not require calibration finger sticks. And each sensor lasts for 2 weeks. It's very typical. You must have seen so many of our friends are now using it. And though it is kind of more of a fancy item, but definitely it makes a patient to realize whenever he feels he can correlate his sugar values with that. And one thing which is very important, these kind of flash devices, they measure the interstitial blood sugar. So there is a lag of half an hour, around 30 minutes, and it is gradually inching towards the exact value. I hope in the coming years, we'll have even the better options what we have today. The test of glycemic control, the plasma glucose, whole blood glucose, urine glucose, and then came the glycated hemoglobin and fructosamine. So the plasma glucose measurements, there were methods, so I will not elaborate. This is just to mention how the story has grown up to the CGM level. So the enzymatic methods are preferred nowadays, and the urine glucose measurements, they're using the Benedict stats, and it has the advantage of cheap, convenient, easily available, but one-to-one correlation with blood sugar values, because the glycemic threshold for glucose, the renal threshold for glucose, is something which is variable, and over the top of it, there are some patients who have renal glycosuria, the familial renal glycosuria. There it cannot correlate to any extent. This was the classical Benedict test, and it is important at this point of time, we should not give up the Benedict test, because it is here only the story started, the blue, green, yellow, and the subsequent values. So this is very important. So the urine analysis, the dipstats also came in, and it basically worked with the glucose oxidation, and the darker, and there was a color chart, and we used to easily manage it, and we are still using it for ketones. So dear friends, the blood glucose monitoring, the goal was to maintain blood glucose within the target range. We all know. Immediate benefit was maximize learning and participation, identification of the treatment, and prevention of the lows and highs. Long-term benefit was there, and many variable impact blood glucose. So the challenges are there, and definitely are people who are really working hard with respect to the science. They are the ones who will be delivering it, what we want in future. Serum fructosamine, again, the half-life of fructosamine similar to that of albumin. So the last 14, 15 days, we can have a glimpse of the blood sugar in the last 14 days. That is something which will come, and which will definitely come in routine. We are using it, but not to that extent right now. And the HbA1c, there are so many methods. Dear friends, you should know about the HPLC based methods, and the NGSP certification, and the IFCC certification. Any machine, use it. Usually the preferred one is the HPLC one, and it has to be certified by NGSP. So the self-monitored blood glucose, this is what my story of today's lecture will revolve around. The self-monitoring of blood glucose is very crucial for those diabetics who are on insulin. As we all know, the pregnant ladies, patients who are on larger doses of insulin, and definitely, why not, type 1 also, where they're showing a lot of brittleness, multiple episodes of hypoglycemia. So to achieve best glycemic control, it is essential to know how you daily do the blood glucose, or how the blood glucose are fluctuating in the entire day. And it is easier for a diabetes specialist to adjust drugs or to adjust titrate insulin dose if proper self-monitoring of blood glucose record is maintained by the patient. And this is the data where it's showing the regular SMBG performer. See the yellow bar, it's clearly showing it's towering over the persons who are not doing SMBG, and the HbA1c is less than 8. And even in those where the HbA1c is more than 8, it is amongst those people who are not doing the self-monitoring of blood glucose. The self-monitoring of blood glucose, it helps in controlling sugars, it helps in preventing the variability, it helps in detecting with respect to the episodes of hypoglycemia. and it improves glycemic control irrespective of the diabetes type. See the data for type 1 diabetes, the adherent one who are doing SMBG, see the HbA1c value in type 1 patients, and see those who are not doing it. For type 2 plus oral hypoglycemic agent plus type 2 with lifestyle measurement, it is towering over the control part in all the segments, whether it is type 1, type 2, or type 2 diabetes with tablets, type 2 diabetes with lifestyle modification. So the SMBG reduces the morbidity and mortality, and see the morbidity is significantly low, 0.002 is the p-value, and the same is for mortality. So now we have got an intervention, a modality which is helping, and that is the 7-point self-monitoring of blood glucose. The most accurate form of SMBG in daily life is the 7-point charting system, where one can fill blood glucose readings taken on 7 occasions in an entire day. And this is, dear friends, it helps in maintaining the sugar levels and allaying or delaying the complications of diabetes and bringing down the HbA1c. Glucose sensor now, apart from we are going beyond SMBG now. The continuous glucose monitoring system was the first to be launched. It had its own limitations. Then the GlucoWatch, automatic biographer, navigation, near infrared, and the implantable glucose sensors like Dexcom, optical sensors. There are many more to come in future. So these glucose sensors are to be applied subcutaneously over the skin, and then it can be monitored through your smartwatch or through the sensor. So this is there. And the continuous glucose monitoring system, it measures glucose concentration in interstitial fluid, as I was talking about. There are 2 types, the real-time or personal. It continuously displays blood glucose levels, or the blinded or professional captures blood glucose level that can be downloaded later. There are now glucometers, which if you apply the sensor over, machine over the sensor, immediately it will tell you the blood glucose level. And there are many of our people who are using it. There are many of our patients, even without medical advice, they are using it. So this is how the era is changing. Dear friends, we need to gear up because patients have already accepted this modality of treatment. So the real-time CGM has been shown to reduce A1C in adults and children with type 1 diabetes with or without pump in adults with type 2 diabetes and reduce time spent in hypoglycemia. So the successful use of CGM is dependent on adherence, duration of the time used. So this is the continuous glucose monitoring. Now it's an older concept. Now we have got better devices, even better than what has been shown in the slide. The continuous glucose monitoring is a tiny glucose sensing device. A sensor is inserted just inside. We all know about this. And initially it was up to 7 days. Now the newer ones, they are even claiming to record the sugar recordings up to 14 days. So that is something, the newer advancement. The fear of hypoglycemia is recognized as a number 1 barrier and for achieving the good glycemic control. So CGM will tell us the present sugar recording. Hypoglycemic unawareness is whenever there is a brittle diabetes, people are unaware of hypoglycemia as a complication. And worry about lows leads to avoidance and suboptimal control, can reduce A1C and glycemic variability and improve quality of life. This is talking about 158 patients of type 1 diabetes on insulin injection, and mean age was 48 years, and baseline was A1C was 8.6. So greater A1C reduction at 24 weeks with CGM. This is significant and definitely different. It helps. Hypoglycemia time cut in half with CGM. This is also significant. And see the interpretation, because nowadays we are aspiring for this time in range, and these kind of devices, when set, the lower limit is set around 70 and the upper limit around 180. So we want majority of the time our sugar should be between 70 to 180, and that is what we call time in range. And if it is falling, the instrument will tell us regarding time below the range, and we want to even we don't want that any of the time our sugar should go time below the range. Time above the range, there nowadays they're talking it should be somewhere around about 2.53%. So dear friends, the era is changing very fast, and we will like even aspire to have time in range almost near 100%, but the days are to come, and we need to have better modalities and better treatment also. What CGMs are out there? Definitely the Dexcom G5, the Medtronic Guardian 3, Medtronic Enlite, Dexcom G4, and definitely the Liver Pro devices, the Freestyle Liver Pro device, professional CGM, blinded to the patient, 14 days of the data, and then it shows in the chart form, and you can easily interpret. And if you want, you can have early retrieval of the data within 3 days, 4 days also. So a lot of liberty has been given to the doctor, and he can bring out, I will say, if you'll say in Hindi, it is like a kundli where you can see where the grahas are being positioned. So nowadays, this modern medication is allowing us to see blood sugar values at any point of time and take rational decisions. So the indication is definitely A1C, when the A1C is above goal, preconception, pregnancy, history of severe hypoglycemia. Hypoglycemia unawareness is basically a deadly condition. Over the top of it, there is diabetic dysautonomia, multiple episodes of hypoglycemia, brittle diabetes, glucose variability, patient's willingness to calibrate sensor with finger sticks, and the basal bolus insulin therapy. So definitely the documentation tips, definitely it will record hypoglycemia unawareness, and there are so many things which definitely help when we are not able to document nocturnal hypoglycemia or recurrence of severe hypoglycemia. We can take help of these modern modalities. And over the top of it, the flash glucose monitoring, which is the most upcoming one, measures plasma glucose in interstitial fluid, blood glucose value displayed when sensor is flashed with a reader device on demand, also displays plot profile of last 8 hours. Sensor can be worn for 14 days and has been shown to decrease the time spent in hypoglycemia in type 1 and type 2 diabetes. So dear friends, to summarize, this particular measure to measure the fifth vital sign of the human body, that is the blood sugar, which nowadays many of us are saying blood sugar is the fifth vital sign. And in this era of COVID, we know the importance, how the sugars have gone bad with respect to control, and over the top of it, there were so many medicines which were given. So these devices have come up as a new modality which will offer us to see the glucose control and improve the glucose control. And it has shown the growing evidence, and it is effective and will play a key role in diabetes management and for the reduction of A1C, reduction of variability, reduction of multiple episodes of hypoglycemia. And it is a safe, usable, simple device for all people. And it is no wonder that they are preferred by patients and providers alike. So meaningful glucose monitoring has ever-changing definition in coming days. We may come across sensors which may need not require any kind of subcutaneous device to be implanted. So the days to come, I'm very much hopeful of diabetes management and the empowerment to the doctor and patient. Thank you. Thanks a lot for giving me this opportunity.
Thank you very much, Dr. Sachin Chittawar. That was very good, exhaustive lecture on the glucose monitoring, starting from history, the during glucose to flash glucose system. Now, I have one question. See, this corona period has seen that many patients are like not doing their monitoring, etc. Okay, so how to once again tell patients to go for meaningful glucose monitoring so that the sugar control could be good and we can avoid the complications?
Yeah, very relevant and pertinent question. Now, in the third wave, people are not very much worried about corona and blood sugars also. This is also true. There were some initial reports which said that now patients are coming more, but that is not true in our part of India. I don't know about Pune and Bombay. It might be the same. So that has a little bit have made them more relaxed. They are now more casual about the blood sugars. So whenever they are coming to your clinic, we need to show what I say in my clinical practice. I compare the blood sugars as if the treatment for sugars is like playing cricket, the 2020 cricket, the IPL cricket, because people are more accepted. They accept things which are in their life. And I say fasting, PP, and postprandial and HbA1c is like your run rate. The fasting should be around 100. PP should be less than 180, and the A1C should fall somewhere around about 7%. And in 2020, the importance of dot ball, people are very much aware. Whoso is a great fan, majority of us are. So I just tell them, you need to have the sugars normal every day. Otherwise, it will be counted as dot ball. And the moment you know what happens, even Virat Kohli is playing, and if there are more of dot balls and you're not scoring as per the run rate, you're bound to lose the match. So losing the match, definitely you need to sensitize them for the microvascular complications. And the moment we touch them like this, they are more aware of it. And then definitely for the ones who are actually not getting the grip of the sugar values, they are the ones where we can promote. We can say, you can have this chip, please apply it for the next 14 days. It will give you a rough picture, what were your sugars were, and I'll be able to help you in if the case is brittle, and if the patient is dipping some point of time late in the night or early morning, that is the point where the patient cannot be awake and we cannot expect them to do the blood sugars. That will help us, and the variability part will also go. So we need to actually take more personal initiative. At a personal level, we'll have to counsel them, and we'll have to talk in their own language, because these kind of CGM, monitoring, and our variability, this is something, it is for the fraternity, it is not for the patients.
Absolutely. That is very good example, that cricket and IPL and Virat Kohli. I think patient can relate that these things very well to the scenario. Any other question from chat?
I don't think we have any questions in the chat box. What about the affordability of these devices?
Yes, ma'am, that is a major limitation. Yes, sir. Yes, ma'am. That is a major limitation. But there are now some of the companies who are doing philanthropy. They are offering this services as a kind of patient service from the even they ask us just to just give the name, and then they are doing it on our advice. So definitely for those who are not affording, we have this option right now. And there are a good number of companies who are actually offering this free of cost to the patient. So that can be for those patients who are not affording, but I fully agree the cost of the treatment for the liver fresh device is around 5,000 rupees. So that is something which has to be brought down, and that is the need of our. But anything which comes costlier nowadays, see the previous lecture also, the molecules was very costly initially. Now it is being available as a generic molecule. So I still hope in the coming days we can have a generic or cheaper version of these kind of devices.
Thank you so much. Any more questions, Dr. Rahul Dobe?
Yeah, so what could be the future of this monitoring devices? What do you expect in another 4-5 years, or maybe down the line 10 years? This invasive thing going non-invasive, something like that, sir?
It is bound to take us towards artificial intelligence-based modalities. The closed loop pumps have recently been launched. People are now using it, though it is not available to all, to the masses. But very soon in the coming years, the things are going to gear up towards artificial intelligence-based algorithms, and the system, the closed system, will predict regarding the sugars, and the insulin delivery will, I think we will be the observers, and it will be, the decision will be taken by the machine which is there in the form of a small pump. So that is a possibility, because bionic pancreas have already crossed phase 3. There are so many other options which are coming. The closed loop pumps are also, and these kind of devices, they are a step towards that only. And especially in type 1, type 2, type 1 diabetes, where we have a problem with respect to sugar control, this will be a big thing.
Okay, so we'll be like reduced to only observer. So we'll be out of.
There are so many permutations and combinations which will come, but it is very easy. Even there are some of my friends who are working with artificial intelligence. They are developing algorithms for type 2 diabetic patients, and they are almost claiming they are about to. They are just nearing to just make a breakthrough. So if it is there in India, then definitely the people in West might be way ahead of them.
Okay. So if there are no other questions, I think I'll give mic to best hall personnel from Chedlara.
Thank you, sir.
Thank you.
Thank you very much for a wonderful talk on meaningful glucose monitoring by Dr. Sachin Chitawar and the chairman, Dr. Rahul Dobe. That was very interesting session indeed. Thank you so much. So we move on to our next session.
The topic is new insights into mitochondria-based targets, and I have the pleasure of inviting the chairperson for this session, Dr. M.V. Hegde. Dr. M.V. Hegde is professor at the Center for Innovation in Nutrition, Health, Diseases in Real World Nutrition Laboratory Foundation, Bharatiya Vidyapeeth, Pune. He has taught biochemistry for the past 33 years at postgraduate level and retired as professor and head of the Department of Chemistry, Pune University, Pune. He has guided MSc, MPhil, PhD students. He has also guided MS, MD, MDS, MBS students on research. He has been a visiting scientist at Sloan Kettering's Cancer Center and at Albert Einstein College of Medicine, New York. He has published over 75 research articles and presented at international forums at Vancouver, Saskatoon, Madrid, Paris, Sydney, Dubai, and Singapore. Post-retirement, he has focused his research on omega-3 nutritional security by developing technologies for enriching poultry, dairy, bakery products by implementing the flax biovillage concept at Bharatiya Vidyapeeth, Deemed University. He has entitled a book, Omega-3 Fatty Acids, Keys to Nutrition and Health, published by Springer International. He has earned several awards, including 2 Lockheed Martin DST Gold Medal and 2 1 lakh cash awards, each for a best paper, each which were a best paper awards, and a Vishesh Seva Award. He has received grants from World Bank, ICAR, DST, DBT, CSIR, and UGIS. Welcome on board, sir, to Dr. M.V. Hegde, and we may please start the session. Our speakers are already there with us. Welcome to all the speakers as well. I can see Dr. Rakesh Sahai, Dr. Tiny Nair, and I think Dr. Chaudhary is yet to join. Am I audible, sir? Dr. Hegde? You have to unmute yourself, so you're not audible. Dr. Hegde, you have to unmute yourself.
Am I audible now?
Yes, sir. Now you're audible. Yes, sir.
Okay.
Dr. Rakesh's CV is there. Can you please read his CV? Can you see it, sir?
Yeah, I can. First, organizers.
So you're not audible.
Am I audible now?
Yes.
No?
Yes, sir. Yes, sir. Please go ahead.
Let me thank the organizers and particularly Dr. Unikrishnan for giving me this opportunity to share this session on mitochondrial dysfunction in diabetes. Mitochondria is a very fascinating organelle, and it has several functions to do. And I am happy to introduce Dr. Rakesh Sahai, Professor of Department of Endocrinology, Osmania University Medical College Hospital, Prime Hospital Sahai Endocrine Diabetes Center, Executive Member of RSSDI and API Member, Secretary Endocrine Society of India, Founder, Secretary South Indian Asian Federation and of Endocrine Society, former Chairman of the AP Chapter RSSDI and Hyderabad Chapter API, Associate Editor of IIGAM, Editor Journal of Academy of Medical Sciences, Fellowship of American College of Endocrinology in 2009, Fellowship for RSSDI 2015, Fellowship of Indian College of Physicians 2006, Fellowship of Indian Academy of Clinical Medicine 2008, highest Senior Fellowship Oration Association of Physicians of India for 2008, over 80 publications in journals, textbooks, monogram on diabetes and endocrinology. Welcome, Dr. Rakesh Sahai. Let's look forward to the speakers who are going to give a talk on mitochondrial dysfunction.
Thank you. Thank you, sir, for the kind words of introduction, and
thank you and congratulations to both Dr. Unni Krishnan, Dr. Savita for being here and for inviting me to be here. And I would, my job is actually, I'll be just introducing the subject because we have two star speakers in the form of Dr. Subhankar Chaudhary and Dr. Tiny Nair, who are going to take the presentation forward in this session. I'll be just introducing the topic, introducing this concept of which has come up and how this is going up. So what we are trying to discuss in this topic on mitochondria based mitochondrial dysfunction, how it's contributing to the metabolic diseases, is what we are trying to discuss today. And as we all know, we are going through this pandemic of what you call non-communicable disease, and the culmination of all these non-communicable diseases in the form of cardiovascular disease. That is the major cause of morbidity and mortality. And the major drivers for this epidemic of cardiovascular disease, as you can see on the right side, you are seeing the prevalence of cardiovascular disease in India, which is growing across the nation. As you can see, although there are differences in terms of different areas having different states having different prevalence rates, but by and large the prevalence rates are very high. And they are growing over the years. We are seeing that these prevalence rates are increasing, going higher and higher. And if you look at the prevalence of diabetes, we know that today we have about 78 million people with diabetes across the country, and we are saying that the major drivers for the cardiovascular epidemic are diabetes, hypertension and lipid abnormalities. And if you look at the various combination of this, you can say that you can say that if you're looking at hypertension itself, I mean, if you're looking at there are at least about 42 million people today. I mean, while we are speaking about 78 million people with diabetes, if you're looking at people with any of these three conditions, that is dyslipidemia, diabetes or hypertension, the number goes up to about 424 million today. And over the years, it's going to go up to it's going to become almost another 50-60% increase is going to happen, and we are going to go almost to 628. That is a projected figure, but very often what we see is that we reach that projected figure even before that time comes. So it's important that we look at the major contributors towards all these factors, because we look at a unifying hypothesis and you try to understand what is driving these three conditions and try to understand how we can prevent their numbers from increasing so high. So that's the concept of, I mean, that's the purpose for this session today. And what we are saying is that if you're looking at type 2 diabetes and dyslipidemia, that contributes about 79% of Indian type 2 diabetes population has dyslipidemia. If you look at that is data from the INDIAB study. And again, if you look at the number of hypertensives amongst the diabetics, there's again 33%, or 1/3 of the patients with type 2 diabetes or people with type 2 diabetes have got hypertension. So the numbers are very huge. And if you look at all the three together, there are about 17.4 million people with all the three of them. And so these are all huge numbers, suggesting that these three factors need to be you need to look at a unifying concept or unifying reasons why these conditions are developing. They are just manifestations. They are different sides of the coin, because what we are seeing is that we need to get a unifying concept to understand all these disorders. It's not that people with diabetes are different from those who develop hypertension. It's not they are not different from those who present with dyslipidemia. It's all a continuum, and that's what has been proposed to explain this. And this is what is called the cardiometabolic based disease continuum, which we are speaking of today. And so this concept takes us away from the glucose-centric approach, which was very commonly followed till now. We are going towards we are going towards a unifying approach, where we are saying that we are not focusing just on the glucose levels or glucose targets, but we are looking at the cardiometabolic spectrum and trying to prevent that as such. And if you look at the major drivers towards these conditions, we are looking at a sedentary lifestyle, we are looking at a unhealthy diet, we are looking at the growing obesity, we are looking at genetic factors which are probably contributing, and epigenetic mechanisms through several epigenetic mechanisms, they are all contributing, and then the increased free fatty acid levels coming from the unhealthy diets and all the other components contributing to that. So ultimately what we are saying is that all these lead to insulin resistance, beta cell dysfunction, lead to cellular glucotoxicity and lipotoxicity, and which is driving to a mitochondrial dysfunction, and that manifests in different forms as hypertension, diabetes, dyslipidemia. So if you look at so a integrated approach is what is the need of the hour, and this concept proposed some time back by Osama Handi and his colleagues and others have proposed this concept where you're looking at a unifying concept. You're not trying to say that these are different conditions. We are speaking of ABCD, which is adiposity based chronic disease, or we are speaking of dyslipidemia based chronic disease, or you're looking at cardiometabolism based chronic disease model. So these models have been proposed to provide a unified understanding about this entire concept, about the factors which are contributing towards the cardiometabolic dysfunction, which ultimately culminates in cardiovascular disease and significant morbidity and mortality. So if you try to dissect out that, what you're saying is that in the ABCD model we are looking at adiposity based cluster, where you're looking mainly at the adiposity or the obesity based factors, and that can also culminate towards cardiometabolic disease, cardiac disease. Whereas if you start off with some people who start off with dyslipidemia, they also go on to develop or dysglycemia based chronic disease model, where again the focus is on the glycemic levels. So they tend to progress towards from pre-diabetes to diabetes, and then go on to develop macrovascular disease and microvascular disease. And others are those who have a combination of both the dysglycemia, they have the hypertension, they also have the lipid abnormalities and the obesity, and they all ultimately culminate in cardiovascular disease. So that is the concept that we are trying to use to understand, to have a better understanding about the problem. And I have great pleasure in introducing the next two speakers who will be speaking about this in greater detail, so that we can understand this better. So with that, I will stop sharing my screen, and I think we'll move to the other presentations from Dr. Shubhankar Chaudhary initially, and then Dr. Tiny Nair.
I think next is mine, and Dr.
Aja, sorry, okay.
So I think again it's already pre-recorded. Ask the organizers to.
Yeah.
Can we please have the CV of?
Yeah, if the CV is there, I can. Yeah. Our chairperson can introduce, or I can also do that.
Yes, anybody.
Yeah. So Dr. Tiny Nair is very well known to everybody here. He is the head of Department of Cardiology at PRS Hospital in Trivandrum. He has many awards to his credit. He is a very distinguished speaker. He has won the Best Doctor Award from the Government of Kerala in 2006. He is probably the most inspiring doctor. He was given this award by the Economic Times in 2019. He is a prolific writer. He is on the editorial board of many international journals, and he is author of several books. I think the most important ones are his books on magic of Indian medicine, and he has got several orations to his credit, and he has actually been one of the TED speakers, a very prolific speaker. I have great pleasure in requesting him to deliver his address on mitochondrial dysfunction contributing to cardiovascular disease.
Welcome to all of you. We'll shortly play the video.
Good evening, ladies and gentlemen. Today we'll discuss about diabesity and mitochondrial dysfunction. Basically, setting the stage for Dr. Shubhankar Chaudhary to tell us about the newer interventions targeting mitochondria in the field of diabetes, obesity, and metabolic syndrome. Let's start with a little bit of confusion. Lambert Adolphe Jacques Quetelet was truly a genius. He was a mathematician, a physicist, an astronomer, but not a biologist. He didn't understand biology at all. And he was given the job of trying to find out in Belgium a clue as to how to mathematically separate people who are healthy metabolically versus people who are unhealthy and obese. So Quetelet went back to his drawing board and drew this picture, a real-time picture of children, young adults, teenagers, and elderly. And then he tried to look at their physical parameters. He drew their height, drew their median weight, and tried to find out some formula to predict which connects all these different age group people. He could not find a formula, so he tried different kind of formulas and finally stumbled upon something unusual. The weight in kilogram divided by height in meter square, and that gave him something that we today know as body mass index or BMI. Now the point is, when he was asked as to why did he suddenly square the height in meters, he didn't have an answer. He said that the best way I could fit in the graph. So it was just kind of fitting the graph. And this doesn't work everywhere because he didn't understand that a person can have huge bit of muscle, and muscle is heavier than fat. A hefty person with a lot of muscle who weight more and end up with a higher BMI, who might be perfectly healthy but show a BMI in the range of overweight or obesity. Now let's check it out in our population. This is the data that came in the Lancet 2 years back, where the body mass index and cause-specific mortality in India was looked into 500,000 adults. So body mass index versus cause-specific mortality. Now look at the data. On the x-axis, we have body mass index. On the left, we have Chennai, India. On the right, we have Europe and North America. Now, the European values, you can see it's linear, which means higher the BMI, the cause-specific mortality progressively increase. But wait for a moment. The Chennai, the Indian data is different. BMI did not predict our cause-specific all-cause mortality in India. So BMI is not predictive of outcomes every time. In fact, this crossed the borders, and I did this expert analysis in JACC just about a year back on more than skin color, ethnicity-specific BMI cutoffs in different ethnic population. Now that brings us to more and more confusion, right? Confusion in multiple areas. One, the area of definition of metabolic syndrome. All these years we thought that metabolic syndrome, the center stage, is cardiovascular disease, which is surrounded by a host of abnormalities like high triglyceride, low, high LDL, low HDL, inflammatory markers, elevated sugars, elevated uric acid, high blood pressure, insulin resistance. Today we know that we were wrong. In fact, the CVD and type 2 diabetes has moved to the periphery, with center focus being intra-abdominal obesity. Now this complex interplay should be understood here. For example, if you look at the Zucker rat, which is an animal model, rat model of obesity, right? So the Zucker rat is obese, normal rat is not. Similarly, if you look at the DBDB mouse, the typical mouse model of diabetes, again, the DBDB mouse is obese. And naturally, our focus is on the obese person, thinking that this would be diabetic, which turned out to be not very correct when we look at the BMI of the Indian patient. Second is the kind of food that we eat. We abuse carb. Whether you take a standard South Indian meal, South Indian snack, parathas, North Indian breakfast, or the kids that they have in the school or what they drink. Yeah, we abuse carbohydrate right from childhood in our diet. That's challenge number 2. And the third is this. Indian metabolic syndrome doesn't look like this at all. The BMI doesn't predict it. So we are kind of invisible metabolic syndrome. So we are not this kind of fat, but have more of visceral fat, what we call as thin outside, fat inside, or TOFI. More of visceral fat and less of subcutaneous fat. In fact, this had been covered from the cardiologist perspective by excellent coverage by JACC Focus Seminar, where now we have 2 different subtypes. One, we have those with functional subcutaneous adipose tissue, where there is no free fatty acid spillover. This is what we see in the Western population. In contrast, in our population, the so-called excess of visceral fat has a higher fat cell size density and tend to have higher FFA spillover, giving rise to fatty liver, fat around the heart, and of course, all the complications and manifestations of cardio-diabetic metabolic syndrome. Right. So clinically, how do we go? Now, one clue clinically would be to look at the waistline. Now, if the waistline is more than 90 for men, and if the triglyceride levels are more than 177 milligram per deciliter, is an indication of what we call as hypertriglyceride waist, telling us that this gentleman is likely to have a cardiometabolic syndrome. And not just that. So these clinical parameters are simple and can be easily measured by a physician. Moreover, a waistline reduction of more than 4 centimeters in such a background would actually drastically improve his cardiovascular outcome. So for the cardiologist today, our focus is on waistline and triglyceride, trying to pick up that thin outside, fat inside, visceral adiposity, which is at the center of the problem of diabetes, obesity, and metabolic syndrome. Before we finish, let's take a deep dive here. Now, we know that what we see on the right is the chromosome uncoil it, and you get finally the DNA strand. And the DNA is basically like a digital archive, right? The digital archive, digital data is stored in 0 and 1 binary, while the DNA is in quaternary of ATCG. Now, exactly like digital data, DNA is very resilient. It's safe. You burn it, you heat it, you boil it, you hammer it, you beat it, but still a little bit of DNA, you can get the data out. So DNA, that's why from crime scene, we try to detect even with a wee bit of DNA, right? So, but the problem is DNA is also not changeable like the digital data. But histone, see those, around those woolly bubbles where the chromosome goes around is histone. Histone is something like an analog counterpart, where histone decides which gene will be silenced or which one to be promoted. And today we know that cardiometabolic syndrome is an effect of abnormal de-acetylation and methylation of certain genes that are either silenced or promoted. For example, my brain cell doesn't manufacture melanin. My skin cell doesn't manufacture serotonin. That is because still with the same genetic background, they are silenced at the histone. Now, the good news is that today we know exactly how genes are silenced and inactivated. And today we know that even in our own lifetime, therapeutic maneuvers, not just drugs, simple lifestyle maneuvers like exercise can actually have a potential effect on inhibiting abnormal de-acetylation methylation and preventing to a certain level on cardiometabolic syndrome. So today we have the ability to not change our genetics, but alter the epigenetic expression of our genetic background that we have. And second brings us to the kitchen, the mitochondria. We today know that there are very critical areas of mitochondrial metabolic chain connectors which alter in the long term in cardiometabolic syndrome. And if we can tweak them, we can have a better outcome in cardiometabolic syndrome. So where are we finally? So if we are looking at epigenetic processing, we're looking at abnormal adiposity, looking at endothelial insulin resistance. We are looking at immunometabolism. We are looking at metabolic cardiomyopathies. And all of these are translated through the very delicate energy metabolism in the mitochondria. So in conclusion, ladies and gentlemen, cardiometabolic disease is epidemic in India. Cardiometabolic disease is an epidemic in India. The invisible obesity marked by a so-called near normal BMI and a normal weight is often missed out. A triglyceride of more than 177 milligram percent and a waist size of merely more than 90 centimeters is a good indicator of presence of cardiometabolic syndrome. Exercise and simple maneuvers can actually change our epigenetic programming and giving us long-term outcome. The core here, which Dr. Shubhankar Chaudhary would go in a moment's time, is focus on epigenetic change and mitochondrial inflexibility. If we have a method of correcting the mitochondrial inflexibility, certainly we would at least partially try to correct the cardiometabolic disease and fight this epidemic in India. Thank you for your time and attention.
Thank you so much, sir. I request our chairperson, Dr. Mahaveshwar Dhikwe, to introduce the next speaker. Can we have a slide of Dr. Shubhankar Chaudhary over? So you're not unmuted, sir.
Am I audible now?
Yes, sir. Now you're audible. Thank you.
Sorry. This introduce Dr. Shubhankar Chaudhary. Dr. Shubhankar Chaudhary is professor and head Department of Endocrinology, IPG, ME, and R, and SSKM Hospital, Kolkata. He is secretary of the West Bengal chapter of the Research Society for the Study of Diabetes in India, RSSDI, and immediate past president of the Endocrine Society of India. He is also a founder, patron of the South Indian Federation of Endocrine Societies. Welcome, Dr. Shubhankar Chaudhary. Let us have your talk and then we'll discuss.
The talk is recorded. I'm sure the organizers will play it. Very good afternoon. First of all, thanks to the organizers of this International Diabetes Summit, which has been a great event over the years, organized by Chellaram Diabetes Institute. I'm especially thankful to Dr. Unnikrishnan and his team for giving me this opportunity. And we've already heard about mitochondria, and I'll take you through how it can have a very exciting potential role in therapy of cardiovascular disease and disease risk modulation. So we talk about mitochondria, and let me try. So my only conflict of interest in relation to this particular talk is that I happen to be an advisor in the core scientific steering committee of Torrent Pharmaceuticals, who are in the process of, I understand, maybe developing something to excite us therapeutically in this field. Now, we all know that in India, at least 50% of all heart attacks are below the age of 50 years. So no longer is it just a disease of old age. And even 25% of heart attacks are seen in patients below 40 years. And we're also seeing strokes, brain strokes, occurring at younger and younger ages in our country. And that brings us to the interlinking of the cardiovascular risk factors. And we talk here especially the burden in India. And we all know type 2 diabetes is a major factor that binds together, that brings together various cardiovascular risk factors and increases cardiovascular disease risk burden very significantly. We need to remember that we start with possibly the soil sort of. We have a large number of individuals of which very significant numbers develop pre-diabetes, and we should try and understand how they do so. Out of them, a certain proportion develop frank diabetes, type 2, and we know the numbers are quite big. We have at least 65, 68 million people with diabetes in our country. And of those with type 2 diabetes, at least about 3/4 of them have either also got hypertension or dyslipidemia or both. And we all link them very strongly with macrovascular complications of diabetes, heart attack, stroke, peripheral artery disease. And we have listed the numbers on the right: coronary artery disease, 11 million, peripheral artery disease, 4.5 million, strokes, another 4 million or so. But we also now understand that these also contribute to the microvascular complications, nephropathy, retinopathy, and even possibly neuropathy. So we do understand that there is significant interlinking of cardiovascular risk factors, and we do understand that there isn't a watertight compartment between microvascular complications and macrovascular complications in diabetes. And we also know, whatever may be the underlying mechanism, and we do have some understanding, the risk of coronary artery disease in type 2 diabetes in India is at least 2 to 4-fold higher than in those without diabetes. And not only does type 2 diabetes occur earlier in India, by at least a decade, even coronary artery disease tends to occur prematurely amongst Indians. And the mechanisms, some of the factors could be the higher triglycerides, the abnormal lipids, the small dense LDL particles, higher CRP, increased ectopic fat deposition. All these may be contributing to this abnormally early high risk as we see in Indians. And we all know mitochondria play a very critical role in cellular energetics. And we know mitochondria are there everywhere, be it in the heart or the lung or the brain or the liver or pancreas or kidneys, everywhere. And even in the blood vessels, in the endothelium.
you find mitochondria, and they have a very important role in maintaining the health of these organs or parts of organs. And we now understand that mitochondrial dysfunction is associated with metabolic inflexibility. I'll spend a minute on metabolic inflexibility. Normally, when we take a meal, it's primarily glucose that is metabolized by the mitochondria inside the cells, mostly glucose. Whereas in the fasted state, it is more of free fatty acids. So clearly there's a partitioning between fuels, glucose and free fatty acids, which generate ATP inside the cells. In various conditions, including especially chronic overnutrition, what you find is the mitochondria are in a state of indecision, what to use, glucose or free fatty acids. And many times what happens is that irrespective of feeding or fasting, it continues to try and metabolize a mixture of glucose and free fatty acids at the same time. So this is called metabolic inflexibility, where the mitochondria doesn't know how to partition between, how to switch between glucose and free fatty acids as the primary source of energy generation. That's, of course, the entire thing being simplified. And we were talking about endothelium. There also mitochondria have a primary role in preventing the progression of injury. And that is mainly through the generation of reactive oxygen species. In states of mitochondrial dysfunction, there is increased generation of reactive oxygen species. And there could be various ways, by use of antioxidants, by use of some metabolic modulators like resveratrol, maybe metformin to a certain extent, by calorie restriction. You could improve the mitochondrial functioning and thereby dampen or reduce the reactive oxygen species generation. Now, this ROS, reactive oxygen species excess, eventually damages cellular homeostasis. It leads to apoptosis of cells, loss of tissue function, and so on and so forth, and including endothelial dysfunction, which we all know endothelial dysfunction underlies most of the major cardiovascular disease conditions. So once again, we are back to the mitochondrion on the left side. So first of all, it's a cell, and then there is a glycolysis. So one is glucose coming into the cell, undergoing glycolysis, generating pyruvate. And on the other hand, you have fatty acids gaining entrance into the mitochondrial through fatty acyl-CoA transport, undergoing beta oxidation, and then generating acetyl-CoA. Similarly, glucose through pyruvate through the glycolytic cycle also generates acetyl-CoA, which then is metabolized through the tricarboxylic acid cycle. But eventually, all of them would generate hydrogen ion proton, which is then taken up by the mitochondrial inner membrane. And through the electron transport system, the ETC or electron transport chain, eventually generates the ATP, the energy unit of the cell, in an efficient manner. However, when you have dysfunctional mitochondria, you have compromised electron transport chain, you have insufficient nutrient sensing, you have incomplete substrate utilization, and the end result is oxidation. The beta oxidation of fatty acids is affected, reactive oxygen species are generated in excess, and as we have seen, gives rise to eventual dysfunction. So quickly, we try and see how mitochondrial dysfunction can be at the root of heart failure. So if you have dysfunctional mitochondrion as shown at the bottom, there is reduced ability of the mitochondria to generate and transfer energy. And this can affect left ventricular function, not only the systolic, the pumping function, which intuitively we may understand and associate with defective energy generation, but even the relaxation of the myocardium, which is to do with diastolic function, that is also affected because of defective energy transfer. And so we can have both diastolic and systolic heart failure, or in other words, both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, stemming from mitochondrial dysfunction. And as we were discussing, that energy production in the mitochondrion is primarily occurring at the inner membrane of the mitochondrion. And we don't need to go into the nitty-gritties, but suffice it to say that on the left side, you have a healthy mitochondrion where enough of ATP is generated, protons are accumulating, the gradient would drive ATP production. Whereas in the right-hand panel, we find a dysfunctional mitochondrion. There is increased electron leak, there is impaired endogenous scavenging, there is increased reactive oxygen species, and eventually there is reduced proton gradient and reduced ATP generation. So therefore, this would give rise to a disbalance between cardiac demand and supply. On the one hand, the energy supply in the form of ATP is less. And on the other hand, also there is damaging effect of increasing ROS for reactive oxygen species. And that brings us to this very interesting model, relatively recently proposed by Jeffrey Mechanic, the CMBCD, cardiometabolic based chronic diseases. We do understand the concept of primary drivers, maybe genetic, environmental, maybe behavioral, and then there are metabolic drivers. The metabolic drivers may be adiposity related, so ABCD, adiposity based chronic diseases, or it could be dysglycemia based, DBCD. And then we need to therefore identify the core pathological targets of these in order to provide a rational and effective treatment right from the very basic pathogenetic process down to the end results, for example, of heart failure. So if we start to think of any chronic disease, it doesn't happen overnight. It comes through stages. You need not be overwhelmed by this number of information in this slide, but we're trying to show how this concept of cardiometabolic based chronic disease, CMBCD, or dysglycemia based chronic disease, or adiposity based chronic disease could actually unify and give us the mechanism how the chronic cardiometabolic disorders can happen. So if we think of the adiposity-based condition, first of all, there is the basic risk stage where you have genetics, you have environmental factors, behavioral factors, which would then give rise to pre-disease in the form of increased amount of fat deposition, abdominal fat deposition, but not yet in the disease state proper. Only at a later stage that will progress to obesity, would give rise to abnormal biochemical test results, and only after that shall we get the cardiometabolic based chronic diseases, which would include diabetes, which would include hypertension, atherosclerosis, distributive MS, and so on. So through the process of abnormal fat deposition, not only in distribution, but also in amount, it can give rise to insulin resistance. Similarly, from genetics and environmental factors, behavioral factors, it can give rise to insulin resistance. This insulin resistance could directly give rise to macrovascular complications, or it could give rise to the same through prediabetes, diabetes, and then macrovascular complications. And similarly, you can have the metabolic syndrome traits, which could also directly give rise to cardiac dysfunction, cardiac heart failure, atrial fibrillation. All of these could happen even without obvious dysglycemia being there. But insulin resistance still plays a very important role. So this, I think, is sort of connected together through insulin resistance. And mitochondrial dysfunction and the metabolic inflexibility is also associated with ectopic lipid accumulation, which in turn would give rise to adverse cardiovascular events. So we do know, on the one hand, metabolic syndrome, where we have diabetes, or at least hyperglycemia, maybe dysglycemia. Even before that, there's insulin resistance, and there are abnormal lipids, not just high triglyceride, but low HDL, small dense LDL, apoprotein, ApoB containing lipoproteins being increased. And then there is ectopic lipid accumulation in the liver, in the pancreas, in the renal sinus, in the muscles themselves, the skeletal muscles themselves. And all of these could give rise to adverse cardiovascular disease risk burden, which could, on the one hand, give rise to increased coronary artery disease. It could also give rise to heart failure. It could give rise to atrial fibrillation, sudden death, and so on and so forth. What can we do in terms of pharmacological intervention? Well, there is the theoretical possibility that if we could set the mitochondria right, which could be done either by increasing the number of mitochondria or by improving their function, which would eventually reduce the amount of oxidative stress. This would definitely improve insulin sensitivity. This will improve not only glucose utilization, this will also improve lipid utilization, and would, it is expected, improve the function of skeletal muscle, adipose tissue, heart, and also the pancreas. So overall, if you correct the mitochondrial dysfunction, you actually improve the functioning of the electron transport chain, ETC, and that would give rise to a whole load of subsequent improvement. And here, through this busy slide, I'm trying to take us to the next generation therapeutics, exciting areas where we are trying to restore mitochondrial function to reduce cardiovascular disease burden. Now, normally, if you look at the heart, there is a balance between energy demand and energy supply. Now, energy demand will be to support systolic function of the heart, diastolic function of the heart, looking at the heart rate, and so on. And supply, normally in health, the largest proportion of the supply, which is shown in the orange bar, is through mitochondrial oxidative phosphorylation. The smaller, lighter orange bar represents energy generated from glycolysis. In heart failure, this is clearly deranged. Your demand is more and your supply is less because the mitochondria is dysfunctional. It cannot provide enough efficient energy. If you look at the current treatment paradigms, this is the bottom half of the same figure. On the left, we look at conventional treatment, beta blockers, ACE inhibitors, ARB, even possibly ARNI, SGLT2 inhibitors, mineralocorticoid receptor antagonists. They are primarily trying to reduce the energy demand. They are not primarily increasing the energy supply. So if we can restore the mitochondrial function, I think we shall be doing justice to the heart by improving the energy supply as well. So it may not be this or that, but possibly we should be looking at this plus that, mainly or namely existing treatment. They will not go out of vogue, but we will have additional important treatment to address the mitochondrial dysfunction and improve the energy supply. And this, once again, looks at in greater detail the electron transport chain efficiency, which is located on the inner mitochondrial membrane. So if you remember mitochondria, they're small organelles, and they have an outer membrane and they have an inner membrane with a little bit of space in between, which is the intermembranous space. And this inner membrane is then further thrown into folds known as the cristae in order to increase the surface area on which you can have all these complicated physiological functions going on in an efficient manner. And one of the most important functions occurring on the inner mitochondrial membrane is the electron transport chain functioning. Various complexes 1, 2, 3, 4, 5, which eventually tie in the beta oxidation or the tricarboxylic acid chain generated acetyl coenzyme A, and its further metabolism to give rise to NADH or FADH2, and this hydrogen or the proton is now being handled by the electron transport system to give rise to ATP. And for uncontrolled diabetes and also for heart failure, if we improve mitochondrial modulation, that will also help to improve diabetes and heart failure. And so while we have a number of therapeutic interventions currently, especially in the realm of type 2 diabetes, metformin and all, as far as cardiovascular disease risk reduction goes, these are not enough. These are good, but these are not good enough. So there is still an unmet medical need, and which is likely to be or expected to be, or we hope that mitochondrial modulation could restore metabolic inflexibility. And so before finally signing off, I would like to draw attention that existing treatment, including the newer ones like SGLT2 inhibitors and somewhat older ones, metformin, pioglitazone, imeglimin is a very new agent, probably available only in Japan, which is oxidative phosphorylation blocker. And then other antioxidants like resveratrol and the agents like trimetazidine, which are all in clinical use, probably also have some role in improving mitochondrial action. However, their effect is primarily not there, and we do not yet have robust randomized control studies, do not have enough level of evidence as to their efficacy in improving mitochondrial function, which we understand is critical abnormality, a basic abnormality that underlies a whole lot of cardiometabolic based chronic diseases, which is the cause of so much of morbidity and mortality across the globe, and even more so, as we have pointed out, in our country. So we are looking at the future. We are hoping to have the right sort of drugs in order to address our patients in a more logical, rational, and efficient manner. With these few words, I would like to end, and I'll be happy to take any questions. Thank you.
Wonderful presentation, sir. I think Dr. Hegde, you are muted, Professor Hegde. Rakesh, would you like to take over the moderation?
Yeah.
Yeah, Dr. Hegde, your comments.
Mitochondria in all eras, they are very fascinating organs. They have been rated with very high, producing a lot of ATP by TCA cycle and oxidative phosphorylation on which we live. But the carbohydrate intake that we take, actually diabetics is maybe because of the excessive carbohydrate, which is because of which the mitochondria becomes less effective because there are more reactive oxygen species produced with more of carbohydrate to oxidize, and that reactive oxygen species itself kills the or they destroys the DNA, mitochondrial DNA, and that is resulting in the decrease in the biogenesis of the mitochondria. I think these are one of the key things that are happening in the diabetes, and there can be very easy way of tackling the mitochondrial dysfunction, particularly by giving antioxidants which are operating in mitochondria more effectively, like alpha lipoic acid, coenzyme Q10. I think these may be much better suited to deal with mitochondrial dysfunction rather than, of course, you can always use the drugs that you want. But as a nutritional biochemist, I would say that the mitochondrial antioxidants may be very good way of managing mitochondrial dysfunction in diabetes.
Thank you, Dr. Hegde. You have actually brought in the role of these antioxidants, and even there's a question in the chat box about ubiquinone. So I would like to ask Dr. Subhankar Chaudhary, because he spoke about the modulation, mitochondrial modulation, which can potentially have the benefits, therapeutic benefits. And so how do you look at these agents? How do they stand in terms of the mitochondrial dysfunction that we are seeing in patients with cardiovascular disease and diabetes?
Right, thank you. So ubiquinone, otherwise known as coenzyme Q10, is the most abundant coenzyme Q that we have, is actually a part of the electron transport chain. So it has a very critical role in normal functioning of the mitochondrion. However, coenzyme Q10 or ubiquinone is not an approved drug in any formulary, but it is an important dietary supplement. And the point possibly is there is no doubt there is evidence that coenzyme Q10 dysfunction or deficiency can give rise to disease, but whether by giving coenzyme Q by mouth, you are able to correct that, you are able to make that coenzyme Q10 reach the correct place inside the mitochondria, possibly that part is not well understood. So yeah, theoretically it's got great potential, but in practice it's not yet used as a medicine widespread. It is widespread use nonetheless, but not a specific treatment.
Yeah, can I actually ask Dr. Tiny Nair about the role of these molecules in heart failure and in cardiovascular disease? How do they fare? I mean, what is the evidence? Is there any evidence for the benefit from using these molecules?
For example, coenzyme Q10, when it came with a big noise, and we thought that we have a cure for today of some of those cardiomyopathies, diabetic cardiomyopathies, for example, but we found that they are of clinically no significant use, like Dr. Shobha Chaudhary said. None of the trials have shown benefit with coenzyme Q10. So actually, we don't use them anymore, apart from some supplementation or placebo effect when we have nothing else to do, but they are not really useful. But what we are learning today is that a lot of drugs, including our ACE inhibitors, including SGLT inhibitors, the way they act and benefit in heart failure might be through altering the mitochondrial metabolism. I mean, that is a new learning today. And I'm sure that but these are drugs which have multiple action. They also improve the inflexibility of mitochondria. But today we are looking at newer drugs which would be probably coming in a couple of years' time, where we are directly targeting the mitochondrial inflexibility, what Dr. Shobha Chaudhary was talking about, and we are very excited about it.
And how do you foresee that this molecule would it have effects on the blood pressure, on the lipids, and on the diabetes management? Could you tell us? How you expect this molecule to be providing the clinical benefits? What sort of benefits do you expect from such a molecule?
Data is not yet out, so we can't discuss it. But generally, what it looks like, it is more for primary prevention. It has good effect on lipids. It tends to lower the blood pressure slightly, and it is glucose friendly. Now, despite the fact that the intensity of these lowerings are few, we know that few millimeters of lowering of blood pressure, a little bit of glucose friendliness, and a little bit of lowering of LDL might entirely change the mitochondrial inflexibility, and in the long run make a big change, right? We today know that 2 millimeters reduction in systolic blood pressure translates into about 10% reduction in CVD. So this adds up to something that is harmless, but at the same time translates into an enormous primary and secondary prevention.
Also, do you think that because all these different parameters are affected by the same molecule, the additive effect of this may be something which is very important, just like what we saw from the Steno study, that we looked at multifactorial approach having much greater benefit than a single factor playing. So probably this sort of molecule, if it has different effects, then probably all those will become will add up to a greater benefit. Dr. Subhankar, what is your views on this, sir?
Yes, I fully agree with you. And look at the benefits that we are already seen proven out of the SGLT2 inhibitors. They reduce glucose levels, but only by modest amount. They reduce blood pressure even by a very tiny amount. And they, of course, have other effects. But overall, they are such powerful agents today, we know, to protect the kidneys and also in heart failure. So here again, if you are looking for a primary mitochondrial modulator, of course, as Dr. Tiny Nair has said, we do not have the end results, phase 3 study results. Those are ongoing. We may not expect, if we raise our expectations that they will be strong antihypertensive agents, give rise to double-digit blood pressure lowering or HbA1c lowering by 1.5 or 2% points, we may not see those results, but still we may be able to observe very tangible positive effects in terms of overall cardiovascular disease risk modulation. That's the hope.
Thank you, sir.
Can I interrupt? Can I ask a question, sir?
Yeah, please.
What is the role of these modulators on retinopathy? You mentioned nephropathy. Any idea of its role in retinopathy?
Right.
Yes, sir, please.
Yeah, so at this point of time, we can't talk of the specifics because the results are not there. We can only talk of the expectations. Yes, even for the retinopathy, we would expect a salutary effect of these class of agents.
Yeah, again, the proof of the pudding is in eating it. So maybe we'll have to wait till we get the results, because we know of some molecules like the GLP-1 analogs, which tend to be very good for almost all the outcomes, for the renal outcomes, but for the for the eye, they have not shown that benefit. So I think we still need, we have a long way to go before we are able to exactly know about the effects of these molecules on the retinopathy also.
Can these be used in pre-diabetes as well?
Sorry, couldn't hear you.
Can this be used in pre-diabetes? As Dr. Tiny Nair was saying, that probably they are going to be more of a preventive, have a more of a preventive role rather than a therapeutic role in full-blown disease. So probably we see that there is going to be a good scope for these molecules in pre-diabetes segment. Dr. Subankar, your views on this one?
Patients with diabetes and cardiovascular risk, or can they be used for all diabetics?
They should be usable for all diabetics, and I suppose even for pre-diabetes. But again, we need to develop the evidence base for all that before we start talking of specific indication. Today is the era of evidence-based medicine. So we have to show the evidence that this is good for this. So we have to await that.
One last question, if I'm allowed, by Dr. Rakesh.
Yeah, please.
How did they hit upon this idea about mitochondrial dysfunction, and how did they come about it?
Dr. Subankar, sir.
Yeah, I mean, it's actually surprising that we didn't think about it so long. I mean, they are, as Professor Hegde already mentioned, they are such crucial elements of function within a cell, the energy, the powerhouse of the cell. They should be thought of. They should have been thought of even earlier, and so I think it's almost axiomatic that we should be thinking about it now. Now that's the understanding.
Yes, sir, your comments? So you're not audible. Dr. Hegde, you're not audible. Please unmute yourself.
So you have to unmute yourself.
So please unmute yourself.
Yeah, now I think we can hear you.
Comparison of mitochondria in diabetes versus mitochondria in cancer cell. Cancer cell suppresses the mitochondria so that it can become immortal, doesn't die. Apoptosis is suppressed. So the mitochondria is a very vital organ for generating ATP. At the same time, unfortunately, it produces a lot of reactive oxygen species. So unless you are able to neutralize that reactive oxygen species, mitochondria and the cell in which this is happening, that will be dysfunction. So mitochondria dysfunction, eventually apoptosis and death, and the whole thing will get jeopardized. Therefore, one of the important things that I think for any disease, all mitochondria, the metabolic syndrome that we are talking about, primary thing is to effectively neutralize the reactive oxygen species. Unfortunately, all our diet today is giving more of reactive oxygen species produced. Mitochondrial function is cleverly, the cancer cell is able to completely suppress. It depends only on the glycolytic cycle, anaerobic glycolytic cycle, so that it is not producing that much of reactive oxygen species, and therefore it becomes immortal. So this particular aspect has to be seen, and the antioxidants have to be given a lot of importance for any non-communicable disease. You have to first see to it that you don't produce so much of the free radicals. Your low-caloric diet would mean that you will produce less free radicals, and then you have to also see to it that you have got enough of green vegetables and other, so that you can neutralize the free radicals. So balancing the production of reactive oxygen species and the free radical is the key to health.
Thank you, sir. Thank you very much for the very valuable insights that you provided about the mitochondrial dysfunction. And do you have more time for some more questions?
Yes, there's one more question in the chat box. Can you please, this role of serotonin 1.
Serotonin 1. So, can I ask Dr. Shubhankar Chaudhary about this?
Well, yeah. So sirtuins are again very interesting proteins which are implicated in cellular metabolism, and they are highly conserved. They are quite ancient. They have evolved several millions of years back, and they're still preserved. So the structure is fairly conserved across different species and organisms. And they also are involved in mitochondrial function, of course, and they are related to energy balance, they're related to inflammation, apoptosis, a whole lot of areas. And they are noted to have a favorable positive effect. However, in the realm of therapy, and it's also been suggested maybe longevity, aging is also partly related to sirtuin defect, but it has not been proven or finally, we don't have a final answer on this. So these are important areas to work upon, but at this point of time, I don't think we have a therapeutic target, primary therapeutic target. Sirtuins have yet been exploited.
Thank you, sir. Can I have the views of Dr. Tiny Nair on this?
Nothing to it. Nothing. Absolutely.
Yeah. So I think there's another question. So since we are running late, we'll have to wind up this session. That's what the organizers are telling us. So I think we had a very exciting discussion about how mitochondrial dysfunction plays an important role in the continuum of adiposity-based chronic disease to dysglycemia-based chronic disease to going on to cardiometabolic-based chronic disease models, and how the mitochondrial dysfunction probably forms a unifying defect which contributes to all these problems. And we had a very good information that we got today about this, and also the fact that we are looking forward towards newer molecules which are probably going to have an influence on the mitochondrial function, with the hope that we'll have something which is going to be useful for our for managing these patients with the multiple cardiovascular problems. I think on that note we'll conclude the session today, and I thank the speakers, Dr. Shubhankar Chaudhary, Dr. Tiny Nair for the beautiful presentations they've done.
Thank you. It was an honor to be part of this program.
Thank you, sir.
Thank you for the very enlightening session. And we move on to our next session. Thank you, all the chairmen and the speakers. It was a wonderful session.
Thank you.
Thank you. So we move on to our next session on cardiovascular diabetology. And I have the pleasure of inviting the next session's chairperson, Dr. Ranjit Patel. Dr. Ranjit Patel is cardiologist in Pune. He is very famous cardiologist in Pune, and he is from BJ Medical College, Pune, DM Cardiology, AFMC, associated with Chellaram Hospital. He has various national and international publications to his credit. I welcome Dr. Ranjit Patel here for today's session. We have one more chairperson, Dr. Aniket Gadre here. Dr. Aniket Gadre is MD Medicine, DNB cardiologist and fellowship from UK, completed cardiology residency training from NM Varia Institute Cardiology. He completed his fellowship in international cardiology in United Kingdom from 2 years, where he was trained in transradial coronary interventions. Currently practicing as consultant interventional cardiologist in Dilanath Mangeshkar Hospital, NM Varia Institute of Cardiology, Joshi Hospital, Pune, and Chellaram Diabetes Hospital, Pune. I welcome both the chairpersons here for the session.
Can we have a slide of Dr. Om Lakhani?
Good evening. In this today's session, we have Dr. Om Lakhani, who is a physician and endocrinologist. He is winner of President DMB Gold Medal in Endocrinology and National winner of ESI UISA in 2016. Second winner of the AV Gandhi Award 2017. Winner of 2 gold medals during MD and 5 gold medals during his MBBS. So, esteemed academician, Dr. Lakhani, please.
Thank you for the kind words. Good evening, everyone, and thank you for joining us today. So, in this symposium, this is sponsored by AstraZeneca, and I'm going to talk about a very, very important aspect of management of diabetes, which is often relegated to sidelines in many situations. And we are going to talk about management of diabetic dyslipidemia in Indian patients. We are talking about the goals and how we can potentially save lives. So I'm Dr. Om J. Lakhani, and I thank the organizers, Dr. Unnikrishnan sir, and the International Diabetes Summit organizers for having me today for this talk. So, if you take a typical Indian diabetic patient, right, a lot of these patients have a multitude of complications which they can have, and all these complications can add up to increase the risk of developing cardiovascular disease. So, age is very important, right? And older the person gets, more they are exposed to poor metabolic health, leading to more likelihood of having diabetes-related complications. A male gender will have more diabetes complications. Somebody with a family history of acute ASCVD or a coronary event early in their life often again will be exposed to a higher risk of complications. Those living in urban areas because of multiple reasons can have higher risk. Central adiposity, hypertension, and obesity, all of these contribute towards apart from diabetes, contribute towards the higher cardiovascular risk in patients with type 2 diabetes. So a typical Indian phenotype with type 2 diabetes, there are a few things which are very typical to Indian patients. First and foremost, we tend to have higher insulin resistance. We tend to have a more central or abdominal adiposity and higher waist circumference, which makes us more susceptible to type 2 as well as more susceptible to the complications of type 2 diabetes. We have a very characteristic dyslipidemia pattern. We tend to have very high triglyceride, and we have seen this very commonly. We have low HDL and higher amount of small dense LDL particles, all of which are poor karma in terms of metabolic sense. And also we need to remember, we also have a lot of fatty liver. Right, so this type of combination in terms of diabetic dyslipidemia is also associated with non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, which can then progress to develop liver-related complications. But interestingly, all these things happen in Indian patients at a lower BMI. So we tend to have a lower BMI, yet we tend to have more complications compared to the Western counterparts. So again, all these things ultimately make us, the higher waist circumference, the lower adipokine level. Remember, something like adiponectin, which is protective, that, is lower in Indian patients. We have lower rate of glucose disposal, which makes it higher insulin resistance. We tend to have certain genetic factors, which again, all these things predispose us to higher diabetes-related complications. Again, one of the major challenges, of course, in India is poor glycemic control. Of course, we are almost at par across the world, and the recommended glycemic target is less than 7% by ADA. But India, as in the case with the rest of the world, the average HbA1c across the world is close to 8.5%, 8.6%. In India also, we are no better. And overall, slightly worse, in fact. Globally, 8.4% is the average HbA1c in known patients with diabetes, whereas in India, it's 8.6%. So, we need to, of course, not only work on the other factors, but very importantly, the core problem, diabetes itself, needs to be worked better. Now, as we said, the early and timely, I would say not early, rather, early or timely treatment and appropriate treatment is required for both the situations. So it is important for us to not only control the blood sugars to the target range of less than 7%, but also to control the dyslipidemia. In fact, management of diabetes is incomplete unless we take all the factors into consideration: the diabetes itself, the hypertension, the dyslipidemia, and other macrovascular potential complications, including obesity. Right? So we need to address all of these. Now, how do we fare in terms of overall dyslipidemia management in patients with diabetes? This is a study done by Dr. Shashank Joshi, and also another study by Dr. Amrish Mittal. So these are all larger studies where we have looked at the overall dyslipidemia prevalence and dyslipidemia pattern. So overall, there is 79% prevalence of dyslipidemia in patients with diabetes. Now, patients with statin, about 50%, only 50% are able to achieve the desired HbA1c, the desired LDL target. We'll see that in a few minutes. And patients, on statin and patients on statin plus other lipid lowering agent are doing slightly better. But again, it's not more than 54%. So overall, despite having a high prevalence of dyslipidemia, we are not doing very well as far as the LDL target is concerned. Now, in clinical practice, very often we see that there is subclinical dosing of statins. Often statins are given in doses which are subpar than recommended doses. And these doses are not titrated. So there is often a sense of, inertia in titrating the statin dose as well. This could be because of multiple reasons, perhaps, not very sure what the reason could be. To pinpoint to one reason could be patient-related factors or physician-related factors, but this is something which we commonly see in clinical practice. However, some statin is always better than no statin. And in that sense, we do always say that, at least the statin should be prescribed compared to not being prescribed at all. So there is a need for appropriate treatment for Indian diabetic dyslipidemia patients, and this area of this problem has to be sorted out. So we all discussed that in India, the problem is worse compared to others, and yet our treatment is probably not at par with what it should be. So we tend to have coronary vascular disease, cardiovascular disease a decade earlier compared to the Western Europeans. Again, 10% of myocardial infarctions in India occurs to Indians who are less than 40 years of age. And 52% of the deaths occurring under 70 years of age are contributed to cardiovascular disease. And of course, Interheart study has clearly proven that dyslipidemia is the strongest contributor to the risk of myocardial infarction in Indian patients. So, that this is the most important factor. And this is the factor which, unfortunately, is the most ignored as well. So we know, like I said, it's always some statin is always better than no statin. And if we reduce the LDL by 39 milligram per deciliter, we reduce the risk of major cardiovascular events by 21%. So this is the broad consensus. And for every 39 milligram per deciliter reduction in the LDL, our reduction of major cardiovascular event continues to be better. So in that sense, lower the LDL, the better. I think that is always a good idea. But having said that, we of course need to be, more prudent, and we need to be more, we need to find the right balance, and that's the most important thing. So at the end of the day, this important data needs to be kept in mind while prescribing the correct dose of statin. So what are the guidelines saying, and what do the guidelines suggest in terms of dyslipidemia management? So overall, a simple rule of thumb is that if the patient is not on statin therapy, you see the LDL at the beginning of treatment. And typically in diabetic patients with higher cardiovascular risk, we tend to try to target LDL reduction by more than 50%. So what would you begin with? So let's say you started with a the LDL target of LDL starting base value of 140 milligram per deciliter, you try to reduce that to less than 70 milligram per deciliter. So that should be the broad consensus in terms of LDL reduction in your diabetic patients. Of course, this is again consistent with the recommendations from various guidelines, including the guidelines of European Heart Journal, European Cardiovascular Association's guideline. Again, in very high risk people, so are very high risk people, diabetic patients with target organ damage which has already occurred, or at least 3 major risk factors, or early onset of diabetes or type 1. Nowadays we see early onset of type 2 also, so it's not just type 1, or long duration of diabetes. In all this situation, they are considered very high risk. High risk is a diabetic patient without target organ damage with diabetes duration more than 10 years. And then moderate risk patients and low risk patients are the other groups of patients. So diabetic patients generally, their risk determination often starts from moderate risk. All diabetic patients are to a lot of extent having moderate risk. There is no diabetic patient who is considered low risk. So this should be kept in mind. Again, very important factor. So if you have a patient with type 1 or type 2 diabetes, the patient automatically by default is in the moderate risk criteria. And then anything above that is what makes them worse. So again, what are the LDL targets at various risk parameters? So if you see again the ESC guidelines, low risk, you can keep it less than 116. But like I said, there is no type 2 diabetic or type 1 diabetic in low risk criteria, right? All of them start at moderate risk. So it should be less than 100 in younger group of patients. In high cardiovascular risk patients, the LDL target should be less than 70, and very high risk, it should be less than 50. Now, generally speaking, the best rule of thumb is to start by 50% from the baseline, and that's the easiest thing to follow in clinical practice also. Again, ACC guidelines also have very similar recommendations. I'm not going to go into too much detail. You can see the guidelines and it's available online as well. So you can check the guidelines to help you access. But the idea broadly is that you should be treating your diabetic patients at least as a moderate to high risk. And all these patients should have at least 50% reduction of their LDL from baseline. Sometimes, we need to, and if you can go more than 50%, you are doing better in terms of event rate reduction. So the lower you go, the better it is. However, having said that, at least I think a target of 50% is always reasonable to start with. Again, LDL more than 50% results in lower number needed to treat. So one of the biggest challenges of these trials which are done for statins is that these trials need to be done for a long time to really see meaningful outcomes. However, the other problem is that a lot of the times in the past trials, there was no consensus with regards to the LDL targets. And now, since we have, more perhaps meta-analysis and dissecting the available data, what we have seen is that the number needed to treat is just 26 when you try to target an LDL reduction of 50%. So let's say, if you are, let's say you have 100 patients, right? Or if, let's say you have 26 patients whom you are treated with a target of more than 50% LDL reduction, you'll prevent one coronary event, which is, I think, a good number. However, if the target you just LDL reduction is by 20%, the number needed to treat is 1:63. So the lower the LDL, the better NNT and the better outcomes you'll get in terms of preventing cardiovascular complications. Again, this is one of the banes of statin trials, and a lot of the times this also leads to a lot of myths in patients. Also, they feel that the statins are not protective enough. Perhaps the risk benefit does not apply to statins. Unfortunately, that is not true. In fact, statins, the number needed to treat are pretty robust. And if you try to reduce the LDL by 50%, you achieve reasonably good outcomes. Statins are recommended. Remember, hypertriglyceridemia. So a pattern of high triglyceride is very common in Indian diabetic patients. And also remember, as per the guidelines, the first line of therapy in patients who are having dyslipidemia with hypertriglyceridemia is also statins. So statins continue to remain as the first line therapy, even for hypertriglyceridemia. Any other therapy, like for example, a fenofibrate or a saroglitazar, may be an add-on therapy, right? So that is something you should keep in mind. This has been similar guidelines in 2016 as well as 2019. So in hypertriglyceridemia also, statins remain the primary therapy, and the other drug which you add can be a secondary therapy. So the first line therapy continues to be statin, and hence I think Indian diabetic patients, statin is again very, very important. Okay, so if you talk about intensification of statin before adding combination, I think this again should be kept in mind. And again, the guidelines also remember that is one of the challenge again. Statins, remember, often not intensified. There is a clinical inertia in intensification, and the guidelines suggest that before you add a combination therapy like a fenofibrate or ezetimibe or something, you perhaps need to consider intensification of the existing medication before considering. And I think the best possible dose in terms of the patient tolerance should be the one which should be given. This is the ADA guidelines for treatment of diabetic dyslipidemia. This is based on 2020 guideline. And remember, earlier there used to be a group of more than 70, but now they removed this. They just kept it less than 40 and more than 40. So in less than 40, the patient, like I said, most patients, there are patients with very low ASCVD risk. Again, these are the only patients where statin is not indicated, but otherwise, again, patients with either a prior history of ASCVD event, which is again, like I said, not, it's not uncommon for people to have myocardial infarction in less than 40 years of age. So if they have a prior ASCVD event or if they have high cardiovascular risk, again, high intensity statin should be used. And all diabetic patients more than 40 years of age should receive moderate intensity statin. All of them should receive. In some situations, however, if they have higher risk, they can be considered for high intensity statin. Now, to make this and make you help this understand better, what is high intensity and what is moderate intensity statin? High intensity statin is anything which lowers the
Yeah, so time is over.
Yeah. Thank you, Dr. Lakhani. That was excellent presentation. We move on to next, and then we'll discuss. So, can we have a slide of next speaker? Okay, so I welcome Dr. Varsha Jagtap. She is MD Medicine and DM Endocrinology. She is Associate Professor in Endocrine, BHRC Pune. She is attached to Dinanath Mangeshkar, KM Hospitals and various hospitals. She has her own Jagtap Clinic at Research Center in Pune. She has multiple national and international publications. She has received Palekar Prize and Prabhakar Ramdas Sadhare Prize for standing first in Indian medicine. So I welcome Dr. Jagtap. Over to you, Dr. Jagtap.
Thank you for the introduction. Can we have the pre-recorded? Yes.
So good evening to all of you. First of all, let me thank Dr. Unikrishnan sir and team Chellaram for giving me this opportunity, and Astra, the sponsors of this talk. So today I'm going to be speaking to you all about diabetes and sympathetic overactivity and how it can be a precursor, a silent precursor to coronary artery disease. So we all talk about, cardiovascular events and how we can actually prevent those events in type 2 diabetes. But I think we rarely talk about this sympathetic overdrive that is seen in these patients of our type 2 diabetes. So let me start by sharing this particular case capsule with you. So he is Vijay. He's like your any other type 2 diabetic patient recently diagnosed. Okay, and he is worried that he may also be suffering from cardiac problems, as the case was with his mother. So he lost his mother at a young age because the mother died from a cardiac ailment, and she also had diabetes. So he is worried that he'll be following the same lines as that of his mother. And when we look at his parameters, then we can see that his HbA1c is uncontrolled. It is 8.4. He is slightly overweight with a BMI of 24. His blood pressures are well controlled. But we can't say the same about his cholesterol. His LDL value is quite high, 165. And he does complain of intermittent chest pain on exertion. His EGFR is 70 and he has some microalbuminuria. So as you can see, he has got multiple risk factors for developing cardiovascular events. So we all know that we need to bring his HbA1c to as close to normal as possible. That is, say, even up to 6.5 without causing hypoglycemia. We all know that we need to intensify the statin therapy if he is on, and we need to address the microalbuminuria part. But having done all this, do we address the risk completely, or are there still some other risk factors left? Then yes, there are. And the other one of the risk factors which is left is this sympathetic nervous system activation. So we know that increased SNS can be seen in patients with diabetes, obesity due to insulin resistance. And besides insulin resistance, there are other causes. There are other comorbidities which can exist in our type 2 diabetic patients, like, say, for example, stress or depression. Some of them may be suffering from hypoglycemic episodes intermittently or sleep disorders. And all of this can lead to a SNS overdrive, which can then cause renal dysfunction as well as cardiac dysfunction. But is this sympathetic nervous system overdrive all bad? No. The answer is definitely a no, because we all know that we do require our SNS. So the sympathetic nervous system is required for us to maintain our heart rate, to maintain the cardiac output, to maintain the contractility of our heart, to maintain the volume of our blood. But if this SNS goes in overdrive, then it would lead to hypertension, then it would lead to endothelial dysfunction, platelet activation, hypertrophy, arrhythmogenicity, stiffening, coagulation, and all of these are nothing but predisposing factors for developing coronary artery disease. So this is what we need to be aware of. Now, when we talk about sympathetic activity, is it actually elevated in our patients with diabetes and hypertension, and what do the studies tell us? So this particular study has compared patients who were normotensives with diabetics, those who had only hypertension, and those who had both diabetes and hypertension. So as we all can guess, those patients who had normotension, they were the ones with the least sympathetic activity. Okay, and those who had both diabetes and hypertension, those were the ones with the most sympathetic overactivity. So obviously the presence of diabetes and hypertension together intensifies this whole problem. And if you look at the Indian figures, so how many of our Indian hypertensives have sympathetic overactivity? Then this particular study done from India, puts the figure somewhere at around 62%. So more than 62% of Indian hypertensives have sympathetic overactivity. And this overactivity is further elevated when hypertension is clubbed with diabetes or smoking or obesity or mental stress. Now, mental stress is something I think which we all undergo at one or the other time point in our lives. And when we look at the survey findings, then it's quite, I wouldn't call it surprising, but it is definitely revealing to know that 90% of our Indian population say that they are suffering from some or the other form of stress. Then 3 out of 4 feel that they are not ready to talk about it with the medical professionals about the stress. 50% Indians feel that they do not spend sufficient time for social activities, either with friends or for their hobbies, because of the work related stress. And 50% of them feel that the stress could also be because of financial worries, because they are worried about taking care of their family's financial needs. And COVID has compounded this problem further, where 40% professionals are experiencing increased stress or anxiety due to COVID-19. So we all know that insulin resistance causes hyperinsulinemia, which then drives the norepinephrine release. And this norepinephrine release can then activate the plasma renin activity, the PRA, which then acts on the angiotensin 2. And angiotensin 2 can cause glomerular problems, nephropathy. Okay. We also know that norepinephrine release can directly cause ventricular arrhythmias. It can cause cardiac and coronary artery damage and increased blood pressure, plus non-dipping at night, which is very classical. So sympathetic nervous system activation not just acts on one particular organ, but it is acting on different organs. So at the level of adrenals, as I've already told, it causes increased adrenaline release. At the levels of pancreas, it reduces the insulin release. Okay. At the level of liver, it produces glucose, so there's going to be more gluconeogenesis. At the level of the skeletal muscles, it is going to reduce the glucose uptake. At the level of fatty cells or the adipocytes, it is going to increase the substrate for gluconeogenesis by causing lipolysis. And at the level of kidney, it is going to activate the RAS system. So overall, whenever the sympathetic system goes on overdrive, we can see that all these things are what they are going to lead to is basically hyperglycemia. And how can we notice that, our patients are having this sympathetic overdrive? We all know that patients continue to experience these symptoms, like tremors in hands or fast speech or restlessness or inappropriate sweating. So these can be silent markers or silent symptoms of the sympathetic overdrive. But some of our patients may not have any of these symptoms, but the only sign that they have is tachycardia. So we should not neglect tachycardia. So elevated heart rate, as per this one particular study, elevated heart rate in those patients, particularly less than 55 years of age, it increased the cardiovascular, heart disease mortality by almost 2 times. So the relative risk of a patient dying from a cardiac problem is almost 2 times if the patient's heart rate is higher, more than 100, as compared to that of a person whose heart rate is lower. And another study has shown a similar finding. So here in this particular study, Beautiful Study is the name of the study. So there were 2 subgroup of patients. So one in whom the heart rate was more than 70 beats per minute, and the other subgroup where the heart rate was less than 70 beats per minute. So when these 2 groups were compared, that group of patients who had a higher heart rate, they had almost 34% increased risk of dying from a cardiovascular event, 53% increased risk of admission for heart failure, 46% increased risk for admission for myocardial infarction, and 38% increased risk for needing a coronary revascularization. So as you can see, all these p-values are significant, and they tell us that elevated heart rate is something that we should not neglect. So now we have decided that we want to treat the sympathetic overactivity, but how can we actually do it? So these are the European Society of Cardiology guidelines, which recommend that beta blockers should be used as a first line of treatment, specifically when there are certain clinical situations like angina, post-MI, heart failure, or for heart rate control. And this is a level 1A evidence. So beta blockers should not be shied away from, and we should use it in this subset of patients. So what do beta blockers do? So beta blockers are going to inhibit the sympathetic stimulation. So less sympathetic stimulation, less heart rate, less contractility, less need for myocardial oxygen, and hence the lesser incidence of developing a coronary artery disease. But does that actually manifest, or has it been seen in trials? Then the answer is yes. And one of the beta blockers that we commonly use and has shown these benefits is metoprolol. So what is the uniqueness of metoprolol? So metoprolol, we all know, is rapidly and completely absorbed throughout the GI tract, including the distal regions. The half-life of metoprolol is 3 to 4 hours, and hence we use extended release preparation. its excretion is mainly through the hepatic route. There is no accumulation of the drug in late stage CKD patients, and there are no active metabolites. So metoprolol reduces the sympathetic overactivity. There's an average reduction in the heart rate by around 14.5 beats per minute. So this was shown in the live study. So again, when metoprolol is compared with diuretics, then the risk of all-cause death and sudden cardiac death, both of them were less. All-cause death by 22% and risk reduction in sudden cardiac death by around 30%. So this was a study which had a follow-up period of up to more than 10 years. And this clearly showed that metoprolol reduces the risk of cardiovascular deaths. So now we have decided to use metoprolol. What kind of metoprolol? Does that actually matter? So yes, it does. And for many of the other extended release metoprolol, what is being used is a gel-based matrix system. And in this gel-based matrix system, what happens is that it may not be an ideal choice because more than 90% of the drug gets released in the first 10 hours. Okay, but in Celokin XL, you have the zero order kinetics and the MUPS system, that is multi-unit pellet system. And this MUPS zero order kinetics best formula, it gives the desired constant plasma concentration for 24 hours. So how does it do it? So here there are pellets which are, enclosed in these microcapsules, and you have got several hundreds of these micro pellets in the one tablet, which are covered by one of the polymeric membrane. Okay, so each of these micropellet acts as a diffusion cell, and it leads to a constant release of metoprolol succinate from the pellet during a 20-hour period. And absorption occurs during these at least 20 hours throughout the whole GI tract. So this unique system of MUPS, that is the multiple unit pellet system, it basically causes a slow release matrix tablet. It does not disintegrate, and the entire dose is consequently contained in one single unit during the GI transit. And this leads to basically an extended release formulation for Celokin XL. So Celokin XL, the zero order kinetics, why is it called as the zero order kinetics? Basically, it is not being affected by your meal or the gastric pH or because of the agitation. And throughout, it is able to maintain the 24-hour action. So Celokin XL has got some benefits, that is once a day administration, better compliance, therapeutic plasma concentration is smooth and uniform throughout the 24 hours. It has got a higher beta-1 selectivity and less side effects, higher degree of response among hypertensive patients, so therefore a better tolerability. And because of its specific outer membrane, which prevents its impact from food intake or pH or intestinal motility, so absorption is not interfered by any of these problems. So to summarize, sympathetic overactivity is elevated in patients with diabetes, obesity, smoking, and stress. And this elevated heart rate increases the mortality specifically in those patients of diabetes less than 55 years by almost 2 times. And metoprolol helps to reduce the sympathetic overactivity by reducing the heart rate by around 14.5 beats per minute. It reduces the incidence of sudden cardiac death by 30%, all-cause mortality by 22%. And metoprolol, with its unique MUPS zero-order kinetics prolonged release formulation, which is seen in Celokin XL, it provides a 24-hour duration of action, with its absorption being unaffected by food intake, pH of body fluids, and intestinal motility. Let me thank you all, and if there are any questions, we can discuss. Thank you.
I think we will take questions in the end. Thank you, Dr. Jagtap. That was excellent presentation, finished well in time. Next speaker is Dr. Rajiv Sethi. He is quite well-known figure in field of cardiology. He has done DMD medicine from Vijay Medical. He's a gold medalist in medicine from Pune University. He has done PM Card and DNP cardiology from Sion Hospital, Mumbai. He has done fellowship in a well-known institute in Melbourne. He has fellowship of Sky, FESC. He has presented many articles in national and international journals. So over to you, Dr. Sethi.
Thank you very much, Aniket and Ranjit. I will first try to share my screen. Yeah, are you able to see my slides?
Yes.
Good. So, good evening, friends. And at the outset, let me thank Dr. Unnikrishnan and the Chellaram Diabetes Hospital team for giving me this opportunity to present a very important topic of risk factor modification in patients with acute coronary syndrome, especially after 1 year of therapy. So in this talk, what I'm going to do, we are going to review the epidemiological evidence in patients with established coronary artery disease and look at their long-term risk of developing cardiovascular events. We are going to discuss the trials which have looked at prolonging DAPT, that is dual antiplatelet therapy, for more than 1 year in patients with acute coronary syndrome. And we are going to evaluate a new algorithm for selection of patients as to who are the patients who should be getting dual antiplatelet therapy beyond 1 year. So we all are aware that whenever a patient comes to us with an acute coronary syndrome, whether the patient undergoes an angioplasty, bypass surgery, or receives medical management, he receives dual antiplatelet therapy, that is the combination of aspirin and a P2Y12 inhibitor for 1 year. Especially if the patient has undergone an angioplasty, the preferred agents, P2Y12 inhibitors nowadays are ticagrelor and prasugrel over clopidogrel in patients with acute coronary syndrome. And all the guidelines are very clear that irrespective of what the patient receives as management protocol, post-acute coronary syndrome, he receives P2Y12 inhibitor along with aspirin for 1 year. But the question that we are going to talk about today is, does the residual risk reduce after 1 year? Where there is enough evidence, as we will see in subsequent slides, that the residual risk is still substantial at the end of 1 year, even after the patient has undergone angioplasty, even after the patient has undergone bypass surgery. As you can see in this slide from the REACH registry, that patients who had history of ischemic events, their risk of developing MACE was double at the end of 48 months. As you can see in the lower line, the residual risk in patients who had risk factors only was around 9%, and it was close to 18% in patients who had history of ischemic events. So even after the patient has undergone successful revascularization after an acute coronary syndrome, substantial residual risk still remains, as has been shown by the Apollo study, that in 1 in 5 patients who developed an acute MI, they further developed subsequent cardiac events of MI, stroke, or death within the next 3 years. And in the Pegasus trial with ticagrelor, if you look at the placebo arm, the residual risk at the end of 72 months was 15%. So even if we cardiologists may do a very good job at cardiac intervention, we must remember that there is still remains substantial residual risk, in which we need to continue with important secondary preventive measures. And amongst this is important antiplatelet drugs, and that is the content of the talk today. As also has been shown by the Improve It trial, that in patients with coronary artery disease, those who had polyvascular disease and diabetes, they had a very high risk of residual risk and very high risk of subsequent cardiac events at the end of 7 years. And both Aniket and Ranjit will agree with me that when we do complex angioplasties, complex meaning multiple stents in important locations like left main or proximal LAD, we are never comfortable in stopping dual antiplatelet therapy at the end of 1 year, because we know that late-stage thrombosis can still occur, and we want to reduce the subsequent cardiac event rate further, as has been shown by this trial, where patients who had complex angioplasty had a higher rate of stent thrombosis, myocardial infarction, and cardiac event rate. So there definitely is a case for continuing dual antiplatelet therapy beyond 1 year in patients with acute coronary syndrome. Now, what are the trials which have looked at prolonging dual antiplatelet therapy more than 1 year? One important study is the DAT study, which was with clopidogrel and prasugrel in patients post-angioplasty. And after 1 year of receiving dual antiplatelet therapy, patients were randomized to receive dual antiplatelet therapy versus aspirin alone. And at the end of 30 months, they found that when dual antiplatelet therapy was continued, there was a significant reduction in the ischemic endpoints. And one very important study is the Pegasus trial with ticagrelor, which gives us more robust evidence in that patients who had a prior MI 1 to 2 years prior to randomization and any one of the risk factors of diabetes, polyvascular disease, peripheral arterial disease, CKD, they were randomized to receive ticagrelor 60 milligram twice daily, 90 milligram twice daily, or aspirin alone. And they were followed up for 3 years. And as you can see here, there was a significant reduction in the primary endpoint of cardiovascular events at the end of 1 year. And if you break this down, significant reduction in cardiovascular death, MI, and stroke at the end of 1 year. So to summarize the findings of the Pegasus TIMI 54 study is that patients post-acute coronary syndrome, when they receive dual antiplatelet therapy, especially patients who have high ischemic risk and low bleeding risk, there is a significant reduction in the ischemic endpoints of recurrent MI, sudden cardiac death, and stroke, and with slightly higher increased risk of bleeding. And if you compare, if you see here, the risk of bleeding was slightly higher with ticagrelor, but the incidence of fatal or intracranial bleeding was almost similar. And this resulted in a net clinical benefit, which was better if the patient has a high ischemic risk. So the net clinical benefit was to the tune of 14% when patients had a high ischemic risk. This did not matter whether the patient had diabetes, whether the patient had CKD. The beneficial effect of ticagrelor was observed across the subset of patients with acute coronary syndrome without increasing the bleeding risk. So what does Pegasus tell us? So Pegasus tells us that if you have a patient who has acute coronary syndrome and he now receives dual antiplatelet therapy for 1 year, and if you need to decide beyond 1 year whether you need to continue with dual antiplatelet therapy, you look at the ischemic and bleeding risk. And if you have a high ischemic and a low bleeding risk, then you can safely continue with ticagrelor. Out of the 2 doses of ticagrelor, the results were almost similar with 60 and 90 milligram, with a lower bleeding risk with 60 milligram. So the protocol is at the end of 1 year, if you need to continue ticagrelor, it is better to switch over from 90 milligram to 60 milligram. And these are what the guidelines tell us. If you can see, the European and American guidelines are in sync with each other. On the right-hand side, patients who have undergone an angioplasty after 1 year, there is the class 2B indication to continue ticagrelor, which is preferred over prasugrel or clopidogrel. And on the left-hand side, patients who are medically managed, ticagrelor is preferred over clopidogrel at the end of 1 year. Now, if you break down the Pegasus TIMI 54 study, you will see that the risk factors which are very important in deciding the ischemic risk are presence of multivascular disease, diabetes, peripheral arterial disease, CKD, and patients having multiple MIs. And this has been shown in previous studies also, as was in the Sweetheart study, that more the number of risk factors, higher the incidence of recurrent cardiac events. So the Pegasus TIMI 54 study developed an algorithm of selection of patients as to who would benefit from prolonged DAPT beyond 1 year. They had a stepwise algorithm in which the first step was to exclude patients who were having a high bleeding risk. And these were patients who were either hospitalized for bleeding or who had anemia, a low baseline hemoglobin. And once you had ruled them out, then the second step was to assess the number of risk factors. And as I said, they looked at these 6 risk factors. So if you break down the Pegasus study, there were 19% of patients who were high bleeding risk who were excluded. And in the remaining percentage of patients with one risk factor, there was some benefit which was seen with ticagrelor, but it was not clinically significant. But if the patient had 2 or more risk factors, the beneficial effect of 60 milligram ticagrelor was found to be statistically significant. And this mortality benefit, as you can see here, there was a 34% reduction in cardiovascular death and a 24% reduction in all-cause mortality. So if you have a patient post 1 year of acute coronary syndrome and he has a low bleeding risk, you look at the number of risk factors. And if you have more than 2 risk factors, then you are safe to continue with ticagrelor 60 milligram, and the data we have is up to 3 years. So if we go through the protocol again, step 1 is to assess the bleeding risk and rule out patients with high bleeding risk, those who are having low hemoglobin and prior hospitalization for bleeding. And then you assess the ischemic risk, and patients with more than 2 risk factors, once they are started on ticagrelor 60 milligram twice daily, there is a significant reduction in cardiovascular events. And you can see here a 34% reduction in relative reduction in cardiovascular mortality and a 21% relative risk reduction in cardiovascular death, MI, or stroke. Now, this becomes very important because what options do we have post 1 year as far as antiplatelet therapy is concerned for secondary prevention? The choice is either clopidogrel, prasugrel, or ticagrelor. Now, results with clopidogrel were disappointing. There was the Capri trial and the Charisma trial, which did not show mortality benefit, but there was a high risk of bleeding. On the other hand, data with ticagrelor is very robust from the Pegasus TIMI 54 trial, where both the 60 and the 90 milligram doses were found to be equivalent with lower bleeding risk associated with the 60 milligram dose. So if at all we need to continue with dual antiplatelet therapy after 1 year, then the choice of P2Y12 inhibitor should be ticagrelor, and we should cut down the dose of ticagrelor from 90 milligram to 60 milligram. So for 1 year, irrespective of whether the patient undergoes medical management or angioplasty or bypass, he receives aspirin with ticagrelor 90 milligram twice daily, and post 1 year, patients with high ischemic and low bleeding risk receive aspirin along with 60 milligram of ticagrelor for up to 3 to 4 years. That is what the data tells us. And if we go through certain patient profiles, we have 3 patient profiles here. On the left-hand side, a 51-year-old lady has undergone angioplasty 1 year ago and also has diabetes. She had single vessel disease in which stent was implanted. The second patient is a 65-year-old male who has undergone an angioplasty 1 year ago, but he also had an MI 7 years ago, so he has multiple MIs. And the third patient has had an angioplasty 12 months ago, but also has multi-vessel disease and CKD. So do these 3 patients qualify to receive long-term anticoagulant, antiplatelet therapy with ticagrelor? We go through the 2-0 algorithm where we try to see whether they have low bleeding risk. Now, since these patients have been on dual antiplatelet therapy for 1 year and they have tolerated antiplatelet therapy for 1 year without a high risk of bleeding, means that they have a low bleeding risk, and they would then qualify to receive ticagrelor 60 milligrams. And if you count the number of risk factors, the first patient has 2 risk factors in diabetes and an angioplasty done 1 year ago. The second patient also has a history of multiple MIs along with an angioplasty 1 year ago, and the third patient has a previous angioplasty along with CKD and multi-vessel disease. So when you have more risk factors, it makes sense to continue with dual antiplatelet therapy for 1 year. So to summarize, it is a very simple patient selection algorithm in which patients with predictors of high bleeding risk are first excluded, and then patients with low bleeding risk will look at the number of risk factors. And if there are 2 or more risk factors, then ticagrelor 60 milligram along with aspirin has been found to reduce significantly the incidence of further ischemic events. Patients who are not at high bleeding risk and with at least 2 ischemic risk factors, there is a reduction in the cardiovascular death by 34%. There's a reduction in the primary endpoint by 21% and all-cause mortality by 25%. So this is in synchronization with the DAPT score that we commonly use in patients, especially after 1 year of angioplasty, which again looks as to who are the patients who should be receiving dual antiplatelet therapy beyond 1 year. So our job as an interventional cardiologist does not stop at intervention itself. We need to be more proactive and more aggressive, especially with the secondary preventive measures, especially with antiplatelet agents to continue P2Y12 inhibitors beyond 1 year, especially for those patients with high ischemic and low bleeding risk. So thank you very much. I think I'll stop here and then we can have a discussion. Thank you.
Beyond 1 year?
Sorry, I was not able to, you were on mute. Can you repeat the question, please?
Yeah, so the question is, when we consider prolonged DAPT beyond 1 year, do we need to consider any bleeding risk calculator like precise DAPT or ARC-HDR?
Yeah, see, now we need to, always assess the bleeding risk in an individual. Whenever we start a patient on dual antiplatelet therapy, we know that the bleeding risk increases, and we need to weigh the ischemic versus the bleeding risk. Now, how do we assess the bleeding risk? There are a number of scores which can be used to assess the bleeding risk. And as you pointed out, one of these scores is the precise DAPT score, which takes into consideration 5 variables. And if the score is more than 25, it tells us that the patient has a high bleeding risk and that we need to shorten the duration of DAPT. But the precise DAPT score is actually done once we start the patient of DAPT. So usually when we are about to commence the patient of DAPT, that is the time that we do the precise DAPT score. And at that time, the precise DAPT score is high. That means the bleeding risk is high. We know that we need to shorten the duration of DAPT. So in patients with acute coronary syndrome who have undergone angioplasty, we probably give dual antiplatelet therapy for a period of 6 to 9 months. And as you're aware, with the current implantation techniques and the current quality of stents that we use, it is possible to reduce the duration of DAPT to 6 to 8 months, especially with the patient with high bleeding risk. And even after a year, we should be very careful, because there is residual risk. But at the same time, we should see to it that the patient does not develop bleeding. So we need to reassess the bleeding risk at the end of 1 year, especially if we are going to continue with dual antiplatelet therapy for 1 year. So as all these scores are, they look at the various risk factors for bleeding, like if the patient has CKD, if the patient has anemia, if the patient has had history of bleeding, if the patient has intracranial hemorrhage, if the patient has a low platelet count, if the patient is on oral anticoagulant therapy, and so on. And that is the ARC score that you are talking about, where you look at multiple risk factors for bleeding. And if you find that the ischemic risk is not that high and the bleeding risk is higher, then probably the patient does not merit receiving dual antiplatelet therapy for more than 1 year.
There are a few questions. There are online questions.
So there is a question for Dr. Jatta. What about bisoprolol in sympathetic overactivity? And second question is, what is the maximum dose of metoprolol that can be given in diabetic patients?
Yes, thank you for the question. So I agree that my talk was biased towards metoprolol, but I don't mean to say that other beta blockers cannot be used. So other beta blockers bisoprolol can definitely be used. And when it comes to the dose of metoprolol, the books have given the maximum dose of metoprolol up to 450 also. But in practice, what we generally use is up to 200 milligrams, and what we have seen our patients tolerate. And for bisoprolol, it will be 5 to 10 milligrams that you can give the patients, even 2.5, depending upon your blood pressure and the heart rates.
This is my personal question to Dr. Varsha. Like we are starting patients on metaprolol. What will happen if we advise them to go some yoga or some pranayama therapy? Because government is nowadays more and more inclined towards the Ayush therapy and all that. So what is your experience?
I'm sorry, I couldn't hear the question. Is it for me?
For this sympathetic activity, yoga and pranayama advice to the patients.
Yes, definitely. So yoga and pranayama, as you're saying, would help in reducing the sympathetic overactivity. And when I have actually tried to read about it, and I wanted to find out about the different yogasana practices and as to which one would benefit the diabetic patients per se. For hypertension, I haven't read much, but if I were to speak about diabetes, then the twisting asanas are supposed to be good for that. For sympathetic overactivity, yes, more of breathing exercises and pranayamas, logically speaking, would do. But my knowledge or my reading about it as to what it actually and what studies exist for it, I haven't read that much, so I wouldn't be able to comment on that.
I think because of lack of time, we have to stop here. So I'll conclude this session. I want to thank Dr. Rajiv Sethi, Dr. Lakhani, and Dr. Varsha Jakta for their excellent presentation. And thank you, Dr. Ranjit Patil.
Thank you.
Thank our chairpersons for being here for a wonderful session on cardiology. We'll move on to our next session, keynote lectures. The chairperson, Dr. Makhdoom, I invite him for Syria Ideas 2020. You're welcome, Dr. Makhdoom. Dr. Makhdoom is endocrinologist, currently consultant endocrinologist at Jahangir Hospital, Birla Hospital, Pune Hospital Research Center. He is a teaching faculty for certificate program at Cleveland Clinic, PHFI. He is principal investigator in multinational clinical trials. Past assistant professor at Thyroid Center Institute of Nuclear Medicine and Allied Sciences in New Delhi. I request Dr. Makhdoom to introduce our first speaker, Dr. Juliana Chan from Hong Kong, to elaborate on diabetes and cancer, what is missing. Over to Dr. Makhdoom. Okay, I think Dr. Makhdoom has not joined. Okay. So we will start with the lecture of Dr. Juliana Chan. She has joined the meeting. Dr. Juliana Chan, you can start your lecture.
Okay, thank you.
I just introduced Dr. Juliana Chan. Can I have a CV slide, please?
Okay, so can you see the slide?
Yes, I can see.
Yes, ma'am. Yes, ma'am. We can see the slides.
Okay, thank you very much indeed. Okay, firstly, I would like to thank the organizing committee, particularly Dr. Uni, for inviting me to join the symposium. I'm going to talk about diabetes and cancer. What is the missing link in the next 20 minutes or so? These are my disclosures. Diabetes and cancer is not a new phenomenon. In fact, back in the sort of 1914, you could see that in this particular journal, already Professor Bally, acting on behalf of Mr. Jacob, brought one of a collection of Swiss statistics and requested that it should be analyzed with the object of measuring the relationship between the death rates of cancer and diabetes. It shows that actually with the modernization and also urbanization, we are seeing a lot more cardiovascular diseases and kidney diseases. And because of these competing causes of morbidity and also mortality, that cancer has been forgotten. Or has not been, deserving the sort of mention that I think is important. But I just want to remind the audience about this emerging risk factors collaboration studies, which is a prospective. It was a summary of 97 prospective cohorts with nearly 800,000 people with 125 million person years and have accrued about 123,000 deaths. And the point here is that people who have diabetes young, okay, they might lose as much as many as 6 years of life, and this might be even a greater loss of life in in areas with less well equipped healthcare system. But the important point is half of these deaths is actually due to cardiovascular diseases, and about 10 to 20% of that is actually due to cancer. And the remaining is so-called non-cancer and non-vascular deaths, and which are mainly due to kidney disease, liver disease, infections, etc. But in many parts of the world, actually, because of the increasing use of statin, blood pressure lowering drugs, we are really seeing a decline in terms of the cardiovascular diseases, and replacing that will be actually cancer. And it's something that we have to take note of as the burden of diabetes rise, together with the burden of aging, we are going to see more cancers. In this analysis, you could see that nearly all cancer, the risk of cancer, all sites cancer is actually increased in people with diabetes, particularly with liver cancer, pancreas cancer, ovarian and colorectal cancer. What is for a long time, people think that actually the risk of cancer in diabetes might be related to insulin resistance. We know that with hyperinsulinemia, there might be a decrease in terms of the binding protein for IGF-1. And as a result, we have increased free IGF-1 insulin growth factors, and this actually can increase cellular proliferation and reduce apoptosis. So a lot of people thought the increased cancer risk in people with diabetes may be related to obesity and insulin resistance. And indeed, in this, hyperinsulinemia is actually an important factor. So in this particular studies involving 38,000 Japanese adults, people who have the high C-peptide as an index of insulin resistance, the risk of colorectal cancer is increased, more so in men. The relationship is not so obvious in people, in women. However, in these very nice studies, these are Korean, and these are big studies where they have more than 1.2 million people, 10 years follow-up. And here you have 20,000 cancer deaths in men, 5,000 or 6,000 cancer deaths in women. And they stratify people into different grades of BMI. But within each category of BMI, whether it is a slim, obese, or very obese, you could see that there is actually a linear relationship between glucose and also the risk of cancer, suggesting that it's actually an independent relationship between cancer and hyperglycemia. Indeed, in our diabetes register set up in 1995, we have been tracking the outcomes of people with diabetes. And in fact, we were seeing that people with diabetes are not experiencing different kinds of causes of death. In fact, about 10 years ago, we already reported that 1 in 4 of our people with diabetes die with cancer, and 1 in 4 die with cardiovascular diseases. What's interesting is we found a near linear relationship between A1C and cancer risk, with every 1% increase of A1C from a threshold of 6.5%, there is actually an 18% increased risk of cancer, independent of all risk factors. This 18% is very interesting because 1% increase in A1C have also been associated with 18% increased risk of cardiovascular diseases, suggesting that the harm of hyperglycemia on organ damage might be very similar in different circumstances. In fact, there is actually a biological possibility for the relationship between diabetes and cancer. Some of you might have heard of this Warburg effect, reported back in 1956, and that is malignant cells, they actually utilize glycolysis rather than the Krebs cycles in order to yield ATP. These malignant cells are very energy demanding, and they actually have to use a lot of glucose in order to generate ATP, because if you just use glycolysis, the ATP production is a lot less than through the Krebs cycle. A lot of some people, particularly if they have a microacidic environment or if they have a ischemic environment, then they actually have the lactic acidosis accumulation, and that has also been shown to promote mutagenesis and also alteration of chromosome structures and also a DNA inhibition of DNA repair. And this acidosis in microenvironment have also been shown to promote invasion and metastasis of the cancer cells. And the hyperglycemia actually creates an environment which very much facilitates the Warburg effect and promote cancer cell proliferation. And this is a very nice review. Actually, the author summarized the effects of hyperglycemia on multiple pathways. It activates the advanced glycation end product pathways, the polyo pathway, giving rise to a lot of oxidative stress. Activates a lot of hemodynamic factors, particularly angiotensin II system, a lot of the growth factors, particularly the IGF-1, as well as some of the intracellular signals, such as the NF-kappa B. In fact, while this analysis is applicable to diabetic kidney disease, actually the ultimate is dysregulation of cell growth. Apart from the hyperglycemia, obesity associated with diabetes is also associated with a lot of inflammation. These are adipocytes, particularly the visceral adipocytes. They are actually metabolically very active cells, apart from just storing the excess triglyceride. These cells can secrete a lot of cytokines and adipokines, particularly the angiotensin system, which I'll come back later on. And these cytokines and also vasoactive hormones can promote a very abnormal microenvironment, which might actually favor cancer growth. So we have a situation where we have glucotoxicity, lipotoxicity, and inflammation, which increase a lot of oxidative stress and reactive oxidative species. And it's been shown that this reactive oxidative species can, activate a lot of the transcription factors to cause abnormal cell growth. Now, we always think about diabetes as a disorder of glucose metabolism and to some way lipid metabolism, but really we should be seeing diabetes as a disorder of energy metabolism, which involves not just glucose, lipid, but also protein. The fuel, the excess fuel is often used to actually can actually stimulate a lot of the protein synthesis. And some of you might remember the endoplasmic reticulum is a very important microorganism, a microorganelle within the cell. When we have a lot of protein being synthesized, there might be, this is the ER is where we actually fold the protein, but when there is too much protein trafficking, then there might be protein misfolding. And the ER is actually the place in the cell where they will start synthesizing some of the chaperone proteins, such as the BIP and the CHOP, and they will bind this misfolded protein in order not to clog up the cells. However, if this system is actually overwhelmed, then that will lead to cell death. Or if the cell death, if this pathway is actually dysregulated, and that will be lead to abnormal cell growth. So we were very interested because of these epidemiological findings. We were interested to find out whether hyperglycemia would indeed promote malignant cell growth. So in this serious experiment, we actually exposed these cancer cells, these are colorectal cancer cells, to a high glucose environment and also a normal glucose environment. And you could see that actually with increasing glucose environment exposure, then there is increased cellular growth. And these are actually MTT assay, and these are actually protein synthesis. So you could see that with actually prolonged exposure to hyperglycemia, these cancer cells growth. And these are actually not just in terms of the protein synthesis, but also the number of cells. And also this is another way of actually, it is not just a dose-dependent relationship, but also with increasing duration of exposure to hyperglycemia environment, there is also increased cell growth. So, but most importantly is after we return these cells that has been exposed to high glucose back to a normal glucose situation, the cells continue to proliferate. So once these cancer cells are exposed to a hyperglycemic environment, they appears to be programmed and they continue to grow, even they actually are returned to a normal glycemic environment, suggesting that there might be some epigenetic effect. And what we found is actually, without going into great detail, we found that this flexigarian, which is actually a endoplasmic reticulum activator, this is a prodrug which is used to treat cancer, because sometimes when some of these anti-cancer drugs, they actually utilize the endoplasmic reticulum in order to induce apoptosis to kill the cancer cells. But what we found is actually for these cancer cells, once they're exposed to high glucose, while there is actually increased cellular proliferation, what they found is actually the apoptotic pathway is actually reduced as compared to cells which are exposed normal glycemic. In other words, these cancer cells, once they're exposed to a high glucose environment, there is increased cellular proliferation. But when you even give them this anti-cancer treatment, they actually are not very effective, and because of reduced apoptosis. And we know that a lot of patients with diabetes, if they get cancer, they are very resistant to some of the anti-cancer treatment. So based on these mechanisms, we went on and asked the questions, if hyperglycemia is so important, so would hyperglycemic burden and obesity obesity interact in order to increase the risk of cancer? So here you could see that, when these people with high A1C over a period of time, this is the normal A1C, this glycemic burden, which is accumulate inside the patient's body and different organs, might have this adverse effects. And together with the lipotoxicity, we will actually have increased risk of liver cancer. So in the last year or so, we published three papers in this area, and we thought we would like to share with you. So using our diabetes register, we follow up these patients, 15,000 patients, and these patients had more than 10 years of disease duration. And we found that these patients developed liver cancer. So of these 15,000 patients, about 117 of them actually developed cancer. And they're more likely to be men. More of these patients have more than 8 years of diabetes. And you could see that actually these people who develop liver cancer are more likely to have central obesity. They're also more likely to have retinopathy. Interestingly, they're less likely to have cardiovascular disease. That might be the reason why they can survive longer. But because of the poor glycemic control, they actually are more likely to develop cancer. And here you could see that these people have high A1C. And if we look at the area under the curve, these patients with liver cancer have considerably higher median or mean area under the curve of A1C. And they're also more likely in the top tertile or rather quartile of the AUC for A1C. And what's interesting is these people are also more likely to have abnormal liver function test, okay? Because of the poor glycemic control, they're more likely to be on insulin. But what's interesting, and something that I'll go back later on, these patients were less likely to be on lipid-lowering drugs, which is statin, and also on RAS inhibitors, and this might have significance. And these patients obviously are about 5 times more likely to die compared to those who did not have liver cancer. And what's interesting, and then when we look, we actually observe a dose-dependent relationship, so that people who are in the top quintile of glycemic burden reflected by the AUC of A1C, they have nearly 2-fold increased risk of cancer, liver cancer. And we also found that if we look at the standard deviation of these glycemic burden, which is the AUC of A1C, you could see that the hazard ratio is much higher in patients with obesity compared to those without obesity. In other words, the relationship between the standard deviation of glycemic burden was only significant in those people with obesity. And these models have been fully adjusted for age, sex, disease duration, risk factors, complications, and drug usage. And so when we stratify these patients by the median of glycemic burden and also obesity, we found that actually patients who were obese and who have the above median of glycemic burden were most likely to develop liver cancer. And here, these people have 2.5-fold increased risk of liver cancer compared to those people who are lean and who do not have a high A1C burden over time. The other part, apart from glycemic burden, I think glycemic variabilities are also very important. And I think now with the CGM, we could really visualize a very good set of mechanisms where whatever you do, whatever you eat, glucose is actually maintained within a narrow range. It has been shown that short-term hyperglycemic variability as measured by continuous glucose monitoring, or using the variation of the A1C reflecting long-term glycemic variability, is associated with increased oxidative stress, endothelial dysfunction, increased inflammatory cytokines, as well as increased micro and macrovascular complications in both type 1 and type 2 diabetes. In this analysis, we actually asked the question whether glycemic variability would also interact with obesity to increase the risk of all sites cancer, as well as other causes of death. And here we actually define A1C variability using this HBS score. This is A1C variability score. This is indicated by the percentage of A1C values varying by 0.5%. Compared with the previous value. So for it's because this is a very long database, okay, this started in 1995. So we have observed these patients for nearly 20 years. So we have a lot of A1C measurement in these individuals. And essentially we count the number of A1C, which is actually 0.5% higher or variable, okay, different compared to the previous value. It could be higher, it could be lower. So for example, these 5 A1C values obviously have a lot of fluctuations. As compared to this one, they are actually quite stable. And so we divide people who have actually who have actually high HBS score and those who have low HBS score. So this is using a 50% cutoff. So about half of these patients have 50% of the A1C with variability, and these are the 50% of patients with low variability of A1C. And here you could see that patients with high glycemic variability had slightly longer disease duration. They're actually more likely to be active smoker. And these people are also more likely to have sensory neuropathy, retinopathy. And if you look at the glycemic variability, not only do they have a high A1C, they also have more A1C measurements, probably because of unstable glycemic control. And the mean A1C was also higher, and so is the standard deviation of A1C. These people also are more likely to have albuminuria and also abnormal LFT. And these people are also more likely to be on insulin and less likely to be on lipid-lowering drugs. And what you found is actually people with high glycemic variability, they nearly have twofold increased risk of death compared to those who have low glycemic variability. And when we actually use the spline analysis, you could see that there is a near linear relationship between cancer death, vascular death, and non-cancer and vascular death for people who have high HBS. The relationship is not obvious in those who have values below the median. So, and then when we actually stratify these patients into a high HBS, okay, high variability and obesity, you can compare to those people who are non-obese, who have very stable glycemic control. These people have about 1.5 to 1.7-fold increased risk of cancer death, vascular death, or non-cancer and non-vascular death, mainly due to renal disease. And again, this is actually adjusted for all confounders. So obese patients with fluctuating A1C have 1.3 to 1.4, 1.5 higher risk for death compared to lean patients with stable A1C. So the key question is, can cancer be prevented? Without going into great details, what we found is actually when you have hyperglycemia, dyslipidemia, and obesity, you have an extremely abnormal metabolic milieu with inflammation, oxidative stress. The insulin deficiency can actually cause some abnormality of this very important SREBP pathway, which is related to the HMG-CoA reductase pathway. And by blocking this pathway using statin, you can actually reduce some of the production of the abnormal cell signals, which is causing the cancer growth. By correcting the hyperglycemia, you can actually reduce the perturbation of this IGF-1 and also SREBP pathway. On the other hand, there is also abnormality of the AMP kinase pathway and also the angiotensin 2 pathway, which can be actually blocked by the metformin and also the ARB and also ACEI. So it's very interesting to note that in our databases, we found that patients who were actually not reaching target, they were not being treated with the statin and they were not protected by RAS inhibitors. Their risk of having cancer is nearly 4 times at that of the people who have good glycemic control who were protected by statin and RAS inhibitors. So ladies and gentlemen, I think in conclusion, continuing and quality care in order to reduce glycemic variability and glycemic burden, which of course also is dependent on self-management, control of all risk factors, not just the glucose, but also the lipid and also the blood pressure, together with the use of organ protective drugs such as the statin and RAS inhibitors, can reduce all-cause cardiovascular, cancer, non-cardiovascular, and non-cancer death. Thank you.
Thank you, Dr. Julia Nathan, for the very wonderful session, very informative. We will move on to our next session, and I request you to be here for the discussion, if possible. We will move on to our next lecture, Perioperative Diabetes Management. The lecture will be delivered by Dr. Vinaya Simha. Dr. Vinaya Simha, consultant endocrinologist in the Division of Endocrinology and Assistant Professor, Department of Internal Medicine at Mayo Clinic, Rochester, USC. He served on faculty at UT Southwestern and in Texas Tech University Health Science Center. He is both certified internal medicine endocrinology and clinical lipidology. His research interest includes lipidostrophy and the role of body fat distribution on glucose, lipid homeostasis, and have many publications in the field of lipodystrophy and leptin replacement therapy. He has taken keen interest in clinical lipidology and as an investigator in some early trials at PCSK9 inhibitors. I welcome Dr. Vinaya now, and we can start his lecture.
Hello again, I'm Dr. Vinay Simha from the Mayo Clinic, and this time I have the pleasure of discussing with you some key aspects about perioperative diabetes management. Now, this is such a long topic. We have whole seminars just on perioperative diabetes management. So I thought the most effective way of probably addressing this topic is just to answer a few questions, take a couple of minutes to answer each of these questions. And that should probably cover this to whatever most clinicians need to know. So these are the questions that I have in my mind when I approach this. Number one, should we be screening patients for diabetes preoperatively? Number two, when should we recommend postponing an elective surgical procedure because of poor diabetes control? Number three, how should we manage patients on oral hypoglycemics? And number four, how should we manage patients on insulin therapy? How should we manage patients on an insulin pump? And what is the optimal glycemic control in the post-op setting? So these are the questions that we will try to answer. Let's start with the first question. Should we be screening patients for diabetes preoperatively? Now, the answer is quite simple. To my mind, yes. And it's a big emphatic yes. And why? Mainly because there's a very high prevalence of undiagnosed diabetes in surgical patients. Now, these are all data from the United States, so I can't imagine it being any better in India or elsewhere. So, and I just picked a few studies. So, but the main reason why I picked these 3 years, so these were studies that looked at the prevalence of undiagnosed diabetes in patients who either were for elective cardiac surgery. So presumably they have had a lot of workup already. Like, this was in patients who had 7,000 patients who had CABG. And the other thing is many of them made sure that they had recently seen their PCP, their primary care physician. So these were all insured patients, seeing doctors, had a lot of medical tests. And yet you see that at the time of surgery, the incidence of undiagnosed diabetes or impaired fasting glucose was so high, 10%, 24%, 5%. So there's a lot of undiagnosed diabetes in these patients who come for surgery. But then you might ask, so what? Yeah, we are anyway picking it now. Here's the thing. these patients with undiagnosed diabetes have been found to have a higher morbidity and mortality, not just compared to those without diabetes, but also in comparison to those with known diabetes, which is why it is important to make this diagnosis of diabetes well before surgery. So I do think that we should be screening everybody. Now, however, of course, the ADA does not want to go so far to say this. So what they recommend is that, it's just, to my mind, it's just wordsmithing. So they say we should screen, not all, but then anybody. So there's such a wide net that is being cast. Okay, patients over 45, non-IFG, about even below 45, if BMI is about 25, or if they are high risk race, ethnicity. So, it's very hard that any of our patients would not really fall into any of these categories. So quite simply, I think it's best to screen most patients for diabetes. The next question, which is a little bit more challenging, is this. When should we recommend postponing an elective surgical procedure because of poor diabetes control? And we grapple with this all the time. To my mind, I think the clearest indication for stopping surgery or postponing surgery is if there is evidence of metabolic decompensation. Obviously, somebody has DKA or HHS, then there would be such a high perioperative mortality. You would first want to stabilize that before undergoing surgery. And maybe perhaps in the same line of thought, people with severe hyperglycemia who are likely to develop this metabolic decompensation, I threw in the number 300, but who knows? Yeah, something like that. So severe hyperglycemia, mainly because that would increase the risk of metabolic decompensation. Now, most people would agree with this, but then where there is a lot of debate is about the elevated A1C. What do we do in patients who are due for surgery and have an elevated A1C? Let's discuss a few things about preoperative A1C. Should we do it? Yes, it's recommended in everybody. And there are multiple studies which have shown that there is an increased risk of, you just name it, any complication, wound infection, pneumonia, UTI, sepsis, whatever, with a higher A1C. However, interestingly, there's no study which has examined the benefit of delaying surgery to improve glucose control. Like if we took people with whatever, A1C of 9, 10, and delayed surgery, then later on we did the surgery, does it mean that the outcomes are better? Well, there's no study which has clearly looked at it. But however, most people agree that it would be reasonable to postpone elective surgery if hemoglobin A1C is greater than 8%. Because if not for anything else, this would give us an opportunity to obtain specialist consultation. And it also actually makes the patient get more serious about their diabetes control. But again, I think it is a reasonable recommendation, but not necessary. And why do I say that it's not really necessary? Here's a very provocative study. So which actually, I think this is from Duke. So they compared A1C and perioperative glucose on the surgical outcome. So it was a retrospective analysis of over 400,000 surgeries. So these were the two things they looked at. What was the preoperative A1C? And then they looked at the perioperative glucose. That's the average 3-day post-op glucose. And the outcome was the 30-day post-op mortality, the excess 30-day post-op mortality. And what they found was it was only this perioperative glucose, that's the average 3-day post-op glucose, which predicted this excess 30-day post-op mortality, and not the preoperative A1C. So when adjusted for this perioperative glucose, the preoperative A1C really did not predict the outcome, meaning that the antecedent glucose control is less important than perioperative glucose control. So if you have a patient who comes with an A1C over 8%, it's not that he is doomed to have poor outcomes. So as long as we are good with this post-operative glucose management, it is still okay. They can still probably have surgery, but that's the key. The key is we should ensure that there is good perioperative glucose control. The next question is, how should we manage patients on oral hypoglycemics in the perioperative period? So the traditional approach is something like this. So basically what do? We just stop all diabetes pills and non-insulin injections, etc. when they are fasting and resume them when they are back on their diet. A special mention on metformin. So the ADA and most experts have, for some reason, recommended holding metformin the day before surgery as well, not just on the day of surgery. I think that that's not required. We just simply do this. I don't know why this fear of metformin and acute kidney insufficiency and lactic acidosis, I think, is overblown. In fact, here's again one more provocative study. This was from Cleveland Clinic. So again, it was not it was just a retrospective review of patients who were undergoing cardiac surgery. They looked at those who were, quote unquote, inadvertently taking metformin up to the day of surgery. And then they looked at these patients and they looked at their different post-operative outcomes to see if taking metformin the day before surgery adversely affected it. And if you look at the odds ratio, if anything, I mean, of course, clearly nothing is higher than 1, so it does not increase the risk. In fact, many of them were actually, it seemed that it was protective in the study. So like those who took metformin seem to have lesser risk of prolonged intubation, infection, overall morbidity, and so on. Okay? So much so that there have been follow-up studies trying to see whether giving metformin preoperatively will have beneficial outcomes. Those trials were negative too. But the point is that maybe there is no great beneficial effect, but clearly there is no adverse event. So it's probably not critical to be stopping metformin the day before surgery. There are, however, other medications which we absolutely must stop. And top amongst this list is the SGLT2 inhibitors. And this is something that everybody should be aware of because there are now at least a spate of case reports of patients developing diabetic ketoacidosis post-operatively when they were on SGLT2 inhibitors. So this is, I know most of you are aware of all the emerging data on how good these drugs are for CKD, for CHF, and so on. I do use them quite extensively in my practice. But then, however, the one thing that we need to be aware of is this euglycemic DKA. The drug somehow seems to increase glucagon levels, and in the right setting when there is also decreased insulin, which is what happens in these people because they will decrease their insulin, and there is going to be increased levels of other stress hormones, it seems to be a perfect setup for DKA. And we need to stop this at least 3 days before surgery. That's very important, and we should continue to monitor ketoacidosis after surgery and treat with insulin if required. They don't develop severe hyperglycemia, so that way it is very easy to miss DKA in these patients. The other drug category that is increasingly used these days is, of course, GLP-1 analogs. So all these the things like liraglutide and semaglutide and dulaglutide, I don't think they have any clear disadvantage, but then as you know, they can cause gastroparesis, and there is some concern that it might prolong post-op ileus. So perhaps the prudent thing to do would be to hold this on the week before surgery. DPP4 inhibitors, on the other hand, the gliptins, I think are quite safe, and I don't even think that it needs to be interrupted. So like people who have day surgery, and if they take their gliptin every day in the morning, it's probably quite okay to even take it. It doesn't cause hypoglycemia, no real GI adverse effect. So there's really no need to be interrupting this therapy. What about insulin therapy in the perioperative period? Let's do this with cases, okay? That makes it clearer. So here's somebody 58 years old with type 1 diabetes, long-standing. He's on a basal bolus MDI regimen. He takes Lantus 15 units and 4 to 6 units of aspart. Fairly decent glucose control. He also measures his glucoses, and this is his log book. So you can see these are his insulin doses, and these are the glucose levels. So the morning sugars 165, 190, 171, and in the hundreds later during the day as well. What should we do? Should we withhold his morning glargine and aspart on the day of surgery, withhold the aspart, administer half the usual dose of glargine or the full dose of glargine, or just continue his usual insulin? Unfortunately, I don't really have the option of knowing what you're thinking, but Typically, when I do this with a live audience, so many of them say administer half the usual dose of glargine, and we don't need to do that. So the actual answer is we just administer the usual dose of glargine. And that's because you can see this person, his fasting sugars are fine. So which means to say, if anything, they're a little high. So there's nothing wrong with his basal insulin. And we know that inappropriate basal insulin in type 1 diabetes will cause ketoacidosis. So we should never, ever withhold or inappropriately lower basal insulin in people with type 1 diabetes. So the bolus insulin, again, now if he's going to have surgery in the afternoon, we should not even stop the bolus insulin if he has breakfast in the morning. So that's important too. But then again, there are some instances when decreasing the basal insulin would be appropriate. And because many of our patients, unfortunately, are on too much basal insulin. And, they'll never tell you they're on too much. But here are some of the clues. So people who are having nocturnal or early morning hypoglycemia, or a steep overnight decline in blood sugars, or they just need to eat a bedtime snack just to avoid hypoglycemia. So they'll tell you, oh, if I don't eat anything at night, then I get hypoglycemia. That clearly means that they're getting too much basal insulin. Or also, if there's a very skewed basal bolus ratio, most people in type 1, it should be a 50-50 between the basal and bolus. So if you have somebody who takes like 25 units of Lantus and 2 or 3 units of Novolog with each meal, I already know that they probably are getting too much basal. So those are the instances when I would decrease. Otherwise, most other cases, it's best to continue their basal insulin. Contrast this with somebody who also has long-standing diabetes, type 1, and he's on a different regimen. He takes this intermediate acting insulin, NPH insulin. So he takes NPH 12 plus 4 regular in the morning and something similar in the evening. What would we do for him? This is the time when we should probably be giving him just half the dose of NPH and not the full dose. And why is that? So as opposed to, say, the Lantus, which is presumably, or at least which is traditionally considered to be a peakless insulin, we know that the intermediate acting insulins they do have a peak. And so they are, while we use them as kind of a basal insulin, they also provide some prandial coverage. And since they are not eating that day, we don't want that prandial coverage. So which is why a good option would be to cut the NPH in half in patients who are on an NPH-based insulin. Now, I know there are very few type 1s these days who are on NPH and regular, so I don't think this is too much of an issue. What is a bigger issue is in patients with type 2 diabetes. What do we do in preparation of surgery in patients with type 2 diabetes who are on insulin with or without other non-insulin therapies? Now, the non-insulin therapies, as we already talked about it, we usually hold them. What do we do with insulin therapy? Either the NPH or the basal insulin. NPH, yeah, we'll probably cut this in half, as we already said. What do we do with the long-acting basal insulin? So it's very, very common for patients with type 2 diabetes to also be on glargine, usually like a bedtime basal insulin, because it will help suppress their hepatic glucose output. Here, there is a little bit of data. Most of it suggests that we should be decreasing the dose by anywhere between 25 to 50%. Now, when I say data, it is not like a nice randomized controlled trial or anything. But then what we do have is, so most of these are actually retrospective analyses. So here, this is one of those studies where they looked at the percentage of people who landed up the next morning with a good glucose. That is, a good is like they should have a fasting glucose in the 100 to 180 range. So they looked at that in relation to how much insulin they took the previous night, their basal insulin. So clearly, if they took nothing, if it was 0%, then all of them were obviously high. And then if they took their usual dose, you will see a large number of them ended up with low. So the optimal dose appeared to be something like about 75%. So when they took about 75% of their usual dose, then they seemed to land here between this 100 to 180. Then there was one other prospective study. So this was, they compared 3 strategies. So the 3 strategies were everybody got an empiric 80% reduction in their basal dose, or they saw a physician who then did whatever physicians do in terms of analysis and gave them a directed dose, how much to take, or they all consulted some nomogram, an algorithm which adjusted their dose based on this table. And no matter what they did, there was no difference in their morning fasting plasma glucose. So a simple approach like an empiric 80% of their usual basal dose seems to be quite effective. And that's what the ADA recommends, that in people with type 2 diabetes who are on a basal insulin, we should decrease the previous evening's dose by about 80% or so. Now, the 80% is not set in stone. There are some who likely will require a higher dose reduction and some who will require more, but then a dose reduction seems appropriate. Now, the next question we have is, what about intraoperative glucose? What should we aim for? Okay, like for instance, this is somebody who's undergoing CABG, and we know that we have lots of data here that IV insulin is probably the best way to deal with their intraoperative glucose control. What should be the goal of this IV insulin infusion? It's more an aspirational question than a practical question. Should we aim for normoglycemia, 70 to 110? Or is it okay to let it drift a little higher, 110 to 180, 150 to 250, or something like that? Again, I don't know what you people are all thinking about, but of course, the actual answer is we don't really aim for normoglycemia. Okay? So, and why is that? If you look at the effect of intraoperative glucose on clinical events, so there is a clear data, multiple lines of evidence which show that people who have hyperglycemia have worse outcomes. In any outcome, look at any outcome, death, infection, neurologic, pulmonary, renal, cardiac. So people who have any of these events have higher blood sugars than those who don't. And it seems to be almost like the ones who have the least of these intraoperative events are those whose glucoses are 100 to 119 or less than 120. Once you increase that, then the incidence of all these complications keeps on increasing. So that is true. So having a higher glucose is clearly bad. But does that also mean that getting the glucose down is good? Well, one of my former colleagues, Dr. Gunjan Gandhi at Mayo Clinic, investigated this very elegantly. So he looked at patients who were undergoing cardiac surgery, and all of them had IV insulin infusion. So the one group, which was intensively treated, so they maintained their blood glucose here between this 70 to 110, basically around 100. So this is normoglycemia. Whereas in the conventional group, it was up to 180. So up to 180, they were okay, and then they would have this infusion started to maintain it between 100 to 180. And this was only intraoperatively. So following surgery, of course, everybody's blood sugars were maintained well. And lo and behold, what they found was that actually there was no benefit. So none of these, so there was no decreased incidence of any of these things. In fact, if anything, there seemed to be, for some reason, a higher incidence of stroke. So we don't think that trying to normalize blood sugars with intensive insulin is beneficial. That's not to say that IV insulin is bad. But we have lots of studies which clearly show that overall, yes, we should be doing insulin infusion perioperatively. That's probably better. It does decrease the pooled estimate of death, which is probably the most important thing. But we must be aware that there is an increased estimate of hypoglycemia. So there is the risk of hypoglycemia, but it might reduce mortality. And it is reasonable to target blood sugars below 180 rather than trying to normalize blood sugars. Now, the other question is, how do we manage patients on an insulin pump? We are increasingly seeing patients who come on pumps, and so there is like all kinds of pumps and sensors these days. So I have just taken somebody who came with this so-called closed loop hybrid pump, the Medtronic 670G insulin pump with the continuous glucose monitor. He's here for a minimally invasive parathyroidectomy. So this should be a fairly simple surgery. And these are all his rates, and he's doing reasonably well. So his glucose values are okay for a type 1. So what should we do? in such instances? So should we just stop the pump? It's a small surgery and then restart it after that, switch him to a sliding scale, or switch him to a basal bolus regimen as long as he's in the hospital? Or should we continue the pump on a manual mode and then get him back on this closed loop later on while patient uses finger sticks? Or he's doing very well, just don't rock the boat. Leave him on this sensor augmented insulin pump therapy. Well, anyway, the answer is, I think there is no reason to be interrupting insulin pump therapy. We can just leave him on the insulin pump, but there are some concerns about continuing to use the continuous glucose monitors or the sensors in the hospital. Now, about the pump, the utility of the pump itself. So we don't have very robust studies, but then a few small studies have actually looked at, like here, what they looked at was the percentage of patients who were able to maintain fairly good glucose control on the pump as opposed to IV insulin. Now, clearly, that's the best. We know that IV insulin is the gold standard. So compared to that, so you can see that being on a pump at the basal rate running is not too far behind. So that's still pretty good. So this is all blood sugar 70 to 179. So, and clearly putting them on a quote unquote sliding scale won't do that. So then you see there's a much higher incidence. Of course, you won't get hypoglycemia, true, but then you'll have a lot of people who have very high blood sugar. So that's not a good option. So continuing the basal rate with the pump is probably a good option. So continue the usual basal dose. We don't, of course, give boluses unless they eat. However, there are some instances where this might not be appropriate, like people who have a very long course of surgery, and if there is vascular compromise. So clearly, if they're going to be in shock or they're going to be on pressors, then the absorption of insulin is not going to be reliable. So their IV insulin is clearly better. And also, if they're going to have abdominal surgery where the pump insertion site is close to the operative field, then again, we should probably be switching them to IV insulin. A quick word on continuous glucose monitoring systems. So I'm not entirely sure what is your experience. So I think increasingly the people who are hospitalized also, I have been noticing that those on the closed loop do remarkably well. But unfortunately, they have not yet been quote unquote validated in the hospitalized setting. And clearly they have not been studied in the operative patients. So as of now, till these studies become available, it would probably be prudent to hold off using continuous glucose monitors till more data is available. Finally, what is the optimal glycemic control in the post-op setting? Again, unfortunately, we do not have any focused trials which have addressed this question, and there are no specific guidelines. But however, I think we can extrapolate from other studies which have looked at non-critically ill hospitalized patients, where we know that perhaps this 140 to 180 is the sweet number, that is fasting and before meal sugars less than 140, and any random blood glucose should be below 180. We know that beyond that, there is a higher risk for both fluid and electrolyte imbalances and for infection and wound healing and so on. So that should probably be our goal. Most important thing is we should make adequate arrangements at the time of discharge to ensure continued optimal diabetes management, because as we saw in the very beginning, is these post-op glucose management, which is critical for ensuring that there are no post-op surgical complications. So this is what we typically do at Mayo Clinic, and I think this would be a good practice. Everybody who undergoes surgery who has diabetes is given written printed instructions on exactly how to adjust their different medications. So like if this is your medication, the diabetes pills, and if your test procedure or surgery is before 10 a.m., what you should do, after 10 a.m., what you should do. Like if you're taking this insulin, you have to take how many doses, how many units of this. So giving people these written instructions on what to do before surgery and what to do after surgery, I think will ensure that there is good outcomes in people with diabetes following surgery. Thank you very much.
Thank you so much, Dr. Vinaya Simha, for excellent presentation and enlightening us on perioperative diabetes management. I would also like to thank Dr. Juliana Chan for discussing about diabetes and cancer. Now we have the valedictory function in the banqueting hall. So requesting all the faculty members and the chairpersons to join in the banqueting hall. So we conclude the session from the guest hall. See you in banqueting hall, valedictory function.
Ma'am, can I end the meeting?
Hello.
Yeah, can I end?